hope nobody has had broken hearts over Valentine's Day. But even if you did, I think we'll learn how to mend it today. So I'm Dr. Mansi, I'll be your host for today. And for the next 8 hours, we are going to indulge in some discussions, some debates, and don't worry, we'll also entertain you with some drama and laughter. And obviously, we have our signature mark, the Kahoot. We've gathered here to discuss one of the most time-sensitive cardiac emergencies that we see, which is the cardiac emergency. Now, from MI to cardiac arrest, no matter how trained we are, we all tend to fall under pressure. So, how to be very instinctive in that situation and how to decide whether to do this or that, because there's never a black and white decision that you have to make. So I hope that you all go home with some good knowledge and some skills so that you all are better at saving patients, right? So our goal is today to equip you with knowledge plus confidence so that you can go back and give the best patient care that you could. Having said that, I'm excited to bring Dr. Akshay on stage with the first Kahoot. Dr. Akshay, can I have you? Thank you.
Good morning. How are you? Didn't have breakfast? It doesn't seem so. It's too quiet. It's a very simple CME. You know most of the things, I assume. I was having a challenge while making the Kahoot quiz. So I've tried to pose the simplest questions, and I think you'll have fun. So I hope you have downloaded. Any issues with connecting? So you will need to log in. So try to keep your name same. Good. Opening batsman is opening in the Kahoot also. That's good. You can scan the code or you can type the code, whichever way is fine. Any challenges, please let me know. I think I mistakenly wanted to change your author. You might have to just log in again, once again. Ten people. I think I mistakenly cancelled it. I thought I would change your avatar. Yeah. Anyone pending? 14 people in. Please join in. Any challenges? We prefer everyone joining in. Is everyone joined in? Anyone having any issues? Anyone having any issues? 24. Shall we start? Okay. So, answer what you feel. Again, it's not an exam, it's a fun quiz. The quicker you answer, the more points you get. Clear? Obviously, I'll let you know the answer after that. Anyone else pending? 25 people are done. Pradeep? Issues? You want to log in Wi-Fi? You have it. Okay. Anyone pending? I think even Nitin sir, Kirti and Rupali should also join. At least the first Kahoot. You will have fun. Okay, let's start. Okay. You have 20 seconds to answer. Just checking if you guys are awake or no. Post-night people seem to be smiling. Still two people are sleeping. Wake up. Okay, next. Who's P? Okay, it's a poll. I want answers, please. Wow. Wow. $27. Who's okay? Chocolates, gadgets, reassurance. 8 people. Good. I believe in a 14 November. Good. One more poll. That spelling mistake is chahte ho, not chaste ho. I hope you guys understood the question. Prasad seems confused. Oh, okay. Not bad. 33% feel it's normal sinus rhythm handling cases like this. We'll see in the due course. I expect within 10 seconds everyone to answer this. Are you still thinking, my God, who are these 4 people? Your CME has ended. Bye. Have breakfast and go. Again, one more poll. Wow, that was quick. Someone is still trying to think. Wow. Time over money. Good. One more poll. Just trying to open your eyes. Who's that one person who's taking a bit extra time every question? Good. I like that one person. I am with you. Quiz. Who is not expected to be here today? I hope you have gone through the schedule. If not, I am helping you. Huh? Huh? My God. You do realize, na? Your login names and email IDs are with me. One more poll. I think you're going to love this. Don't worry, I won't send it to your departmental heads. I'm expecting KGF at least. Nah, such big liars. More than 40% are hum saath saath hai. I don't believe it. If you get this wrong, seriously, you're going home. No CME points, we won't return your money. Psychiatry. ये प्रसाद ही रहेगा जानबूझ के. Last poll. Don't check your phones and answer, please. Just answer. Sheriff, this is for you. The message, not the picture. Ooh, too many Apple users. Okay, so that's it from my side. Obviously, the podium will not make much sense since we had polls most of the time. Dr. H is third, KS is second, first is Devdas. Krish. So I hope that sets your tone for today. So, awake? Because you have the most important topic. If you're working in ER, this is the first topic you will have to tackle.
I hope you all are more awake now, but I think you all need some more awakening. So I'd like to call upon Dr. Murtaza Bagwala, the head of emergency in Safi Hospital. I hope you all have a power pack starting to this CME.
My presenter. Check, check. Okay. All right. See, this is what happens, in the department when you're not very organized sometimes. Have it? All right. But we are very organized, but it was just a technical glitch. All right. So my name is Dr. Murtaza. We'll be talking about, rather, I'll not be talking about. I want to listen from you all, okay? Because we'll be understanding what challenges we normally face during a resuscitation in the hospital or in the ER. All right. So I'll just brief up. It's a very easy but a very difficult topic because there are n number of problems. All right. And to pinpoint and pick up the most important ones and put it over here was a challenge for myself. But I just hope that I've done justice to this PPT. So what we'll do is we'll start with some statistics and another quiz. Okay. So if you see 32,000 people have died by a cardiac arrest globally in 2022. Sorry, in India in 2022. All right. We don't have a data for 23-24 yet, but I'm pretty sure many people must have died after the budget was announced. So that we shall know in the next CME. What are the top 2 causes of death in India in more than 5 years? Can you tell me? 2 causes. Guess. Trauma. That is Nitin sir's favorite baby. Myocardial infarction. Okay, ischemic heart disease. Okay, very good. What is the survival rate of out of hospital cardiac arrest globally? Any guesses? 50%? 5%. Okay. Anyone else? बोलो यार, wrong तो wrong कुछ नहीं, मुझे भी नहीं मालूम था. कितना है? 10%. 10%. Yes, it's a right answer. 10%. What is the survival rate of in-hospital cardiac arrest globally? 20. Anyone else? 60%. My God, which hospital? All right, 20% is the right answer. So if you go to see that the out of hospital to in hospital, okay, the ratio is only 10%. So in hospital also there are a lot of other challenges probably in which we are not able to achieve the desired outcome. So that is one thing which we have to understand. What are the bystander CPR rate in India by any chance? Anybody knows? Very close, sir. 0 is a very close answer, but anybody knows? 1.8 to 9%. So average around 5 to 6%. That is the bystander CPR rate in India. Okay, so that's how poor we are with CPR with out of hospital with laymen. So what does that mean? The whole thing, you know, what does this mean? What lag gayi hai? Okay, so you should know that. Now we'll just go with scene by scene. Okay, so with these scenes probably we'll understand better. Scene 1. A 65-year-old presents to the department with some burning in the chest. He attributes it to be a GRD which he has on and off. A junior doctor sees he's very busy, it's overcrowded. He just writes acidity hai, kuch nahi hai, pen 40 lo jao. Okay, very common. आप लोग सो रहे हो क्या? देख रहे तो जरा respond करो. Yes, very common. Very good. Okay. Now the senior comes. Okay, you are the senior most over there. You come and you see and you stop them. Why? Why? Yes, bolo. ACS, very good. Rule out करना है, ठीक है? और ECG करना है, very good. Okay. ACS can be an impending cause for a cardiac arrest. We never know. All right. कि भाई ने बोला करने का मतलब करने का, पूछने का नहीं, ऐसा है क्या? Okay. So this comes to the first challenge, that is early identification and diagnosis. Okay, that's the first challenge what we normally see in cardiac arrest, in managing cardiac arrest. The overcrowded ER itself becomes a place, there is so much of chaos going on. Okay, we don't have time to diagnose what is the problem. Okay, when we talk about cardiac arrest, we all know about 5H and 5Ts of cardiac arrest. All right, so we don't get enough time to evaluate those 5Hs and 5Ts. Okay, so these can lead to a cardiac arrest, but we don't have enough time so we can evaluate properly, and that in turn leads to a delayed diagnosis or delayed treatment. So it's a multifactorial approach, and this in turn leads to increased morbidity and mortality. All right. So the first very most important challenge is early identification and diagnosis. If you can diagnose the problem early in the time, okay, if there is no delay, you can definitely prevent a cardiac arrest from happening. Okay. So that is how we can prevent it. So that is one of the solutions for us. So potential solution for this challenge would be a proper triaging. Okay. Unfortunately, we don't have a very a robust triaging system. So we don't triage properly. We might put somebody as priority 1 who's P3. Okay, so a proper triaging will help us in identifying the correct patients. A hospital-based protocol should be there. All right. A protocol for ACS, for strokes, okay, for sepsis. So when we are following a charted protocol which is there in our hospital, at the end, as a resident, we start working at the spinal level. So we don't make any mistake as such. So we know these are the check boxes which has to be ticked. When it is done, definitely whatever the impending cause would be which can lead to a cardiac arrest is picked up early. So that is very important that we should have our own protocols in the hospital. Annual training of the staff involved in managing emergency patients is one of the very important things. All right. So this will be the first challenge and its solution. Then we come to the scene 2. Okay, now we have a single resident, okay, with 1 or 2 nursing staff in a very busy night shift, a crowded billing counter, okay, a lot of chaos happening over there, relatives are very, very agitated, a single multi-para monitor which has been shared among patients, okay, so we don't have much facilities over there, okay, and then suddenly an annoying relative comes and asks you a very stupid question. Okay, so that really puts you off. So that comes to our second challenge. Okay, any guesses what it could be? Any guesses? No? All right. So it is poor infrastructure and insufficient human resources. All right. Lack of emergency care specialists. Okay, so a lot of people who are working in the departments, a lot of the departments in many of the hospitals are not qualified enough for emergency, to take care of emergency as a whole. Inadequate training of nurses and doctors working in the ER. Okay, lack of specialized equipment and spaces. Like, say, there was an old age concept of casualty and now we are turning it to emergency. All right, everybody know that. Not all hospitals were pre-planned to have an emergency department. So now what is happening is the old casualties, the small rooms, okay, now they are getting transformed into an emergency department. So that is, we don't have a space to go out of the facade of the hospital. So somehow we are managing in that, and that is leading to a lack of space, okay. Few fortunate hospitals like Apollo, when they planned the hospital, they had planned emergency department. So they know, okay, we need to have a priority 1 area, a resuscitation bay, and if you have a well-spaced, well-equipped department, probably a lot of your challenges can be overcome there. And eventually leading to over-dependence on ICU. Because of this factor of lack of training, lack of specialists, okay, lack of space, we in turn have a lot of dependence on the ICU. So how to overcome this challenge? Okay. Posting of trained doctors and nurses in the ER, it's very important. All right. Each shift should have a senior and a junior combined together. So what we call is a piggyback technique, in which a senior and a junior are together. So if a junior is making a mistake, a senior is there to always correct it. That's very important. Okay. We should collaborate with the hospital management, okay, and we should have a resource allocation for our department, for a lot of various instruments or equipments, I would say. Our hospital is fortunate enough to have an auto CPR machine. Not many hospitals have them, but our hospital is very fortunate. And it gives excellent quality of CPR, okay? The adequate depth, the adequate rate, rhythm, everything is maintained. And this in terms gives us extra hands, because once we put an auto CPR machine, it will keep on going for hours and hours together. So my compressions are saved. Okay, I have one person extra in our teams, who can help us. So we can always invest in this kind of things. Unfortunately, my machine now is the AMC, the annual maintenance is not possible. The company has closed down. Okay, that is the biggest problem. So I'm just keeping fingers crossed that this machine should not burn out. Otherwise, we'll be again in trouble. And we should have a contingency plan. Okay, if at all a sister or a doctor calls in sick in the last moment, okay, we should have a contingency plan, how the resources can be reallocated, how the doctors or the nurses can be reallocated, so that, the show must go on. All right? So that solves the second solution, or second problem. That is just, I don't know, I found it cute, so I got it. Okay, scene 3. You are resuscitating a patient, okay, and a senior cardiologist walks in, okay, and he starts shouting, give atropine, give adrenaline. होता है? कभी हुआ है? हुआ है? रोज होता है, देखो, very good, okay. And वो लोग बोलते हैं, and we as like probably, the younger generation, we like, अरे यार इतना senior आदमी बोल रहा है, but atropine तो protocol में लिखा हुआ ही नहीं है, तो क्या देना है कि नहीं देना है? फिर क्या होता है? क्या होता है? What do you want to tell him? कुछ बोलते हो कि नहीं बोलते हो? मन होता है बोलने का? क्या होता है मन? है ना? होता है ना? ठीक है. So this is what happens. So now it comes to the third challenge. Okay, high pressure environment. Okay, ER being a very high pressure environment, if you see the annual burnout rate in 2025, okay, the top 5 specialties, okay, we have just started 2025, but yet we have already statistics out in which emergency medicine is 63% burnout. All right. So this is how bad it is. The reason is the stress of decision making can impair judgment while handling cardiac arrest. Long shifts can cause mental and physical exhaustion. Resuscitation in front of relatives. Okay. Have it happened to you all when you're resuscitating a patient and suddenly सामने 30 लोग खड़े हुए? Okay, so I remember an incident when I was doing a locum duty in an ICU. Okay, I was resuscitating a patient, a 90-year-old female. She arrested, and I was there. I was intubating at that time, and suddenly the son is standing in front of me. Okay, with a gun in his hand. Okay, I like, doctor, कुछ हुआ तो याद रखना. And my hands were literally shivering. I was not able to intubate because it was like this. Okay, so this is another high pressure environment which is created, which really takes a lot of toll on us. Okay, difficult in accessing IV lines, okay, in high pressure situation. Imagine your nurse is trying to get an IV, okay, and you are there and you are shouting, "Arey jaldi karna, arey jaldi dal, arey ye kar," and because of that pressure, she gives up. Okay, and breaking bad news, okay, after the resuscitation, that also takes a lot of emotional, baggage. Like, every time you go out and tell them this has happened, and it's an emotional drain for us. Okay, so this is the third challenge which we have, handling a high pressure situation. All right. What are the potential solutions for this? Very simple. Limit overtime shift. Okay, so we should always have that the shifts are so made that there is no much overtime layover. Okay, set standard protocols for tackling cardiac arrest, as we talked about it initially, that we should have hospitalized, hospital to hospital checklist or a protocol for various ailments. If we do that, probably it will make our work easier. Ensure teamwork, which is very important. Okay, without teamwork, we cannot do anything. Okay, dedicated emergency training programs in hospital, and very importantly, conduct mock drills. Okay, once you conduct mock drills, probably you can get a taste of that emergency, how the situation might be. And once you get a taste of it, probably when it really comes, you can relish it. Okay, organize departmental picnics. Sir, hota hai? Yes? 3 times a year. Very nice, very nice. All right, so departmental picnic is very important so that it creates a very nice bonding between the team, so that, while you are resuscitating the patient, you have that, what do you say, like, we can connect with people. Okay. ये नहीं कि मतलब वहाँ पे झगड़ा हो गया मतलब यहाँ पे एक दूसरे के ऊपर निकाले. It should not be other way around. But yes. And adequate security personnel in the hospital and in the ER itself. Okay, that's a very important thing. So if we can limit the crowd coming in, probably we can be more at peace while doing our job. Scene 4. Okay, you just received the ROSC. Okay, and you tell your junior, okay, please call the ICU and get the bed. Okay, because never to shift the patient. ICU is packed, they deny giving the bed. Okay, what will you tell your junior now? Happens to us commonly. I see a lot of heads shaking, so yes. What will you tell the junior now? What to do? Any guesses? Okay? विनम्रता से बात करो, ठीक है? Be polite. Okay, so that comes to our fourth challenge. Okay, that is communication and intra-department communication. Okay, so first of all, as we all do when we do a ACLS, BLS, we all talk about closed-loop communication. It's very important that with your team you should have a very a good communication, that to a closed-loop communication. The commands or the orders given should be specific. Okay, they should be to the point. एड्री दे दो मतलब क्या होता है, कितने एड्री देना है, ओके, कब देना है, कितना mg, कितना cc, like there has to be a specific order. एड्री दे देना, ये दे देना, वो दे देना. This is not how we work. Okay, so we should have a specific order. We should have a closed loop. So once the loop has to be closed, once you order, the sister or the paramedic has to come back to you with the order. Okay, 1 mg adrenaline given. Okay, so that makes the loop close. Okay, that is very important. Second, cordial relationship with everybody in the hospital, your ICU team, your cardiology, your neurology. You require everybody on board when you are dealing with a cardiac arrest. Okay, it is not, we can do the bit, what is important to prevent the brain dying, okay, prevent the heart dying, okay, but at the end of the day, we require the support of everybody. We require intensivist friend, we require a cardiology friend, we require a neurology friend, so we should have a cordial relationship with them, and please avoid an ego battle, okay, because once you start getting into ego battles with your colleagues in the hospital, it really makes your life difficult, and for the patient as well. All right, now, scene 5, ICU is full, okay, as they told that no bed, and the intensivist has asked you to manage the patient in the ER overnight. How do you feel now? चलता है, क्या करेंगे, करना पड़ेगा. Okay, we can't say no. All right. So that comes to the fifth challenge, that is post-resuscitation care. All right, this is a very important thing. We all know. We all do ACLS, BLS, we get certified, we know how to give CPR, how to shock the patient. We might get a very, we might get the ROSC. But after achieving ROSC, okay, how to maintain the patient is again a challenge, okay. And if we fail in this, probably we fail the entire resuscitation, okay. So adequate ventilation and oxygenation. Do we have ventilators in our department? Okay, if yes, do we know how to use the ventilators? Do we have the skills of intubating? Can we manage a difficult intubation? These are the things which we should know and we should ask ourselves. Hemodynamic optimization. Do we have an arterial BP monitoring system in the hospital or in the department? Okay, it's very important because we cannot just rely on NIBP after a resuscitation is done. So we need to get an exact BP with an arterial monitoring. Do we know how to put an arterial in the first place? Okay. Okay, you might know how to put an arterial line. You might have a facility in the department. Do you know how to set up a circuit? How many, show of hand, how many knows how to set up an arterial line circuit? Very good, Prasad knows. Wow, wonderful. I see most of the nurses raising their hand though. Okay, and 1 or 2 doctors who knows how to do it. So it's a very important thing because you might have a new nurse who does not know how to do it. All right, that is something which we should know. Cardiac stabilization, okay, we should have a 12D DCG, do we have it? If not, then do we have a defib? Do we have a cath lab in the hospital? Okay, so we can take the patient to the cath lab as required, okay, and do the things which is necessary for the patient. So, and can we thrombolyze the patient in the ER? Do we have the drug available in the pharmacy? These are the very, very small things, okay, but really makes a difference when you are dealing with a cardiac arrest. Glycemic control, therapeutic hypothermia. Do we know the protocol of doing a targeted temperature management? Okay, can we do it in our department? Do we have the facility to monitor the temperature? Okay, can we get the temperature down adequately? Can we rewarm the patient adequately? Okay, so it's very good to say theoretically, okay, we can do this, but can we actually do that on the ground? That is something which we need to know. Do we have point of care investigations? Like, of course, blood gas, it's very important, but we should have it in a department. Point of care imaging, okay, as simple as having a 2D echo machine. Okay, you can just do after you just received a ROSC, screen the heart. Okay, you will get to know what might be the reason. Is there an effusion, or if there is a pulmonary embolism? Just put the probe on the chest, and probably you might get the answer, and you can change the entire treatment plan. So these are very important factors which we need to know. These were few of the challenges which I felt, okay, in the given time. Probably if we talk about it and if we introspect on these challenges, we can do a difference, okay. And nevertheless, always remember that तुम बहुत मस्त काम करते हैं. All right? Thank you so much. Any questions from anybody, if permitted? सब लोग सो रहे थे. Very good.
Come on, guys, wake up. Do you all need resuscitation? Should we get on the ground? Come on, wake up, guys. I mean, none of you all are post shifts, right? Post night koi aaya hai idhar? 3 hands. But they look more alive than you all. So, I think it's an interactive session. We all want your involvement as well. You all are not just sitting here and sleeping. So, please. Any more questions?
I've asked my questions. You're not asking. Right? Thank you so much, guys. Thank you.
Dr. Mrityunjay, can we please call you on stage to felicitate Dr. Murtaza? Throw this side. So we all have always seen cardiac emergencies, right? But which of it is the most sensitive one where you know if you don't do anything, the patient might just crash on you? Any guesses? Aortic dissection comes to mind. So we have Dr. Mrityunjay Kalmat. He's our lead consultant cardiovascular thoracic surgery in Apollo. Let's hear from the expert himself how to manage aortic emergencies and how they present to the ED. Dr. Mrityunjay. Call him mic check.
Good morning. Can anybody figure out what is happening in this CT? Anybody? You can come and have a closer look if you want. This is small image. Yeah. Here, can you see something? Hello. Yeah. So if you can see carefully, yeah. See, keep it interactive so that there's no point eyes showing 20 slides and walking off. Because this is what you're going to deal with. Because sometimes patient come with a CT and will show you, Dr. Saab, Anybody? No. Okay. You can see this line here in the aorta. So what is it? That is a tear, that is a dissection. So aorta is separated into two halves. Okay. So what we are going to see today is aortic dissection. Probably the only emergency wherein you can't allow the sun to set and rise on the same patient in the hospital. You need to act immediately. You can't wait for the next sunrise or the sunset to act. Yeah. So acute dissection is a tear in the intima which allows the blood to go into the media and separate the layers of the aorta. So it is a time sensitive emergency. Once there is a tear, the blood starts going into the aorta and it starts propagating and it starts dissecting further till the lower limbs and the femoral arteries. So what happens in the path? There are coronary arteries, cerebral arteries, abdominal visceral arteries. So they all start getting disconnected from the true lumen. So it can create a havoc if you don't act in time. So what are the purpose of treating a dissection is early identification and control of your blood pressure and heart rate to prevent the propagation, so that you limit the disaster, limit the damage. Okay, so let's see how we can do that. So here you can see this is this is a tear. It's a tear generally that happens along the greater curvature at the sinotubular junction, because the hemodynamic impact of a aortic systole is on that region, and when that impinges, there is either a plaque rupture, or if there is a connective tissue, there is a tear in the intima that propagates like this. So creating, this is the true lumen, this is the false lumen. Now as the blood continues to increase in this, the false lumen enlarges and the true lumen starts getting compressed. Even if your visceral vessels are arising from the true lumen, since the true lumen is so badly compressed that you will have a visceral ischemia. So how does it all start? It can have three different variations. We call it as a acute aortic syndrome. So there can be a tear, intimal tear leading to dissection, which if you don't address in time can propagate and involve all the organs. Or it need not be an intimal tear. There can be a vasa vasorum, because of the hypertension, can rupture and create an intramural hematoma. And that intramural hematoma enlarges and can break to lead to a dissection also. I will show you an example, similar thing. So there can be a ulcerated plaque. So this, if you can identify the patient in this stage, probably you can prevent an event. Even this is a good stage. So these two are precursors, and if you can identify these two, probably you can avert this. So the predisposition is basically patients having significant atherosclerosis, hypertension, and connective tissue disorders like Ehlers-Danlos and Marfan syndromes. So you should be very careful when a syndromic patient comes to you with a chest pain. Your first diagnosis in that situation should be aortic dissection rather than your other DDs of a chest pain. So what are the triggers? So any stress, increasing your blood pressure, trauma, a blunt trauma preferably most often, and pregnancy and drug abuse. Very rare causes, but yes, they do. So it's a rare disease, but has a very high mortality, and time is of essence. It is said that every hour the risk of rupture increases by 2%. by the end of a day, if you allow a dissection to stay for a day, you are reducing his chances of survival by more than 50%. Huh? So you need to act immediately, diagnose immediately, and has to operate irrespective of the time immediately. So what are the types of dissections, and how do you decide when to act and when not to act? Huh? So there are two types of classification. One is an anatomical classification, one is a physiological classification or a functional classification, I would say. Huh? So DeBakey is an anatomical classification. It tells you the entire aorta is involved. Type 2 is only the ascending aorta involved. Type 3 is only descending aorta. But how does it matter? Which part is involved? Will it help me in deciding what surgery should I do? No. When to do surgery, when not to do surgery is the decision that you need to take in an emergency. Huh? Otherwise, rest all types of dissections, the management remains the same: control hypertension, control heart rate, and allays anxiety, and manage the any other issues. When to operate, when not to operate is decided by your Stanford classification. Whenever there is a tear in the ascending part of the aorta, the entry or the tear in the ascending aorta, that needs to be fixed. Because what is happening here, when there is a dissection, entire blood is going into the false lumen. So your true lumen is getting compromised, your visceral ischemia is happening. So what you need to do, you need to ensure you give the entire blood into the true lumen and allow for the false lumen to collapse and ensure organ perfusion. So, in type A, the tear is here. So the higher chances of blood predominantly entering the false lumen. So that is where you need to fix this. And also one more reason is you have your coronaries, you have your aortic wall, and you have your arch vessels. Huh? So these three are at risk. Huh? A sudden dissection can trigger without chest pain. Patient can have a severe AR and come to you with a breathlessness. Huh? Or if the dissection goes into the coronary ostia, he can come to you with a MI. He might classically mimic like a MI. But you need to identify. Huh? A classical tear, anybody can detect. But somebody comes to you with the classical symptoms of a MI, you still can't rule out a dissection. Huh? Somebody coming with breathlessness, he need not have anything else, just the aortic valve is prolapsing because of the dissection entering into the aortic root. Huh? Or somebody can come to you with a stroke. This is involved. Huh? So our aim is to fix this flap and ensure the true lumen is perfused. So that is why we call Stanford A and B, because this Stanford A treatment is surgery. Stanford B, you can manage it conservatively, and can be subsequently, if the size increases, you can manage it endovascularly also. So we've already discussed the common presentation is your chest pain, but they can present with syncope and dyspnea. Syncope or any symptom suggestive of a CVA. Okay? And they can, and if it is a late presentation, then they can present to you with abdominal visceral pain, acute renal shutdown, and even acute limb ischemia. The first case that we did in this hospital after I joined was her main presentation was acute limb ischemia. She came to us with the acute limb ischemia of the right leg. So the CT which I showed you initially, I don't think anybody appreciated that. The dissection was extending into the right common iliac vessel, so right lower limb ischemia. She presented classically with the right lower limb ischemia. So how do you, what signs you can elicit? There will be pulse deficit if there is a dissection on one side. Huh? Asymmetry in the blood pressure in the limbs. New onset murmurs because of the acute AR that it can create. Huh? and if it ruptures, it can have a pericardial tamponade as well. So, what are your differential diagnoses when somebody comes to you with a chest pain? Common, somebody comes to you with a chest pain, irrespective whether radiating back or whatever. MI, next, pulmonary embolism, doesn't come to you with a pain. He will complain of breathlessness. Dissection. See, 3 common things that you need to consider when somebody complains of acute onset chest pain. That is pulmonary embolism, MI, and dissection. But dissection can also present like MI, which I have already told you. So your first, how do you evaluate? You can keep this. You should suspect aortic dissection when there is a family history, or if the patient is a syndromic patient like Marfan's disease or something, and if there is a sudden onset pain which is radiating to back and it's a classical ripping kind of a pain, and there is pulse deficit and BP discrepancy. So if these 3, this is the score. If it is more than, anything 2 to 3 is suggestive of a aortic dissection. So what you do an ECG to rule out an ongoing myocardial ischemia. So if that is not there, then you think of the other 2 things. So ECG will also rule out one more cause, that is pulmonary embolism. Can anybody tell what are the things that you see in a ECG in a pulmonary embolism? Loudly. One person can stand up and tell for the benefit of the others. Anybody? Take a mic and tell no. See, you learn more with participation.
So sinus tachycardia will be the S1 Q3 T3. S1 Q3.
S1
Q3 T3.
T3. So what does it mean?
In the lead one there will be S5. In the lead one.
Pardon me? Tell me.
In lead one there will be S waves. Lead 3 Q waves. T waves in T wave inversion.
T inversion in 3 way, lead 3.
Yes.
So what does it indicate?
P pulmonary embolism.
It basically indicates your right ventricular strain pattern. So when you have a severe aortic stenosis, what do you see? Left ventricular strain pattern. This is more of a right ventricular strain pattern and tachycardia. So, see, and then ECG has almost given you a clear idea that it could be something else. There are no signs of pulmonary embolism, there is no ongoing ischemia. So what else? Then you do quickly, if there is an echo, do an echo. Echo will tell you if there is any acute aortic regurgitation or any root dilatation or something like this you might see. See this? What is this? This is the aortic valve, this is the aorta. And see, there is so many flaps inside, dangling. This is one of our patients that we operated. This was the echo done, I think, in the ER only. You see that? I will show you how this echo patient looks on the table. I will show you the surgical video as well. So, oh, sorry, I think we skipped one. So then, if your aortic root appears on the echo you can't see the entire aorta and the arch. So what you see is the aortic root only. And probably there may not be any dissection or aorta might be normal. Will that rule out a dissection? No. You still have a high suspicion based on that score, then you go ahead with a CT. So you do a CT, CT will show you something like this. This is dark color contrast is the true lumen, this is the false lumen. So here, this is ascending aorta, this is descending aorta. So this is true lumen, this is false lumen. So So then what do you need to do? We've diagnosed aortic dissection. What you need to do? There is a high dP by dt. What do you understand by dP by dt? A homework for you all. You can go up and read up. So the whole philosophy of medical management of aortic dissection in the ER is about controlling your dP by dt. Rate of rise of pressure. So you need to control the blood pressure. You need to control the blood pressure and you need to control the heart rate, because your aim is to prevent the propagation of the dissection and give enough time to be shifted and operated upon. So what you need to do, you need to use beta blockers and vasodilators to keep the pressure and the heart rate under control. So what is your preferred beta blocker or vasodilator in the ER? Yeah, I would say, people give oral, when you don't have an infusion pump and an infusion facility, if you are in a peripheral hospital or a periphery, probably you can give a tablet of labetalol or even a metoprolol would be good enough. That will take care of your heart rate and blood pressure. But if you are in the ER and if you have an infusion pump, it is best controlled with the esmolol and NTG infusion. Okay. So once you've diagnosed, while you are doing this, simultaneously you need to ask one of your colleagues to arrange for a blood and prepare the OT for surgery and involve the surgeon and the surgical team. Because time is of essence. While you are doing this, you should not waste your time on the other things. So how do you see? We've already run through this algorithm. Only thing is here once aortic dissection is diagnosed, Stanford A, straight away open surgery. What if it is a Stanford B? If the dissection is, tear is in the descending aorta, what you need to do? If it is not causing any organ perfusion deficits and if the size is less than 6 centimeters, no need to do anything. Just control your blood pressure and heart rate and monitor with a serial CT scans. If there is an organ perfusion deficit, or if the size is progressively increasing more than 5 millimeter per year, or if there is a more than 6 centimeter aneurysm, then you need to address with either endovascular or surgically. So coming to the type A dissection, what we do, if the aortic valve is normal, then we simply replace the ascending aorta. Distal extent depends upon what is the extent of the dissection, whether it is involving the cerebral vessels, then we need to reconstruct them also and do an arch repair. If it is going into the DTA, then the frozen elephant trunk options comes. That I will deal with that later. So assuming that it is involved the aortic root and the ascending aorta and the valve is spared. So then what you can do, first let us deal with this. If the aortic valve is also leaking and the ascending aorta dissection is there, then you can do what is this procedure called as a Bental procedure, aortic root and ascending aorta replacement with a coronary button reimplantation. Can be done with a mechanical valve conduit or a bioprosthetic valve conduit. But if your aortic valve is functional, normal, so then there are different aortic, that was aortic root replacement. This is aortic root remodeling, wherein we don't replace the valve, we preserve the valve. These are valve sparing techniques. So David's procedure and a Jakob's procedure. Jakob, what he does is he makes a U-shaped cuts into the graft and puts it into the sinuses. Because sinus is also a disease segment, so he believes that replacing that part of the aorta is necessary, otherwise it will become aneurysmal later. What David does is he puts a sleeve around the aortic valve and fixes that sleeve beneath the aortic valve in the LVOT. So anyway, that is for the surgeons to worry about. Yes, if it is involved the arch and the DTA, then what you need to do, then see, this is ascending aorta replacement. You are not addressing the valve here. Here, this is ascending aorta and the hemi-arch here. This is total arch. This is total arch. with debranching here, and this is elephant trunk. And now we have two new devices. One is by Thoraflex, Terimo is Thoraflex hybrid. So this has got a arch graft with a cerebral vessel branches and a stent graft for the descending aorta. So this there is one more company that manufactures, that is a Jotec. So this can be used for the hybrid. So type B we've already discussed. So I'll just run through quickly a few of the patients that we did. So this is the type A dissection. This is the first image that I shown you, the CT image. This is the patient, is a lady, smoker, and presented to us with classical acute limb ischemia. On evaluation, the dissection had involved the right innominate and the entire aorta up to the right iliac artery. So the same thing I am describing, so let's not waste time. Yeah, so this is next dissection that we did. So you saw that echo flaps in the echo. You can see those flaps here. See this? See these flaps? This is the adventitia, this is the intima and media, and this is the false lumen that this sucker. Yeah, see these are the flaps. See those? The sucker is in the true lumen. And this is a cardioplegia going, the antegrade cardioplegia we are giving. So that was about acute dissections. There can be chronic dissections as well. Chronic dissections happen when there is a prior aortic valve surgery, or if there is any aortic ulcer which is gradually progressed and has formed a pseudo-aneurysm kind of a thing. So this is the case of a post-AVR, the aortic closure line, suture line, there was a dissection from there. So he came with a huge aneurysm going into the right chest cavity. Entire right chest cavity was occupied from the dissection, the false lumen. So here we are removing this. See how huge the aneurysm is. So we are excising the aortic valve, and in the next video why is this not playing? Maybe. Yeah, this is another case where I told you the intramural hematoma or a ulcerated plaque. So this is the kind of a ulcerated plaque with a fresh thrombus formed. This is what you are seeing is the arch and the descending aorta. Such a huge thrombus in the arch. There was a dissection in the ascending aorta and the ulcerated plaque, and there is a thrombus that had propagated into the arch. Fortunate that he is not embolized and had a stroke. So this is just a pause here. Yeah, see. Here, this is the aortic root. We have already done the aortic valve replacement with a valve conduit, and now we have opened the arch under the circulatory arrest, and then we are removing this thrombus and fixing the dissection, and then making an anastomosis with this graft to the arch. So after the completion, it will look like this. So these are some of the cases. This is the same case. On opening, it looks like this with a impending rupture. This is the completed repair with all the arch vessels being anastomosed, and this is the flaps. This is that aortic thrombus component. See this? Can you see this? Huh? So this is a tear, and the thrombus had propagated nicely here, like this. You can see here. So it's a very time-sensitive emergency. So you need early diagnosis and immediate action saves lives. And if you delay, every hour is going to increase the chance of mortality by 2%. And beyond 24 hours, even the surgical outcomes are very bad. So CT is the key to diagnosis. Type A requires surgery. Type B requires conservative management. Intervention is only required if it is more than 6 centimeters or if there is any organ perfusion deficit. Thank you.
Thank you so much.
Yeah.
Can we please invite Dr. Saurav Tiwari to felicitate, sir?
Any questions? Anybody?
Thank you, sir. Thank you, sir. So for our next topic, I want to ask Dr. Vedic, how many times have you ordered troponin I in the year?
Troponin I has been ordered a number of times, like uncountable almost.
Okay.
Yeah.
So do you feel that it's
Generally, for every patient who presents with chest pain, generally
Yeah.
to rule out if the ECG is unequivocal, we get a trop I done.
Exactly. So don't you all feel that we sometimes order too many troponin Is from ER? I think it's the most used and overused investigation in the ED. So I would like to call upon my senior consultant, Dr. Akshay Deodhar, to the stage to induce an inflammatory response with his talk, troponinitis.
Good morning. I'm again back here. So I wouldn't say most used, I would say abused. It's the abuse test that we do in ER. So I'll start with a take-home message rather than ending my PPT with a take-home message. What is a take-home message? As fast as I finish my presentation, should be your disposition of your patients with chest pain. In and out. No, not out, out. You don't want them to go up, na? Or up? Okay. So the issue is because you have so many causes of elevated troponin, which we don't take into account. So what's happening in the photo? What's happening in the photo? Anyone? You have the mic, Kirti? Your bad luck, I know few of you through your first name, so might actually catch them. What's happening? Let's start with Saili. Where is Saili? Yeah. What do you feel is happening?
Hello.
Yeah.
There's a
You
patient.
can sit and answer, that's fine.
Patient being evaluated. Yeah, they're overseeing the labs. There's another senior doctor in the background. There's a cardiac
Okay.
monitor attached. Fluids are ongoing.
Okay. So basically a 68-year-old male, Johnson, chest pain, sweating, he has come with positive troponin. Okay. How many of you are a fan of House MD? So less? Come on, I'm not that old. Neither are you guys. So less? Okay. So this might be difficult for a few of you. So, you know Dr. Foreman? Yeah? So what's his personality? Anyone can answer. Evelyn? I mean, just 1 or 2 words. I'm not asking a matrimonial type of personality description. Just 1 or 2 words. If you have to describe Foreman in 1 or 2 words, how would you describe
He needs
it?
to be right.
Needs to be right. So Dr. Foreman obviously jumped on to conclusion. Oh, sorry, disclaimer. Few of the photos and names may be accidental. So I'll make sure my phone is switched off after my PPT so that no one catch hold of me. So Dr. Foreman thinks it's what? Troponin's positive, chest pain, sweating. It's MI. Let's call cardiology and take him to the cath lab. Yeah? All of us agree? All of us agree like Foreman? So whom does he go and tell this to? Who? Can someone describe Dr. House's personality? Prasad?
He needs to prove that the other person is not right.
Prasad, we give opportunities to everyone to speak. Then the next personality trait will come from this side.
Means personality is like always think out of the box. Not
Okay.
Taking commonly things.
So Dr. House feels, I think people don't know him. You know him or you don't know him? My mentor, he's the head of department at Kokilaben. So Dr. Foreman goes to Dr. House saying that top's positive, chest pain, sweating, let's shift him to cath lab. Dr. House replies, why don't we use our brains for a while rather than calling cardiology? Radical? It is, but let's use it. So on digging further, we know that patient might have had some fever history. I think the wife died because of something. So in comes Dr. Chase. Who's Dr. Chase? Any personality trait? Niyati? You've not seen? Oh my God. Natasha? Personality trait for Dr. Chase?
He's easygoing.
Easygoing. So Dr. Chase says that it looks like Takatsubo's cardiomyopathy. Yeah? I hope you know him or no? Yeah. So he says it's Takatsubo's cardiomyopathy. What do you think Dr. House will reply? How cute. You learn a long word today. Wow. So then obviously, no, it could be myocarditis also. And in the whole conundrum that is going on, you have Dr. Taub. Is anyone aware of Dr. Taub? Short guy. What's his personality like? No? No one? Anyone wants to answer willingly? He's a? That is what beta? Exactly. So Dr. Taub comes in and he says his creatinine is 8. So Dr. House asks him, what do you feel it is? He says, I want to quit emergency medicine and join plastic surgery. Yeah? So, cutting short, I think all of us have gone through this cycle of ordering troponin unnecessarily, frequently. So I would say we have transitioned from doing chest pain protocols to now fast-track discharging patients with single troponin. Have we improved? I don't think so. Okay. So background, I'm not going to touch base much. I think we all know there are 3 components, ITC. Important is, come on. It should always, I should be important always. Yeah. People didn't get the pun. They're still sleeping. Sorry. So what are my challenges when I talk of troponin? So frankly, what is troponinitis or troponinemia? Anyone has any idea? I think by the end of lecture you would. So my challenges with anyone in the department is first a low risk chest pain and troponin. How do we correlate both of these? A single troponin and discharge, and obviously the falsely positive troponin. Okay? So if I have to tell that we are always worried for the cases that we have missed, how many of you have palpitations if your departmental head calls you post-night? First ring and you are scared. Did I miss something? Yes? That's a knee-jerk reaction? Yeah, even I'm worried for the same. So we are more worried for patients we send home, not for the patients we admit to ICU. Okay? So what is a missed ACS? Missed ACS? If the relatives miss him the next day. Okay. So low risk chest pain. I'm not talking about obvious angina. Every one of us knows on exertion, relieved by rest, relieved by nitrates, fine. The moment we don't have typical pain, we are relieved. Should we be? No. Because atypical presentations are very common. We still call them atypical. More common in, I'm not being sexist, not scaring anyone. More common in females. Come on, literature has proved it. It's not my personal remark. And diabetics, elderly, yeah, you will have atypical presentation. Risk of atypical presentations always stay because you would not take that symptom seriously and you would pass it off saying it's a gastritis or a musculoskeletal pain. You may not have typical anginal pain, but you will have anginal equivalents like most common would be shortness of breath, followed by generalized weakness, followed by sweating. Yeah? I'm not sweating because of angina, it's because of the lights. So these are the categories that may come across in front of you when you want to decide. What do you feel? They are low risk or high risk? They are low risk or high risk? They are mixed. Okay? So the important thing you need to remind yourself is it's not definitive that if the pain is like this, it has to be anginal or it is non-anginal. You are just trying most predictive of ACS and something which decreases the likelihood of ACS. So for example, if I say that a pleuritic pain in nature or pain which is increasing on palpation, you would obviously say it's non-cardiac. Yeah? Now go back to the literature, 7% of patients will still present with this kind of pain when they are having active ACS. Okay? So this is supposed to guide you, it's not black and white. Okay? Next thing we always try to risk stratify is by having a look at the risk factors. So what we always thought of, DM, HTN, dyslipidemia, obesity, sedentary lifestyle, previous family history of sudden cardiac death, high risk. Now slightly tweak it. There is something which is traditional, of which diabetes and family history of premature MI in male patients. Females, be happy. Males are also at risk of it. You are not alone. So these are more important, especially less than 40 years of age. If the patient is less than 40, beyond 40, they may not make much of a sense. When you have young patients coming to you with chest pain, you will need these additional history to be taken about pregnancy, CKD, HIV, cocaine abuse, chronic steroid use and lupus. Okay? Because this again puts your patient at more risk of having ACS. Now, there are key ECG patterns beyond ST elevation. Okay? So I think we are all familiar. I've just put the common ones first. D Winters, every one of us is aware. Okay. Flip T, isolated T wave inversion in AVL. Be always worried. I would push the patient for a consult even if you feel everything else which we discuss ahead is negative. What is this? Valence. Okay. So if you have ECG pattern which is valence, again be worried. You don't have ST elevations, you still should be worried. Now obviously doing ECG is going to be your second part after a history taking, and the third part comes to doing a troponin. Okay. Now I think previously our job was very easy when we had conventional troponins. It was literally black and white. Things above this are positive, things below this is negative. Now with the advance of highly sensitive, you have levels which are easily detectable in healthy individuals. So right now, the challenge for you should not be a positive report. It should be the falling and rising trends. So just so if your cutoff is 26 and your troponin comes 27, patient is asymptomatic. What do we do? Immediate cardio consult. I think most of us do that. So one thing we don't learn for cardiologists, they are already kind of pretty clear about what they want to do ahead. So they would not interpret the value only. They would interpret in the clinical context, importantly. So again, when we talk of highly sensitive, most of the departments have highly sensitive troponins right now. Yeah. Now, the next challenge for you would be doing a serial highly sensitive troponins plus getting the report done quickly. So these two statistics should favor you that a normal ECG and a single undetectable troponin level rules out in 33% of your patients ACS, plus your major advanced cardiac event is less than 2%. Now, if you couple it with a risk stratification score, which we'll discuss, your MACE further reduces less than 1%. So, is this something which every one of you are using or no? Or someone is using Grace, Timmy, anything else that you're using? You're not using heart, you're using HEAR, HEAR, no? So this is something you should use proactively with the intention. You want to be sure whether the patient is low risk, high risk or medium risk. High risk will require a coronary intervention immediately. You don't need to worry for them. Low risk, you need to be very clear when you are sending them home, where your algorithms of either 1 hour or 2 hour delta will come into action. Medium risk is something which will require further evaluation. Okay? Obviously, the heart score comes with its side effects. For example, if the history and EKG are not reported properly and the trop is negative, 0 to 3 low risk, you would discharge. Let's say the troponin is positive, but all the rest are negative. Normal ECG, no history, no risk factors. What's your heart score? 2. Again, between 0 to 3, you will discharge. So it's not the absolute holy grail, but like I have put, do we want best? No, we want better. Better is always better than the best. Lastly, for low risk chest pain, your ancillary testing like CT coronary angio. Will you do it? Will you consider doing it from ER? So one message which I would want to put across to all the ER people, we are here to diagnose ACS. We are not here to diagnose coronary artery disease. That would be something which you would pass on to the cardiologist. So that decision will need to be involved with specialty, not individually. So you cannot take a call that it's a medium risk, trop is negative, I don't want a serial trop, let's do a CT coronary. Okay? So cutting short, this was the main crux that I want you guys to take home, that when you have low risk, history, ECG makes more sense along with ECG and troponin. It cannot be an isolated troponin positive because you have so many causes of troponin being positive. Especially what happens if you incorrectly diagnose? Let's say you have upper GI bleed who's come with hemoglobin of 8 and someone sent a tropi and tropi came 100. Can you take up for angio? If I ask Mahesh sir here, he would deny. Can he give antiplatelets? Anticoagulate? Would the anesthetist be happy to take this patient under GA? So everything gets stuck and delayed. You don't want that to happen because then you are trying to address a problem which is not existing. So again, rushing through, you have certain non-cardiac critical illnesses because of inflammation, because of the, I would say it's not ischemia of the heart, it is the supply-demand mismatch where you have falsely elevated troponins. They will not require a cardiac intervention. They will not require any specific treatment. You treat the primary cause and things will settle. One thing which you can use is troponin is a good marker for mortality and morbidity in your ICUs. So if you have someone constantly troponin on higher side, I would keep a close watch. Same for pulmonary embolism. Trop positive, you need to admit this patient and keep a close watch. Stroke, yes, because of the catecholamine hypothesis, because of the storm, you would have troponins coming positive in stroke and SH also. COPD, trop positive does not mean acute ischemic event. You would have decompensation happening. Again, keep a close watch. Chronic renal failure, because of delayed clearance of the protein, you would always have increased levels. So always scrutinize. Do not jump into immediate intervention. Sepsis, again, it's an inflammatory response. You have increased membrane permeability. So there is no necrosis happening. So it's reversible. You treat your sepsis and things will automatically settle. No cardiac intervention required. So that's it from my side. Any doubts? I'll be happy to answer. Any doubts? Wow, pin drop silence. No doubts? Do we still continue doing troponin? Yes, no? But with what? With slightly more interest in history, risk factors, and ECG. If you're ordering troponin, your plan has to be set when you're pricking the patient, not when you get the report. Okay? Thank you.
Akshay. So, coming to our next topic, we all have been seeing MIs and we all have been pushing our patients to the cath lab. But there are times when some centers, they do not have a cath lab. There are times when even your cath lab might be occupied with patients. What do we do then? So we unclog, we clear, and we unleash. I'm not talking about Harpic. It's about thrombolysis. Can we have Dr. Samrat Chavan on stage, please? He's the head of ED, Hiranandani Hospital. Thank you so much for being here, sir. क्या हुआ?
Yeah. Good morning, all. Yeah, as she said in the instruction, it's pretty much like using Harpic only to unclog the artery. Yeah. Yeah. So, according to the 2023 report published in the Journal of ACC, India has a higher cardiovascular disease burden compared to the Western countries. The current death rate in India is 272 compared to the global average of 235 per 1 lakh population. This rapid rise in troponin, hung over from the Akshay's talk. So this rapid rise in cardiovascular diseases in India is well documented. Since year 2015, we have seen an estimated cases, 64 million cases of ACS already. And as far as the STEMI cases are concerned, the experts put a figure upwards of 3 million a year, which is again comparable with the global disease burden, what we see in the Western countries. So once you have a patient in your ER or in the hospital setting, wherever you are working, with a working diagnosis of a STEMI, and when it comes to their management, your aim is to prevent death, limit the extent of myocardial damage, as well as relieve the patient's discomfort and pain. And how do you achieve that? What is your strategy for getting that done? You have to re-establish the myocardial perfusion before the irreversible myocardial damage takes place. So how can you achieve that? You can achieve that mechanically, you can achieve that pharmacologically, or by pharmacoinvasive therapy. So we all keep saying time is muscle, time is muscle. What do you mean by time is muscle? So what happens when someone is having myocardial infarction? Why do we keep saying that time is muscle? So the amount of tissue salvageable in myocardial infarction is inversely related to the coronary artery occlusion duration. So for the first 5 to 6 hours, the myocardium is very salvageable. Thereafter, the myocardial ischemia becomes irreversible. So if you initiate the reperfusion therapy, as shown in this figure over here, within the initial 2 hours, you can salvage the significant amount of myocardial tissue, especially within the first 1 golden hour. That is what we called it. You can always save the 65 out of 1,000 patients presenting with STEMI. Thereafter, also the benefit persists, but as you can see, you start seeing the flattening of the curve. So there isn't much myocardial tissue left to salvage. So coming to what are the reperfusion treatments we use in the hospital? One is mechanical reperfusion. How do we do that? we do it by primary percutaneous coronary intervention. Pharmacological reperfusion, it can be performed in the pre-hospital setting, which has become a norm at many places. Even in India, we are seeing more and more pre-hospital thrombolysis in southern part of India nowadays. Plus, you can perform the thrombolysis in hospital setting as well. Pharmaco-invasive therapy is mix of those where you first thrombolize the patient, which is followed by early angiography and if required, mechanical intervention as well. Remember that the time is very critical, so you have to take the decisions very fast. So what do the studies say about the reperfusion therapies? So the PPCI, that is primary PCI, remains the gold standard in the STEMI care, provided you perform it within first 20 minutes of first medical contact. Having said that, timely PPCI is difficult to achieve in many reasons. As we earlier were discussing, even during the talk of dissection as well as the troponin eyes, many of these patients don't reach you in time. They take the different channels. Fewer ones first go to a nearest clinic. Sometimes they go home and do their own experiments with various drugs that they have at their disposal. So, what do the STEMI treatment guidelines say about the reperfusion therapy? So the guidelines from the American College of Cardiology, American Heart Association, as well as the European Society of Cardiology agree that the primary PCI is the gold standard of reperfusion treatment. Again, if it can be delivered within less than 120 minutes of diagnosis, that is less than 2 hours. What if it's not possible? What should be done in that case? The fibrinolysin should be performed using a fibrin specific agent, okay, which are the RTPAs as well as TNK. We'll come to that in the later slides. And the ESC as well as ACC guidelines recommend that it should be performed or initiated within the 10 minutes of diagnosis, okay, when you don't have the immediate PPCI facilities available. Preferably in the pre-hospital setting itself alongside the adjunctive antiplatelet and anticoagulant therapies. And subsequently, the patient should be transferred to a PCI capable center for subsequent management. So, this summarizes how your approach should be to a patient of STEMI. So, once you have a patient with a working diagnosis of a STEMI, and if the time to the PCI center is less than hours, then you should most definitely transfer that patient to the PCI capable center, wherein the patient should undergo the primary PCI. So, door to balloon time there should be So you have to keep that in mind. But in case, if you don't have a PCI center available within the next 2 hours, or it happens more often than not in our big corporate hospitals also, wherein we at Hiranandani have 2 cath labs. But it has happened even very recently also. We had a case of CTO going on and one STEMI had come and then we had one more. And both cases were, turned out to be a difficult one. We had to thrombolize that patient in the ER and then subsequently take them for the PCI. So what should be done in case if the PCI center is not available within the next 2 hours? In such cases, you should opt for a pharmaco-invasive therapy. First of all, you have to make sure that the fibrinolysis is not contraindicated. In case if it's contraindicated, no matter what's the time of presentation, whether they fit into the thrombolysis criteria or not, if it is contraindicated, make sure that you ship that patient to the PCI center. Okay? And the guidelines say if you are going for the pharmaco-invasive approach, you should initiate the bolus of the fibrinolytic as early as within the 10 minutes of diagnosis of the STEMI. Once you have done that, then what to do next? Don't keep the patient where you don't have a PCI facility. The patient should be transferred to a PCI capable center again. And once the patient reaches there, a team from there should reevaluate the patient and see whether the reperfusion strategy by thrombolysis has been successful or not. How will you know that the reperfusion has been successful or not? Usually different guidelines say different things, but yeah, let's come to an end point that at the 90 minutes, if the patient gets a symptomatic relief from the chest pain as well as you see the settling STTs, then you can assume that the patient has responded to the reperfusion. In that case, next thing you do is you hospitalize the patient, preferably in the coronary observation unit, and then schedule them for the routine PCI later. But again, that has to be within the next 24 hours or so. What if that reperfusion by the thrombolysis is unsuccessful? How would you know that the reperfusion has been unsuccessful? Yeah, the patient would exhibit the signs of instability. Particularly, you have to look for persistent chest pain or worsening of the chest pain. And EKG wise, you will see the persistent ST elevation. And of course, the other signs of instability would be present there as well. You will see them going into the failure and all other things. So if that happens, then that patient should be taken for the rescue PCI. Okay. So that's what the guidelines recommend as far as the reperfusion strategies are concerned. But in case if you don't have a PCI facility readily available or at that point of time, and when you decide to go ahead with the thrombolysis, first thing that should come to your mind is whether the thrombolysis is contraindicated or not. In case if it's contraindicated, end of the story, doesn't matter how long it's going to take for the PCI, but the patient should be transferred for the PCI. And in case you decide to thrombolyze, then the next question is always, So let's first go through the rationales for pre-hospital thrombolysis as well as pharmaco-invasive strategy. As I said earlier, what is pharmaco-invasive strategy? That you first thrombolyze the patient, and then after thrombolysis, you transfer the patient to the PCI capable center. So the rationale behind the pre-hospital thrombolysis as well as pharmaco-invasive strategy is that not all medical centers are PCI capable, and pre-hospital delays often prevent the patients from receiving the timely PCI. Another rationale is no specialist equipment or setup is required for performing the thrombolysis. Pre-hospital thrombolysis has been established as a safe as well as effective treatment of the STEMI. Plus, pre-hospital thrombolysis reduces the time of perfusion and improves the outcome if the PCI is not possible within the next 2 hours. We already saw that odds mortality ratio graph wherein we learned about the benefits of early reperfusion. Plus, pharmaco-invasive strategy may achieve reperfusion directly, and in case, even if it fails, you always can bank on a subsequent rescue PCI. So, once you have made up a mind that you are going to thrombolyze this patient for the reasons we already learned, so what comes to your mind? What kind of thrombolytic agent to be used? What should be your ideal thrombolytic agent? So it should be rapid acting, should be highly efficacious, should have low incidence of adverse reaction, particularly bleeding, stroke, as well as allergic reaction, should have a low reocclusion rate, it should be easy to administer. Boluses are preferred over the accelerated infusions. It should be easy to administer, it should be simple, and it should have a tailored dosage of regimen. Plus, good long-term effects on clinical outcome, as well as it should be cost-effective. These are the four most common thrombolytics we usually come across. Streptokinase is rarely used in the major corporate hospitals and all, but still it's the cheapest of them all and most commonly used in the low-cost setting. The other one is the Altiplase. Altiplase is a recombinant form of human tissue plasminogen activator, which has a plasma half-life around 4 to 8 minutes. It has shown improved outcomes in myocardial infarction compared to the streptokinase. Retiplase is genetically modified RTPA only with longer half-life, that is of around 13 to 16, around 18 minutes or so. But it has failed to show any major clinical benefits over the use of Altiplase. The only benefit Retiplase offers over the Altiplase is you can use it as a bolus rather than an accelerated infusion, which is you have to do in case you are using Altiplase. The fourth commonly used agent, most common used agent for thrombolysis in US is currently tenecteplase. So the tenecteplase has a longer half-life compared to the RTPAs, plus it has the highest fibrin specificity, as well as it is almost 80 times more resistant to plasminogen activator inhibitor, type 1. You can use it as a single bolus, and the various studies and the trials have shown that its efficacy is equivalent to RTPA with improved safety profile compared to the alteplase. So, what do the ESI 2023 guidelines recommend about the reperfusion therapy? Again, the gold standard is PCI in a patient presenting with the STEMI with the onset of symptoms within 12 hours. If it's not available within next 120 minutes, the choice is use of fibrinolytic if not contraindicated. What kind of fibrinolytic should be used? A fibrinolytic which is fibrin specific. All right, be clear? So these are the recommendations. We can see here the tenecteplase comes out as a winner as it has a highest fibrin specificity plus ease of administration. You can easily achieve what's the door to needle target in case you are doing IV thrombolysis. I know most of us are working in a corporate hospitals in Mumbai, so we don't really do much thrombolysis. But if thrombolysis is to be done, it should door to needle time, like how we have door to balloon time of 90 minutes, door to needle time of 30 minutes, it was the guidelines recommended. But you should initiate as early as 10 minutes if it is required. So this is the brief comparison between the different thrombolytics we just discussed. Just in brief, we can see like the advantage of RTPase and TNK over the streptokinase, that it shows no antigenicity. They are direct plasminogen activators. They have more fibrin specificity compared, whereas streptokinase is not fibrin specific. How do we administer them? If we are using streptokinase, 1.5 million units are infused over 60 minutes. But more often than not, you have to watch out for allergic reaction, and it's recommended that you administer these patients with corticosteroids as well as antihistamines before starting the therapy. Plasma half-life is around 18 minutes or so. It's not resistant to the plasminogen activator inhibitor type 1. Then the comparison amongst the two RTPase and tenecteplase we'll just briefly see. Why tenecteplase is superior to streptokinase? The ease of administration. You can give it as a single bolus over 5 to 10 seconds, so that it's very suitable for achieving door to needle time of 30 minutes. Streptokinase, it's administered over 60 minutes or so. You have a weight adjusted dose available for the tenecteplase. It has the highest fibrin specificity as well as fibrin affinity. Comparison between tenecteplase and retiplase, again, if you compare the retiplase and tenecteplase again you can transfuse or initiate it, give the bolus over 5 to 10 seconds, whereas retiplase, how do we administer? Has anyone used retiplase so far for thrombolizing a patient? So it's transfused, so the tenecteplase transfusion is done in 2 steps. First steps, you take 2 units and administer it over 10 units and administer it over 2 minutes. Then you have to wait for another 30 minutes and next 10 units ka vial you transfuse over next 20 minutes. So it takes almost minimum 34 minutes even if you take the immediate decision to thrombolize. So again, not suitable for achieving door to needle time of 30 minutes or so. The major advantage is of using tenecteplase as a thrombolytic agent. Can you tell me? We just discussed it now. One, you have a weight-specific regimen available. You can give it as a bolus, single bolus over 5 to 10 seconds. It has the highest fibrin sensitivity as well as affinity, specificity and affinity. Correct? It has shown reduced non-cerebral bleeding incidence compared to the other RTPAs and all. this is again what I was just said, the time duration. So tenecteplase, if you are using, you can use it as a single bolus. Retiplase, 2 boluses, 30 minutes apart. Altiplase, how do we use altiplase if we have to use it in a thrombolysis of a STEMI patient? I'm sure we all are aware how we use RTPA or altiplase when we are thrombolizing a patient of acute stroke. What's the regimen over there? I'm sure that's what we are using. We are using tenecteplase also as well. Yeah, so you have to calculate a dose, 0.9 into patient's weight, 10% of that we give as a bolus and remaining over next 1 hour. Here it's even more complicated if you are using it for the thrombolysis of a STEMI patient. This is something we call it as an accelerated infusion, where a 15 mg bolus is first given to the patient, then followed by a 0.75 mg per kg transfusion over next 1 hour, and then 0.5 mg per kg over next 1 hour. So that's quite consuming. So almost it takes 2 hours, and you are not really sure whether it has worked or not till the end of the 2 hours. Wherein, as the recommendations we just discussed, if this patient's post thrombolysis shows failed thrombolysis, then you have to take them immediately for the rescue angioplasty. Yeah, so this is what pretty much regimen we just discussed. If you are using altiplase, you have to give accelerated infusions, 15-minute bolus, and then the 2 subsequent boluses. It has shown better outcomes compared to the streptokinase, yeah, but more difficult to administer because of the short half-life. As far as the tenecteplase is concerned, single bolus over 5 to 10 seconds, as effective as altiplase, plus less non-cerebral bleeding incidence. Retiplase, again, ease of admission is there, but you have to give 2 doses, 30 minutes apart, which ends up taking lots of time. Streptokinase, not preferred now, but still used commonly in the low-cost setting. 1.5 million unit is infused over 30 to 60 minutes. So the take-home points are, STEMI is a time-critical medical emergency. Clinical outcomes improve with reduced time to reperfusion. So efforts should be made to reduce the ischemic time. Implementation of the STEMI network is recommended by the guidelines, and it has shown in various studies and registries that reduction in the delay increases the chances of myocardial salvage. Pharmacoinvasive strategy is recommendable whenever PPCI facility is not available within the 120 minutes or 2 hours, and it can always be followed by the angiography and a mechanical intervention if needed. PPCI is considered gold standard of treatment if it is performed within the next 2 hours of presentations. That's pretty much about the talks about thrombolytics. If you have questions, please feel free to ask about it. Yeah, this is what the Indian guidelines, they also suggest the same thing, which the ESA and ACC guidelines suggest. In addition to that, I have given the references of the various trials which have happened over a period of time, looking at the effectiveness of a pharmacoinvasive approach. All those slides are there, but I'll not take too much of time going through those studies. Just, if time permits, go through those studies so that our concept about use of thrombolytics, when to use and how to use are very clear. Thank you so much.
Thank you, Dr. Samrat, for such a nice presentation. Can you stay, sir? We need to felicitate you. Can I invite Dr. Sandeep Gore to felicitate Dr. Samrat Chavan? This side. So we have an interesting case discussion coming up now. Haven't we all been in a dilemma when we see a rhythm that we really can't reset? Whether it's rate, rhythm, what do we do? Do we ask the expert? Do we follow the guidelines? Or is every case different? Because nothing about the heart is black and white, right? So I would like to call Dr. Mahesh Gogre, our senior interventional cardiologist from Apollo Hospitals, and our junior resident, second year DNB, Dr. Fida KV. So we are going to have a case discussion. I hope you all love it.
Hi, good morning all. Myself, I'm Dr. Fida. I'm a second year resident in emergency medicine. So here we are with one of the most debated and one of the most discussed topic of all time among cardiac emergencies, atrial fibrillation. Offbeat, not off-life atrial fibrillation rate versus rhythm. So we'll be going ahead with case-based discussion. We have Dr. Mahesh Gogre, sir, senior interventional cardiologist. He'll be providing his insight with respect to the same. So we'll be going ahead. Before going ahead with the case-based discussion, we'll have a short, brief discussion on atrial fibrillation basics. So atrial fibrillation is one of the most common dysrhythmia. Patient can present with lethargy, palpitations, dyspnea, chest tightness, syncope, dizziness. The odds ratio for death, male is to female, is 1.5 is to 1 is to 1.9 is to 1. The presentation can vary. It can present as an acute onset requiring immediate management, or AF as an associated or incidental finding with respect to the presentation. The problems with AF is that the uncertainty regarding the onset. Because we need to know the onset, sometimes the treatment modalities may vary with respect to the onset, and also the relevance to the presenting complaints. We know that AF can predispose to many conditions. So with respect to the presenting complaint, we might have to change the management. So this is the 2023 AHA classification for AF. This is a reverse classification. So in this, there are main 4 classification with subsets. So at risk for AF and pre-AF, where there is a close surveillance has to be there, and there is an AF with subsets including paroxysmal AF, which is intermittent and terminates within less than or equal to 7 days of onset. Persistent AF, which is continuous and sustains more than 7 days, which requires intervention. Long-standing persistent AF, which is continuous more than 12 months in duration. And the next is successful AF ablation, freedom from AF after percutaneous or surgical intervention. And then last is permanent AF, where there are no further attempts to maintain a sinus rhythm. This is there should be a discussion between the patient and the clinician with respect to the AF control. So in coming to the clinical assessment, as I've already said, we need to know the rhythm onset because our treatment strategies may vary with respect to the rhythm onset, and also the precipitating events. So with respect to the hemodynamic consequent, almost all the time AF is cardiovascularly stable, but there are some conditions they will present with hemodynamic instability, where if there is a poor LV function, and also if the ventricular response to AF is resulting in high heart rates greater than 150 beats per minute. So what happens is when you have a high heart rate, you have got a decreased diastolic filling, and in turn decreases the coronary blood flow, which in turn can result in ischemia or worsen the ischemia. So we also have a Chadwa score, which helps in deciding the anticoagulation for patients presenting with AF, because they are always at risk of thromboembolic events. So, and there's precipitating events. We know there is a pyrates mnemonic. If you don't know about that, there is a pyrates mnemonic which includes PE, ischemia, respiratory disease, atrial enlargement or myxoma, thyroid disease, ethanol, sepsis, sleep apnea. Not always AF can be isolated thing. It can also present with these things. So we might have to deal with the underlying factors before treating with the complete recognition of the AF. So this is a Chadwa score. So there are 1 + 1 and +2 points. So we will calculate the Chadwa score. Male sex itself put the patient at risk for developing thromboembolic events. And with respect to the score, Anticoagulation is recommended in certain cases, not recommended in certain cases. So if the score is 0 in case of male and 1 in case of female, if it is a non-valvular AF, anticoagulation is not recommended. If the score is 1 for male and 2 for female, anticoagulation can be considered. Or if the score is greater than or equal to 2 in female and greater than or equal to 2 in males and greater than or equal to 3 in females, anticoagulation should be started. So coming to our topic, rate versus rhythm. So according to the current scenarios, NICE guidelines recommend the rate versus rhythm control in acute setting and non-acute setting. So in acute setting, if their patients are present with hemodynamic instability, straight go ahead with electrical cardioversion. If there is no hemodynamic instability, then yes, if the onset is less than 48 hours, rate or rhythm control. If greater than 48 hours or uncertain, then you have to go with rate control, therapeutic angulations for 3 weeks, then you have to go ahead with cardioversion. If there is decompensated heart failures, you can consider beta blockers. You have to have a specialist opinion regarding the same, but do not use calcium channel blockers. Pharmacological cardioversions, amiodarone in case of structural heart diseases, flecainide or amiodarone if there is no evidence of structural or ischemic heart disease. In a non-acute setting, rate control versus rhythm control. Offer rate control in except some conditions, which in default becomes the indications for rhythm control. So those are AF with reversible cause, heart failure, new onset AF with atrial flutter, rhythm control strategy based on clinical judgment. So what drugs can be used? Beta blockers can be used, which include metoprolol. Calcium channel blocker can be used, which include rate limiting, verapamil diltiazem. If the patient doesn't tolerate, you can go also ahead with digoxin or a combination therapy of beta blocker, digoxin and calcium channel blockers. In case of rhythm control, if the symptoms continue after rate control or unsuccessful, you can go ahead with rhythm control and also the indications which I have mentioned below the rate control. Amiodarone can be considered in LV failure. Dronidrone after successful cardioversion can be considered. There is also a pill-in-pocket strategy. When a patient presents with infrequent paroxysmal AF, they should not be put, we can consider that they should not be put on a regular medication. They can have the pill in the pocket. Whenever they experiences these palpitations and all, they can consider taking that pill at that point of time. So there should be a correct discussion between the clinician and the patient regarding the pill in the pocket strategy, because they should know when and how to use the pill. The resting systolic blood pressure should be greater than 100 and resting heart rate should be greater than 70. So there should be some criteria to satisfy to go ahead with the pill-in-pocket strategy. Next is cardioversion. So that's about the atrial fibrillation. Now we'll be going ahead with case-based discussion. Coming to the scenario 1. So we have got a 71-year-old female with generalized weakness, abdominal discomfort, multiple episodes of loose stool since morning. Airway is patent, breathing, respiratory rate of 28 per minute, SpO2 of 95% on room air, chest ABE, bilateral crepitations, heart rate of 150 beats per minute, BP of 90-60 millimeter of mercury. We got an ECG and IV access during the same. GCS is 15 out of 15, pupils normal, sugars of 126 milligram per deciliter, temperature is afebrile, patient is dehydrated. Going with the sample history when we are getting the IV access and the ECG access, there was no history of any chest pain, breathing difficulty, LOC, fever, or altered sensorium or dizziness. No known allergies, no medications. Past history, the relatives revealed there was a past history of diabetic hypertension, rheumatoid arthritis, dyslipidemia, interstitial lung diseases, and PE in the past. Last meal was in the morning. History of constipation for the past 3 days, start on laxatives in the morning. By the time we got an ECG. So this was atrial fibrillation with a fast ventricular rate of 150 beats per minute. So the working diagnosis was sepsis, AKI, atrial fibrillation with fast ventricular rate and acute heart failure. So Chadwa score of 7. So I would like to ask, sir, so this is a working diagnosis in the patient. So we don't have any history of any AFib in the past as per the relative. We don't have any medications also as of now available to know if there was any previous medications going on. So how will we approach this case?
See, probably laxative use has led to loose motions in this lady. and there is clear-cut atrial fibrillation. So if fast rest is not available, we have to consider as new onset atrial fibrillation. And in any case, if patient is stable, then we have to consider rate control. This is the strategy. There are many trials, but AFIM is the one of the most important trial that has studied almost more than 4,000 patients, and they have found rate control is always the best strategy, except in a few patients, rhythm control is required. And in fact, rhythm control patients, they have got more hospitalization, almost 70% increased risk of hospitalization and risk of Torsades de Pointes if we plan for rhythm control. So what are the settings where rhythm control is required? Only young patients with very infrequent episodes of atrial fibrillation, like say every 6 months or every 1 year. These patients are perfect candidate because in these cases LA is not dilated. These are short runs of atrial fibrillation. Second is those patients with hypertrophic cardiomyopathy. This is very, very important. Whenever patient comes to you with atrial fibrillation, just put a probe, echo probe, and see whether patient is having large, means gross LVH, left ventricular hypertrophy. Because if it is HCM, whether it is obstructive or non-obstructive, the LV volume is very less. And 30% contribution to the LV filling is from the atrium. If patient gets atrial fibrillation, that 30% kick is lost and patient may even collapse. You won't come to know what is happening. That just simple episode of atrial fibrillation is giving patient is going to crash. So we have to see this. This is very important. Echo is very important in such cases. So basically rate control is preferable as compared to rhythm control. And there are other instances like those patients with post-PCI, post-myocardial infarction, post-surgery. In such cases, rhythm control is preferred. That's it.
So in this case, initially we went ahead with amiodarone, rhythm control, but the rates were 132 beats per minute even after 1 hour. So in such case, what should be our next step?
Oh, but in this case, first I would like to use beta blocker or calcium channel blocker.
Okay.
As patient was in failure, she had some minimal crepes, saturation was a bit on lower side. CCBs we can think of, still this patient is respond to CCBs well. So beta blocker should have been the first strategy in this case. And if patient doesn't respond to beta blocker or CCBs, then I would have considered amiodarone.
Okay. We went ahead with the beta blockers and the rates were controlled. So later on, we got a formal 2D echo done, which revealed moderate TR with a PASP of 45 millimeter of mercury and mild PH, mild MR, and mild AR. Will that change any of the initial management or any existing management, sir?
No. See, here one should have mentioned the LA size. That is very important parameter. If LA is grossly enlarged, when LA is more than 7 centimeter, we call it as aneurysmal LA. In such cases, forget about rhythm control. If LA is grossly enlarged, we can't get rhythm control by any means. So we have to go for only rate control. So LA size is more important in this case.
Sorry. So the final diagnosis of the patient was sepsis with AKI, atrial fibrillation with fast ventricular rhythm, and STEMI, acute heart failure with normal coronary on ECG. Later on, we found out that patient was a case of chronic AF on Concor 2.5. Medications were not available during the initial presentation. So will that change any of the strategies?
Yeah, then rate control is preferable because this is chronic AF. Certainly this patient should be on higher beta blockers. Here I would like to highlight, whenever we prescribe Concor Core, 2.5 milligram tablet is always for coronary dose. That tablet comes in the name of Concor Core, whenever it is 2.5 milligram. So for rate control, it has to be at least 5 milligram tablet. So that comes in the name of Concor. So this is the difference. This is very common mistake made by people. So they prescribe Concor 2.5, but that comes in Concor Core. Core name is added for coronary protection. So this is low dose medicine. So 5 milligram beta blocker is recommended in this case. Probably this patient is having vasculitis also. He is having HCQs, azathioprine, folitrax. So these are chronic AFib patients.
So patient was discharged with beta blockers and oil anticoagulants.
See, just go back.
Sorry.
Last slide.
Some issues with the...
They have written Ditor plus Telma. So I will just advise, whenever you write Ditor or any diuretic, just add ACE inhibitors or ARBs, because that will take care of hyper and hypokalemia will be balanced. If we prescribe Ditor plus with telmisartan or any ACE or ARB, there is risk of hyperkalemia in these patients. So be very specific while writing diuretics. There has to be ACE or ARBs. Don't write plus unless we are very sure of potassium status. So we continue with next case.
Going on with the next scenario, 76-year-old male, history of decreased consciousness episode 3 days back, airways patent, breathing respiratory rate of 26 per minute, saturation of 95% on room edge, chest bilateral basal crepitations, heart rate of 84, BP of 140/78, all 4 pulses felt irregular, HGT of 261, pupils equal, GCS 15, febrile. We got an ECG done meanwhile, which is an AFib with a controlled rate. History of decreased consciousness episode 3 days back associated with breathing difficulty, no chest pain, palpitations, fall, fever, cough, cold, headache, blurring of vision or seizures, no allergies, no medications going on. He had a history of DM, but he's on medication for the past 5 years. Last mail in the morning, he was hospitalized outside and was diagnosed with STEMI and was referred for further management. CNS examination revealed an NHS of 8, left-sided weakness, drift of both upper and lower limb, left side neglect, left extensor plantar response. CT was done, which showed a huge infarct. So, the working diagnosis was AFib with STEMI with right PCS stroke with acute heart failure. Chadwa score was 3. If considering the stroke of this presentation, it can go up to 5 also. So, in this case, what will be the next strategy, sir?
Already rate is controlled here. So probably thrombolysis will work for both STEMI as well as PCS stroke in this case. So we don't need rate or rhythm control in this patient.
If the initial heart rate was 130 beats per minute, how will we go ahead?
If hemodynamically unstable, DC cardiogen is straight away.
Okay.
So that should be the strategy, because this is ACS.
If the hemodynamic status is okay,
then
whether rate or
then rate control.
Rate
then
control.
IV beta blocker or IV CCBs.
Okay. Regarding the anticoagulation?
So this patient falls for thrombolysis. Anticoagulation will think of later. So once PCS stroke and this is stabilized.
So in general, rate control versus rhythm control. Rate control is preferred in case of multiple comorbidities, severe retinal enlargement, long-standing persistent AF cases. Rhythm control if young age, as Stahl told. Significant AF symptoms, persistent heart failure despite AF control, inability to tolerate medications. These are some journals worth mentioning. RACE trials, RACE 2 trials, and other trials. You can have a look in the PubMed journals. So my references are NICE guidelines 2021 and also 2023 ASHA guidelines. So the takeaway point from this case-based discussion is that whether rate or rhythm, there is no clear-cut thing. So it's based on individual-based. You have to treat the patient. It has to be the patient-based according to the hemodynamics. You have to treat the underlying factors. Unless you don't treat the underlying factors, rate and rhythm control doesn't reach into an ultimate result. So you can choose rate versus rhythm according to the patient hemodynamic stability, age, considering every risk factors into the place, and then treat the underlying factors. So you can have a senior opinion with regard to the same also. So you have any take-home message? So
basically, whenever it comes to rate versus rhythm control, rate control has to be the initial strategy, except in unstable patients like post-MI, post-PAMI, post-cardiac surgery, or those patients who have got underlying HCM. These are the only subsets where rhythm control is indicated. Else, those patients who have got borderline ejection fraction, say 30-35%, and in spite of optimal medical treatment, still they are in failure, and they are in atrial fibrillation. In such cases, we can think of rhythm control, but be sure there are no clots, or this patient has to be at least on anticoagulation for 3 weeks, and after that we can plan for rhythm control in such cases. And one more thing is pill in the pocket concept. We frequently discuss, but we don't know what is pill in the pocket. So it is basically tablet flecainide. If it is not available, simple verapamil tablet or beta blocker. Propanolol they have suggested. So Ciplar tablet comes, it is very handy. So we can ask these patients to have verapamil plus Ciplar. Ask them to take Ciplar tablet first 20 milligram or 40 milligram. If rate is not controlled, they can take verapamil. So pill in the pocket is very simple concept, very effective concept. And one more thing, very common in today's era, we are getting lot and lot this Holter monitorings. 3 days, 7 days Holter, and patient comes with the report, some runs of atrial fibrillation. Whether we should treat these patients. Unless AF burden is more than 15%, we should not start these patients on any anticoagulation, because risk versus benefit we have to see. If it is more, if we start anticoagulation in such patients, certainly these patients will land up with bleeding. So short runs of atrial fibrillation, they are absolutely benign. That's it. Any questions are welcome. No question. Thank you.
Here.
Yes.
So you said the patient should be thrombolized, so maybe the PCI would have been the better option.
So here it is very dilemma what to do in such cases. Yeah. So even with infarct, if we thrombolize, there is risk of hemorrhagic transformation. So there is concept of half dose thrombolysis. Okay. No one knows what to do in such cases. But when it comes acute myocardial infarction plus this, then we can consider. Anyways, we will have to start some antiplatelets and anticoagulation in these patients. So what I will consider is I will give heparin, injection heparin, very short half-life, and continue heparin infusion or 5,000 TID doses in these patients, and we'll get repeat CT scan. If there is no hemorrhagic transformation, we can continue that. Recently, I had one patient who had LV clot and stroke with hemorrhagic transformation 1 month back, and he landed up with STEMI inferior MI now. So in such cases, we have done the STEMI, we have done the PAMI. We started this patient on ecospin Axer for say 15 days, and after that we have shifted to clopidogrel. Patient is doing very well. So judgment we have to be very means counseling to the patient and relatives is very important in such cases. There are no clear-cut guidelines when stroke and acute stroke and STEMI are concomitant.
But in stroke guidelines, it's very clear. Already the history was 3 days back, he was decreased consciousness. But so that might have been the onset of stroke. Yeah, but the CT showed more than 1/3 area of the infarct, which directly becomes a contraindication for thrombolysis.
Even on ECG, it looks STEMI was days old, because there was ST elevation only in lateralis. There was no reciprocal ST depression. That's why I said we will keep this patient on at least heparin. We have to save heart also, and that will help for if I don't know if that MRI angiography was done or not. If there was some thrombosis, no.
No, MR angiography was not done at that point of time.
So if there is thrombus, then heparin definitely will help in such cases.
Thank you.
Thank you, sir, for providing the valuable insights. Thank you all. Have a nice day.
Can I call Dr. Sajal to felicitate Dr. Gogre and Dr. Fida? Thank you, Dr. Sajal. Thank you, Fida. Thank you, Dr. Gogre. So it's time for a refreshment break. I know we all have been waiting for a while. Go set your rhythm. Go. Yeah, please be back in 5 minutes for our next session.
And and yeah, I'll show, don't worry. So it's what? Squid Games and come on, we have residents here. I think this should be interesting to you. Mahashivratri. It's Mahasam Wars. It's on 19th April. So I hope you guys start practicing? Yeah? Okay. Let's start with Kahoot. 32. Can we start? Everyone in? Start? Yes. These are easy ones, huh? Not much difficult things to ask. Music. Okay. So you try to use adult pads, but making sure they don't overlap. Okay. Blink it. Wow, nice name. Easy. Some Samrat would be pretty angry on you, right? Krish is flying high.
This has to be 100%.
Stanford, huh?
कितना अच्छा session.
Okay. Good. Again, easy. Next is वो बंद हो जाएगा. I know this guy is not giving fibrinolytics. Who was that? That's why I said simple questions.
Big shake-up in the list. AFN.
Okay. Why are we getting confused? I think every one of us has to get this right. Everyone does triaging. Don't get confused with the background of your options. I bet people would have jumped the gun. Nah. Somebody jumped the gun, seeing the background of options. White is not an obvious category that we put. Again, very easy. कौन इतना टाइम ले रहा है? अरे रेड प्लेस का उसने बोला भी स्पेसिफिकली. You answer quick, you get more points. I hope you know that. Presence of healthcare professional. We are not that many right now to be everywhere in public place. Aditya has been on a streak. Good. Come on, don't get this wrong. Otherwise, my opponent will go high. Stroke, I told you, stroke, it will still go high. Sepsis also, it will go high. Again, very easy. Basics. Widened pulse pressure is not the answer. Discrepancy. Arey, somebody catch Aditya. 5 questions. Easy. I hope somebody doesn't get this wrong. Training. Training is not required. Infrastructure नहीं. अरे defib तो चाहिए ना. How will you do a good resuscitation? 4 players, good. Aditya is still having a good streak. 4 questions.
Faster, more points.
The 2 people who have answered wrong. Fallen from the grace of my heart. Last 3. This though you have to know. All of you know the answers, it's just who is answering them fast. Last 2 questions. EHA? I have your IDs. Last 2 questions. Correct, na? Why are you guys getting confused? Radiating to both arms, sweating, pressure like pain is typical. Last question. That's not how you give CPR, just to lighten up things. Done? Done? Okay, thank you. Thank you. We are not showing scoreboard. We want everyone to put equal efforts. Okay.
So you all are going to have two more chances at Kahoot. Like I mentioned earlier, Society for Emergency Medicine India has offered sponsorship for the winner. So if you think you haven't won this Kahoot, you have two more chances. You'll be sponsored for the MCon, plus Mansi has got a gift as well.
Yes.
So we'll carry on.
If I would want to do AHA, BLS, ACLS, I would choose Mr. Bean as my instructor. See his videos, they are fantastic.
Okay, so I hope you all had a nice tea break and coffee break. We move on to our next session. So how many of you have received patients in the ED who had a bystander CPR? Nobody? Come on. Nobody? Bystander CPR. Crash in the ER with bystander CPR. I have. 5-6 people have. So our topic is about community BLS and how its effect improves a patient's outcome. And I would like to tell you about some case that I had briefly. Last year I had a 55-year-old, early in the morning, came in cardiac arrest. He was brought in a car, but his teenage son was giving him CPR. He was just downtime 15 minutes. In 3 cycles of CPR, we got him back. He went to the cath lab, PAMI. Third day, he's wide awake, talking to everybody and wants to go Dharma because he wants to go home and drink alcohol. So this was my patient, and it was his 55th birthday, the day he arrived in ER, arrested. So he only survived because of his son. There was no other factor that could have saved him, that could have brought him back. So why community BLS is important and what is its impact and where we are as a entire community, where do we stand? I want to welcome Dr. Sajal Mahajan on stage. He is a consultant ED and critical care in HN Reliance now. He was with us but decided to leave.
Hello, good afternoon everyone. So this topic is a very simple and short topic. So the reason for emphasis to community BLS, because all of us are doing more advanced care now, right? So BLS is kind of basic for us, which is done in the community. We are doing ACLS, and now we have reached the stage where we are going to do eCPR now, right? So we are advanced in our technology, our knowledge, our way to manage the patient, but still we are discussing this topic. Why? Because it is very important to know that where we stand as a community in India at local level, where do that community, and if there is a community CPR, the outcome can improve significantly and the survival rate can improve significantly. So I will start with my favorite quote from Nora Ephron. As she says, death is a sniper. It strikes people you love, people you like, people you know. It's everywhere. You could be next, but then you turn out not to be. But then again, you could be. So any one of us can be there, can suffer cardiac arrest anywhere, anytime. There is no guideline that will predict that when you will have a cardiac arrest, right? So any one of you witnessed any out of hospital cardiac arrest? Like Mansi was mentioning, how many of you received ongoing CPR, somebody started a CPR and reaching to your ER or hospital. But how anyone experienced out of hospital cardiac arrest? Experience. So if you experience, can you share your experience, like how did the bystander or you are there, have you started the CPR, or what was your qualification that time? Maybe you don't knew CPR, or maybe you don't know the CPR. So if you have witnessed, it's very difficult. If you see in community, there are a lot of hesitations to start the CPR because they don't know how to do it. They think only the doctors can do the CPR, right? So it's very important to educate and train the community. So at the same time, why it is important, suppose any one of us suffers a cardiac arrest, be in cab, be in mall or anywhere. You really like that bystander who is non-medical personnel, do you think that he can give you the good CPR? Will you trust your Uber driver to give you CPR? Same questions, right? Obviously, if we suffer a cardiac arrest during traveling to Uber, will he be able to provide a cardiac arrest, the CPR? So we don't know, right? So that is why that community training is very important. If we train the community, it will be very important landmark for us as a community that survival rate will be very high. So we definitely don't want this kind of CPR. They will say, okay, we'll provide a CPR, but how Mr. Bean is doing the CPR? We don't want even that kind of. So it has to be a proper CPR. So CPR is the only time when pushing someone's chest repeatedly is encouraged. And it's very important to know this emergency response technique by the community. So in general public, community BLS involve training the general public. Those are non-medical personals. And if there is early intervention, it improves the survival. So if you see, this is the kind of chain of survival, what we say in out of hospital cardiac arrest as per. So we have to educate the people that don't just be a chicken and watch and record. So nowadays you see there are a lot of cardiac arrest or the people fainting. Somebody will be standing there, they are doing some intervention, they know, or maybe they're just recording the event. So instead of doing on recording event, people should know they have to act and they have to start the CPR and use the early AED, right? If they do the first 3 steps, obviously the EMS is going to bring a A game, no doubt about that. EMS people are trained, they are well trained, so they will take care, and ultimately the happy ending is the recovery. That's what we all should achieve, and that's what we hope for, right? So it is a cardiac arrest is a silent killer. If you see statistics of the India, around 4.5 million people annually suffer a sudden cardiac arrest in India. And out of this, 70% cardiac arrest happen outside of the hospital. And the survival rate will drop by 10% every minute without a CPR. So in India, there is a very limited public BLS awareness. So that's why the survival rate is almost 1 out of 10 people. That is also not, I don't think there is one person who can be saved. There is actually negligible data. You can say that because there is no public awareness about the BLS. So if you look at the globally, anybody knows this flag? So this flag is Denmark country. So Denmark is the only country in the world which has a law that you have to undergo a BLS training. Any kind of job, any kind of educational training that you are going to receive, there is a law that you need to have a BLS training properly, and almost 45 to 50% of the Denmark people are BLS trained. And their survival rate out of cardiac arrest is also 30 to 35%. So they have achieved that. So we are still lagging so behind that we are still less than 10%. So I feel, and anyone who know this player? He's a very good example. He's a Damar Hamlin. He's an NFL US football player. So in 2023, on January 2, he was playing a football match versus Cincinnati Bengals. That time he suffered a cardiac arrest. And he received a CPR for 10 minutes followed by defibrillation by the AED, was rushed to the hospital, was on ventilator for 2 days. After 2 days, he came out of the coma. First thing he asked, a paper and pen. And do you think what he, any guesses what he wrote on that paper? He asked, did we win? Definitely, everybody won that time, right? The EMS team, he and the community, those supported. So everything was done at the proper time and he survived, and today he's playing back again. So these are some examples that do, inspire us to work more harder and educate the community about the BLS. In India, so very commonly say like, what about us? Where do we stand? So I tried to search some data, like what is that? So in India, surprisingly less than 2% of the people know the BLS. And surprisingly, Delhi, which is not so famous for good reasons, actually Delhi has the highest rate of people who are BLS trained. So 6% of the Delhi people are trained in the BLS. So at least something good about Delhi, right? So if you look at the AHA data, so almost in USA, there are 350,000 sudden cardiac arrest death, and they have tried to analyze why the out-of-hospital cardiac arrest people don't receive a basic life support, this. So there are 31% of the people who are afraid of legal ramification because it's US. 24% thought the CPR is too complicated. 16% thought they have not received a proper training. 28% thought that they are afraid that might hurt the people. 18% thought they are not confident to provide a CPR. And 14% of the people were uncomfortable in providing mouth-to-mouth resuscitation. So you look at the data, if bystander CPR is given the first minute of the arrest, the survival rate are almost 22.4%. But as the time increases, more than 10 minutes, it drops more than 50-60%. You can say only 10.5% of the people can survive if they receive a CPR late. So they might just pick up the patient and bring to the hospital in 10 minutes, but still the chances being in the hospital and you don't start the CPR, your chances, no matter how advanced care you have, still your chances drop, right? So starting CPR at the field is very important. Same for the neurological recovery. You can say if started CPR within the 1 minute, you will have a 19.9% chances of good neurological recovery. It significantly decreases to 8% if CPR started more than 10 minutes late. So in community, who should know BLS? So I feel everyone, though people who have hands, they should know how to do a CPR. As simple as that, right? So you can see the train workers, drivers, teachers, office workers. I feel that everybody who's above 10 standard and those who have hands can perform the CPR, and it should be included in the post-junior college level. It should be a part of the curriculum. It should be a subject. And we have been in the field training so many times. So we have seen the problem is that for 2 days, they will be like, okay, for 2 days, they will be enthusiastic. They will remember how to do it. After 2 days, as the memory fades away, then they will be not confident. So repeated training, repeated effort by us, not by them. We have to take the efforts to educate and have a communication and train them so whenever they witness this kind of arrest, they will be confident enough. So how to promote the community BLS? So we have to spread the word, not the panic, and some myth that we need to burst in the society. The common, whenever I went on the fields to teach those society people, or those sheep's people, or what are the myths? So the common myth that I found out that they think that the CPR is only done by the medical professional. And CPR, if you do, it will be a revival of that. That is also misconception. So we have to educate why we are doing CPR, why we compressing the heart, why we want to maintain the circulation, why we want to continue that oxygen delivery till the definitive care arrives, right? They think that incorrect CPR technique can cause the harm. Again, yes, there has to be a correct technique for CPR, but even if you do a correct CPR, it is going to harm the patient. The ribs will be broken, right? So there is no way that you have to start the CPR. So there is nothing like that. Then they think CPR can be done only if there is a mouth-to-mouth resuscitation. No, hands-on only CPR can be done. And CPR, they think it's exclusive for the adults. That is absolutely wrong. So this busting of the myths, as a medical fraternity, we have to be vigilant that we talk to the community and communicate with them. These are the myths that you have to not believe and follow what are the standard protocol. So any innovative ideas anyone can think that how we can improve this community BLS. So like I know this is part of Apollo. Apollo has a very significant community awareness programs being a part of that corporate. They go to the societies, they go to the hospitals, small nursing homes, they teach the CPR there. But apart from that, what else can be done? So we are a very large population. So the one hospital will be catering a very small number of people. But as a community, we are a 150 crore nation. This is a huge country. How will we reach that level that we are going to educate almost 30, 40, reach to that Denmark level? They are 45 to 50% are BLS trained. But at least we can go from 2% to 20%. And how can we improve? Any innovative ideas? So some of them which I thought maybe CPR in your pocket, the technology, their artificial intelligence and all these things. You can have mobile labs, you can have games. We can do a skits, flash mob, CPR. There could be a act done by the emergency department team, a critical care department team, or they can just collaborate, do a flash mob, be at mall, airports, or public gatherings like parks. Parks is a very good place in the evening. I feel, I don't know why there is still not conducting, because if you go in the park, most of the families, including elderly, including children, including everyone will be age group will be there in the parks. So the flash mob can be conducted in the community parks where there will be large people. It would be education as well as entertainment for them, and they will learn something out of it. That's what I feel. Then definitely people don't consider us as influencers, so we can bring some those Salman Bhai or someone like, influencer, and we can ask them to provide the awareness, right? So we can bring the influencers, and then we can do some events like fundraisers for CPR for a cause, and train the trainer model. So recently, 1 week back, the idea came in my mind that I spoke to my society secretary if there can be one mannequin and ambu bag there, if they can purchase from the society fund. If that is there, any Sunday in 15 days, 20 days, you can just take one wing or something and you can train for 1 hour or something like that. We can do that in community. So if we take a pledge and train the 5 people at least, not more than that, and we have a continuous communication with them, talk to them, take a feedback with, then I feel that 5 people we train will train another 25, that 25 can train another 75. Like that kind of awareness can be spread. So train the trainer model can be implemented. So we have to make sure that they are heroes in the community, because they have to act like a hero before the ambulance arrives. So the key takeaway from my topic will be every second counts, and early CPR double or triples your survival chances. And BLS is not only for the doctors, anyone can learn it and anyone can save a life. We have to train the communities. The more lives saved, a well-trained bystander is the real first responder. And you have the knowledge. So I hope everyone will take some effort and try in your community, speak to your society secretaries if you can. Try if they can encourage those mannequins. There is one mannequin is enough, one ambu bag is enough to teach some people. And have some innovative ideas to, make awareness in the community. So that's about my presentation. If anyone have any questions or any ideas, feel free to discuss. Thank you. Yes, sir.
So, my name is Dr. Gunadhar. I am the senior consultant ICU here. So, whatever Dr. Sejal told is absolutely very, very important. I'll just tell you 2 small stories. Like, it's a fact actually. So, one patient, this is a real patient who came to us. He was a football player actually. He collapsed in the field, nearby field in the Apollo hospital. Almost all his friends, but none of them belongs to medical fraternity. They tried to save him. I think somebody was seen some videos from the net and they have given a CPR. And fortunately, almost after 1 hour of CPR there, then he reached here. Then he was undergone impella assisted angioplasty. He's a young guy, 35 years. Almost first time when he came to the ICU, we thought that there is a hypoxic brain injury. This patient stayed with us for almost 1 month. Now he is able to do all his routine activity. He is mobilized, he is at home, and he came for follow-up many times. Now the good thing is that his mother is now promoting this CPR activity at Kerala. He belongs to the Kerala. So this is how the importance of this story actually. And another important case I will just quote from one of our OT patient who was arrested. Dr. Pranali is here. That patient has had a cardiac arrest. They have resuscitated him almost for 1 hour. She is an international patient, came from the Mauritius, then she was in the ICU. That patient also for almost for 1.5 months, she was in the ICU on CRRT, ventilator and everything, but now she is fully mobile, discharged successfully to her own country. So this is what the importance of the SCLS and the BLS is. This is just from my side. And the stories are very important because if you promote these stories to the community, probably the facts, they are able to learn better. That's the main thing.
Thank you, Gunadhar sir, for sharing such inspirational stories.
Dr. Sajal for the BLS session. So now we have a interactive session which I was quite advertising a lot, a hybrid talk. So it's all about ECMO and cardiogenic shock. Can I please welcome Dr. Jumana Haji, Dr. Sandeep Gore, Dr. Swardeep and Dr. Gunadhar on the stage. Thank you all for coming. I just briefly introduce all our speakers here. Dr. Jumana is our ECMO specialist from Fortis Mulund. Dr. Sandeep Gore is the head of emergency Fortis Mulund. Dr. Gunadhar and Dr. Swadeep are our senior consultants from the ICU. So, why have we gathered here? Because I wanted to discuss about cardiogenic shock. What have there been changes? What are the recent advances? And should we be treating cardiogenic shock as we were before? So the topic is stop doping the heart and life on ECMO. My first question is about cardiogenic shock management. What has changed? Do we use dopamine, dobutamine, or we go to the vasopressors like NORAD, vaso, and adrenaline? I would like Dr. Gunadhar and Dr. Swadeep to tell us more about cardiogenic shock. So many times we are receiving patients treated from outside on dopamine, dobutamine infusion, not maintaining stable hemodynamics, already diagnosed with cardiogenic shock. How should we go about treating that patient in the ER so that the patient is stabilized rather than following the old guidelines or a new guideline? What should we be doing?
So better than guidelines, I'll just take some few practical points. Basically, so the cardiogenic shock is different from the other shock because here initially the patient may looks very stable, but the deterioration is very rapid. By the time the patient comes to the ER, you find that he was looking okay, the BP is around 120, pulse rate is around 100, the lactates around 2, 3, but suddenly you find in an hour, suddenly the BP crashed, the patient was breathless, tachypneic, and his lactate has gone up to 10. So that is the reason here you don't have a time actually. Your anticipation is more important. That is one thing. So when the patient comes, you have to see at what stage the patient is, like whether the patient is in the early shock, whether the patient is in progressive shock, or whether the patient is in refractory shock. So most of the therapies in the refractory shock, they don't work. So that just forget it about the refractory shock because whatever you do the best, even if ventilator, ECMO, everything, the patient is not going to survive. 50% of the patients in the ER, they came in the stage of refractory shock where pressures are very low, patient is on high dose of inotropic support, he's on ventilator, the lactates are almost in the range of more than 10, severe metabolic acidosis. So sometimes the efforts are futile. But you have to actually treat the patient in the early shock and the progressive shock. So first of all, when the patient comes, you have to just do the basic management, assess his airway, breathing, circulation, do an ABG, do his metabolic panels, see whether the patient is in pulmonary edema, whether the oxygen saturations are low, intubate him, ventilate him, and do a resuscitation, do an echo, ultrasound, do an 2D echo to look for the IVC collapsibility or fluid responsiveness, do proper inotropic support. Noradrenaline is the first choice, in fact, I can tell. And if the patient is still on severe vasopressor, you start with adrenaline. Then do sometimes 30% of the cardiogenic shock patients are fluid responsive, so don't be under impression that you cannot give fluid. You can sometimes give fluid. If a 2D echo, you find that the patient is fluid responsive, sometimes you can give a fluid, but most of the times they are not fluid responsive. Early inotropic support is very important. Then early intubation, ventilation is very important. And the most important thing is treating the cause. So the treatment of the cause is take this patient to the cath lab and do a proper revascularization, whether that primary angioplasty sometimes very helps. But if you don't find that the patient is stable, then in the ER itself, you can start with the ECMO support or put the patient on the ECMO and take the patient in the laboratory. Inotropic supports, Dr. Jumana is here and she is an ECMO specialist, he can have a highlight on that. But what I mean to say, the basic things is very, very important. Do a standard inotropic support, go for noradrenaline, adrenaline, and if still the inotropic supports are too much, there is a severe LV dysfunction, sometimes you can start with dobutamine and then shift the patient as early as to the cath lab. That is very important. Your time is very, very vital. 30 minutes and 60 minutes, what you have just seen, the door to balloon time and the door to needle time, that you have to achieve the goal. Then the patient's improvement is dramatic, I can say. Yeah.
So there are 2-3 things probably, like Dr. Gunadhar has highlighted the importance of early identification of the cardiogenic shock is very important, which is extremely true because cardiogenic shock doesn't only happen, somebody develops, suppose, AMI and goes in a cardiogenic shock. It's very commonly seen somebody with even viral myocarditis gone into cardiogenic shock because of these poor LV functions. So it's very often seen. So not even cardiac cause, some systemic cause can also lead to the cardiogenic shock kind of scenario, and which is not very uncommon. The first thing is a very high index of suspicion is to identify the entity. The bedside echo is very good entity, very good tool to identify those things. We can quickly identify the LV function, RV functions, LVOT, VTI, and all those things we can do. And then we can identify whether the cardiogenic cause is a predominant cause as an or etiology for the shock in that stage. Now, traditionally, we short to all these vasopressins or dopamine or dobutamine or milrinone or noradrenaline to anybody who comes with low blood pressure. We try to resuscitate fluid, not responsive. We short out to any kind of inotropes, vasopressors and all. But in current days, probably it is very important to understand that any kind of shock stage, it leads to a multiple organ dysfunction. Like it leads to liver dysfunction, it leads to acute kidney injury, it leads to so other organs very quickly affected. So most of the time after the cardiogenic shock, even though the primary pathology gets reversed, people keep on getting prolonged because of this multiple organ involvement, multiple organ injuries. So one of the current modalities at this moment of time that we have is that suppose somebody with a Kiliff class 4 or somebody with a SCI grade 4. So those kinds of patients we should just quickly identify, and they can be quickly given some amount of mechanical circulatory support device, be it with anybody, be it kind of ECMO or can be kind of any other ventricular assist device or anything, which can quickly reverse the hemodynamics, take care of the hemodynamics so that the other organ dysfunction can be prevented, mitigated, minimized as much as possible. And again, we need to understand. So when heart is injured, so with the help of all these sympathetic stimulators like adrenaline, noradrenaline, all these things, what are you doing? We're just trying to make a weak heart beat more. So effectively, we are not giving heart any rest. So all this mechanical circulatory assist device probably help heart to get some amount of rest at the same point of time, having control of overall hemodynamics, so that we can prevent the organ dysfunctions in the other systems like be it liver, be it kidney. So those things can be done, and that is why probably Dr. Jumana again will be able to tell in a better way probably at what point of time she does, because she is a very proponent of the ECMO. We probably do not start ECMO very early. Most of the times we keep on tend to wait for people going into 2 inotropes, 3 inotropes, already on CRRT, and then we sometimes think of going on ECMO in most of the centers. But if we can have a mechanical circulatory support device early and prevent organ dysfunction and prevent all this requirement of RRT and everything, probably that is a kind of new things probably that is coming.
So basically coming to the question, how will you start off and where the role of these inotropes and pressors come? I would like to start with, we always want to do conventional first because that's what we know best. So we cannot do eCPR before good CPR. We cannot do ECMO before even trialing conventional methodology that is tried and tested. I think more often than not, we fail when we think any kind of ACS or heart failure as a left heart failure only. It's not, of course, the cardiac pump is your LV, but there is a whole preload to it, which is your lungs, which is your RA, RV, and then your, the vascular system. So where your problem started is very important. And depending on, so if it is only an isolated LV failure that you're looking at, you may get away with, certain conventional methods, quickly opening up the coronary and undoing the cause. But if it is advanced to a biventricular failure with your lung impaction, then you don't have that much. Then also, that's where what you choose is important. So now coming to what are the causes, whenever a patient does land up to you with, they usually present with cardiorespiratory arrest. You will have a patient who, if intubated, will be on 100% FiO2. You will have a patient who will be on triple inotropes, and we really don't know what we are treating at that point. So if you see left heart coronary artery disease is one of the major causes that comes to our mind, and this is where all the evidences have come from, that, mechanical circulatory devices don't work in an emergency, probably Impella will work, IVP has been disproved. But the problem is that what is available to us as a tool immediately, what we can do. And we are the people in the ER who are seeing the patient, like Dr. Gunadhar said, in a window when they have come walking to us with a lactate of 2, with with hardly any inotropes on board. And then within 5 minutes or within an hour, they are on triple inotropes, and within 4 hours, all the end organs are failing. So that window is what you as the community, or you as a medical community, have to capture, and that's why you are in the best. Now, if you see this whole, causes of circulatory failure, and for me, ECMO is for circulatory failure, not just for a heart failure, because ECMO does not help the left heart, it helps the right heart, it helps do the job of the heart, but it does not directly help the left heart. So what are we trying to support? We are trying to support the circulation, and that's where we come to what is the cause of the failure. So if it is a left LV failure, opening up that coronary is of paramount importance, and if the patient is too unstable to take to cath lab, that's when you have to add a mechanical circulatory device, or instead of just going up on inotropes, because NORAD has a very wide range. You can go from 0.5 to 0.3. Adrenaline more than 0.05 is going to just cause harm, right? But that's what is going to directly help your pump. Milrinone causes vasodilatation, and you can never use it in an acute cardiogenic shock. Dobutamine, again, the peripheral vasodilatation is very unpredictable, and milrinone and dobutamine help better with right heart failure. But can you use it in an acute shock? You can't. So what do you have in hand? Noradrenaline, and if you suspect an additional septic element, you will probably add vasopressin, which is now more and more being used even in cardiogenic shock, because it doesn't seem to cause pulmonary vasoconstriction vis-a-vis NORAD. So you are in a little better position. But then, if supposing it is not RV failure, it is it's not LV failure alone, it is biventricular failure because of viral myocarditis, as Dr. mentioned, or malignant arrhythmias. So patient is presented with arrhythmias, or it is a stunned heart because of primary LV failure, or because of a drug overdose or hypothermia. This particular cohort is the best for ECMO. So if a patient presents with this kind of a picture, immediate VA, peripheral VA ECMO is actually going to be a 4-day run with the heart coming out of this initial shock, you being able to do interventions and carry on. Now, again, if you are on high ventilator support additionally because of pulmonary edema or because of the underlying problem being a viral pneumonia plus viral myocarditis, then again a VA ECMO or a VA plus VV ECMO of some sort may be the best place to go. Problem comes in this cohort where there is a peripheral vasodilatation, where dengue shock syndrome, septic shock, acute liver failure, toxic shock syndrome. This is a very difficult cohort to treat with a peripheral VA ECMO. Again, my stress is treat with a peripheral VA ECMO, and you cannot throw it out of the ECMO out of the window for these indications as well, because there has been proven survival in certain well-selected patients. When I mean well-selected patients, dengue shock syndrome is a very difficult thing, and I wouldn't go there because they are hemorrhagic, they are peripherally very vasodilated. You will never get enough flow to your pump for it to be able to function as a peripheral heart as well. But if you take septic shock, the evidence is that if you do a central ECMO for a septic shock, then you will have very good survival, because you will have enough flows and it's a foolproof thing. But can you do central ECMO in an ER? You cannot. So then you have to check whether there is a cardiogenic element. So that's where your echo comes into place. And that's where you look for, whether your patient is going to benefit. So if you have a mixed cardiogenic plus septic shock, then a peripheral VA ECMO does the job. So you should consider them. Acute liver failure, when their presentation is basically cardiogenic shock rather than coagulopathy, and in these patients, actually these are the patients who may become a bridge to liver transplant, because now you have pulled them out, stabilized them enough to be bridged to liver transplant. They're not knocked off the list because they are deemed too sick to transplant. So in all of these, especially septic shock and acute liver failure, it is a multi-disciplinary call to put ECMO and the configuration that will work, whether it's just a plain, and many a times in this you require hybrid configurations like VAV or VVA, depending on what are the flow requirements. These are basically respiratory indications, but still many of these patients will come to you with hemodynamic instability, like patient has come with status asthmaticus with hemodynamic instability. Here, because of the high intrathoracic pressure. Here, you're trying to intubate the patient, worsening these are actually patients who are bridged to VV ECMO awake. Yeah, the hemodynamics improve, their gas exchange improves, and you buy time to improve this thing. Of course, we know this cohort, and that is pure VV ECMO. But then if you have a patient with pulmonary embolism and hepatopulmonary syndrome. Now, pulmonary embolism is a very interesting cohort. You can treat them without ECMO. In Michigan, there is Ann Arbor, there is one institute which puts all patients of pulmonary embolism who come with refractory shock directly on ECMO. They don't thrombolize because post-thrombolysis ECMO causes a lot of bleeding. So they just put directly on ECMO. Then they wait for 3 days on a stable patient to see whether it dissolves, whether it requires, then they do catheter-mediated procedures to resolve the thrombus, and very few percent, and their survival rate is close to 85%. So this is like a very well-oiled institution which is doing this one-off. This is controversial in our Indian setups, where again I say, do what is conventional, do what you're used to first, but don't lose the window. Why do the trials for ECMO fail? Because most of us are offering ECMO when your lactate has crossed 10 and inotropic score of more than 32, which is a very late window actually. So if you catch them in category C of heart failure, you are more likely to be able to salvage these patients with a short ECMO run. And cardiogenic shock is beautiful. You can save a patient, you can bridge a patient to recovery, you can bridge a patient to a device, you can bridge a patient to transplant, and quality of life after all these is good if you don't have any complications related to it. I think you want to add.
My next question is to Dr. Sandeep Gore. He's been telling me again and again to keep it problem.
Yeah. You can ask.
So, we discussed several times to keep this discussion based on how we tackle emergencies in the ER and how the role of ECPR and ECMO in ER is, the futuristic ED, how it's going to develop in the future of the emergency department. So, sir, what are the patients that we should be identifying very early, recruiting them for ECMO? How do we activate that code? Do we have a special code in the hospital which actually just announces that, we need an ECMO in the ED? And what biochemical values, important values, do we need to look out for, which actually activates that before time, and so that we don't lose a life in the ER?
Okay. First of all, congratulations to Nitin and team for organizing another wonderful CME at Apollo and keeping this particular session, that ECMO. And I will be talking about ECMO in emergency department. Is it relevant? 100% it's relevant. Future of emergency medicine lies in ECMO, I am telling here. One speaker from Japan, one emergency physician from Japan who came to Apollo Hospital on an ECMO national conference there, held at Hyderabad. He has shared some statistics. One of the statistics is that 50% of cannulations in ECPR done by emergency doctors in Japan, and 50% are done by cardiologists in cath lab. Okay, and so that has means emergency department has that much big role to play in ECMO and ECPR. So if it can happen in Japan, it can very much, it can be happen in here. We are competent emergency doctors, we can do that things. So before starting this discussion, I would like to refer to two studies to you. One is a Cheers trial. You write down and you read this thing, Cheers trial. Okay. Refractory cardiac arrest. If we are doing a cardiopulmonary resuscitation in refractory cardiac arrest, what is refractory cardiac arrest? Cardiac arrest means by doing conventional CPR, you are not achieving ROSC within 20 minutes of starting CPR. That is called as refractory cardiac arrest. In that refractory cardiac arrest, if we put that patient on ECMO, means that is called eCPR. Okay, then there are very great survival benefit. Otherwise, what will happen if you do 20-25 minutes CPR now? What will happen if patient, severe MI patients came to emergency department, and as soon as he came to ER in arrested, or patient comes to ER in arrested state and arrest rhythm is ventricular fibrillation, you are doing CPR, 20-25 minutes CPR, and the patient is not revived, what you will do? Okay, it means generally if we don't think for eCPR, then generally we declare the death. Okay. But at the same time, after 20 minutes of refractory arrest, if we convert it into the eCPR, the chances of survival are 50% by the Cheers trial. Okay. If we are doing, means we have to do proper cardiopulmonary resuscitation. That is very paramount importance. And after 20 minutes, if the patient is not revived, then we should go ahead with the eCPR. And in that, according to that trial, 50% patient who undergone eCPR survived. Means I will tell in different language. ECMO will give 50% chances of survival in those patients who have otherwise 100% mortality. Okay, so we are working in emergency department, it's very common. MI patient arrested, refractory cardiac arrest, patient is not reviving. We have done 20 minutes, 25 minutes. What next? We have to go and think for eCPR, and for that, emergency medicine doctor should be aware about the ECMO, they should be aware about the techniques like cannulation, they should be aware about this ECMO machine and this technology. Okay. Another trial, arrest trial, I will recommend you. Arrest trial, you write down. This also says that it shows that those patients who have undergone eCPR, 43% survived. Survived means they are neurologically good outcome, like that. So these two things. And recent one Spanish study also came. So they have shown that 36% survival, 30% patient will be used as organ donor. So otherwise in that patient, 66% patient we can utilize. 30% will survive and 35% patient can be used for organ transplant. That study was published on 2nd August, a Spanish study which was published on eCPR on 2nd August 2024. Another initially, I think initial we have discussion of patients coming to emergency department with cardiogenic shock. Extensive anterior wall MI, cardiogenic shock, frank pulmonary edema. Okay. Okay. In that situation, sometimes even intubation can kill the patient because whatever the heart activity is going on due to adrenergic drive. And in Phillips class 4, mortality is very high, 70 to 90%. In that situation, some very good studies came from Taiwan and Japan. They have recommended that rather than door to balloon time, door to offload time, a patient with acute myocardial infarction when comes to emergency department in cardiogenic shock, Phillips 3 or Phillips 4, and BP is not recordable, cardiac index is more than 0.8 and it's not responding to the dual inotrope. In that condition, taking this patient in means cardiologists may sometimes say that this patient is not stable enough to take in cath lab. It do happen. Okay. So in that situation, the new concept is a door to offload time. Means we have to put the patient on arterial ECMO and then we should taking the patient to the cath lab, and that has shown that survival benefit of very good survival benefit of 70 to 80%. One more that I don't know how many of you saw this aluminum phosphide poisoning. Aluminum phosphide, within 24 hours patient go in cardiogenic shock and patient dies. Very, very deadly this thing. So in that situation, if patients, these patients come by walking to emergency department. These patients come to walking to emergency department and patient in shock, and in 24 hours patients go deteriorate and patient got arrest. In that situation, putting the ECMO in emergency department has shown, means otherwise mortality is 90 to 95%, and by using the ECMO mortality reduced as less as 10 to 15%. So this one study happened at Chandigarh. Dr. Vivek Gupta, he's doing very good work in ECMO. This particular study, I think I recommend you go and read this study. So there are lots of opportunities these things. So your next question that how we determine. So Dr. Jumana is with us, and we have primed all our emergency doctors for this ECMO. We just catch the patient in right window. Means we try to catch this patient. A couple of ECPR also happened in emergency department. So we have to catch those windows. So those recommended. First patient of ECPR which we saw attended in emergency department was a patient of severe myocarditis, 18-year-old girl, severe myocarditis, tuberculous myocarditis, whose lactate is 18. So we planned for VA ECMO, but that patient got arrested. We converted into the ECPR, and that patient, 7 days patient was in ICU, and she discharged by walking. So these changes, dramatic changes can happen if we use this technology appropriately in emergency department. If you are thinking that, ECMO nothing to do ER, no, ECMO has to do with ER. When ECPR comes, that place happens. The place of arrested patient will not go. Patient will not present to ICU in arrested state. Patient will present to ER in arrested state, in shock refractory, or sometimes patient may get severe shock patient of cardiogenic shock like a severe myocarditis or postmortem cardiomyopathy. Severe massive pulmonary embolism, like that patients come to emergency department. So that managing these emergencies is a race against time. So we have to take time-bound decision. So entire team, we have to be very much aware about which patient we can look into these things, financial counseling, everything should happen very quickly. Generally, we haven't made any code for ECMO so far, but if we find out such patients, so we call Dr. Jumna, if I'm not there, they call me and we collectively do these things, but it's a good idea. We can do one code also for these things, but it's good to have that particular these things. But first thing is that there must be emergency medicine doctors. I am using, don't take it otherwise, there should be literate about this ECMO technology. Okay, they should be knowing where to use, how to cannulate, and how to choose this machine dynamics. I strongly recommend it, whenever possible, do read these things, attend some courses, go ahead and pass one ELSO adult ECMO certification exam, and if you pass, then you can start using these things, because earlier you start, you will be the change maker. And it's not difficult at all. We are all intelligent people. If we decide to do something, we can do these things. So just these things, this purpose of this particular session, if concepts of ECMO and if interest in ECMO, if igniting in your mind, I think that will be the purpose which we could achieve through this particular academic activity today. I think so.
So just to extend on what she asked, which are the patients how will you kind of work up to say that we want to go for ECMO? So whenever a patient comes to you, like I said, they will have cardiorespiratory arrest kind of picture, and you always have an ABG handy. Most of the Western literature goes by a PA catheter. So all their shock calls, like we talk a lot about shock teams. But for us, what practically we do is an ABG. We send off the baseline labs, and then we do a echocardiography. So I think this is also enough, and what my algorithm would be that if on your ABG you have predominantly metabolic acidosis with a lactate which is fast going up between the first and the second ABG, this is the rate of escalation. Your inotropic score, more than how many inotropes are on board, how fast they have gone up is more important. And what is your PF ratio. So if your PF ratio is still more than 150, you are maybe looking at a single organ. Then you look at your investigations. So you look at the echo. Specifically on echo, you are looking at your LV function, yes. Your LVOT VTI less than 20, your cardiac index less than 2.2, or your in a patient who is otherwise okay, they decompensate very fast. LVOT VTI less than 10. RV function is very important. So if you find a dilated RV with a flattened septum, you are looking at biventricular failure. Then you should think more quickly about ECMO compared to pushing with inotropes. You look at the aortic valve because aortic valve kind of becomes, if it is stenotic or regurgitant, becomes a contraindication for all kind of mechanical supports. So if you have any aortic pathology, then you will have to really think differently. Otherwise, you have ruled out contraindication, go for ECMO. Your X-ray chest will tell you how many quadrants involved, whether your lung is involved as well as not. If your creat and your SGOT, SGPT or just basic drop in urine output will tell you that you're going into a multi-organ failure, which means the time to act is now, not after the patient gets transferred and after 5 hours or after intervention. If you can get a CBC in time, you at least know that the platelet count is okay, what is the septic element. And if you have a VBG, cardiac output is an indirect, SCVO2 is an indirect marker of your, but this is again from a PA line, and we don't do PA lines routinely, even in intensive care, forget in ER. So let's go by basic investigations and PF ratio. If your PF ratio is okay, patient is still on 2 inotropes, then you add an IABP as a third inotrope. You know, it's more like let not the score go, the inotropic score to go to that extent that it starts harming, that it starts causing kidney shutdown, start causing peripheral shutdown. But if you are already seeing signs of peripheral shutdown, multi-organ failure setting in, lactate more than 5, I think you should be already aiming for VA ECMO. If you do this algorithm, this is your shock call. Call your, activate the mechanical circulatory support pathway. How many of you all have an ECMO pathway in your hospital? Do you know the person you have to pick up the phone and call that I want an ECMO now? You don't. So that's the first thing to establish. Like he said, he calls me, I activate the rest. The rate limiting step is not the machine, not the consumables just now, but not the consumables. If you are a transplant center, you will have some consumables lying. The rate limiting step is the counseling, is the patient counseling. So in our hospital, what we've done is we've created a SPOC for that. He takes over, I counsel the science and hand over to the SPOC. When the family says, I just say broad figures. It's going to be this much and this much daily cost. And then if they say, okay, give us more details, and they are not completely averse to the idea, I tell them, patient needs it now, so I'm going to go ahead, you speak and you sort out. Okay. Now, so that becomes a rate limited step. So these need to be stratified before you think eCPR. If you're not thinking eCPR, you're thinking just ECMO in ER, that's a better thing to do at this point when you don't have pathways. Think early. Patient walks in, eyeball the patient, know he's going to just go down by the time even he reaches. Activate the whole pathway. Tell your intensivist, tell your management, this kind of patient has come, please sort out, he will need mechanical support. So picking up these concepts early, because if you are an ECMO-enabled hospital, now it's a 2A, 2A recommendation to go down the ECMO pathway. Very soon, we are actually introducing DCD, so he touched upon organ donation internationally. We are currently working, and very soon ISCCM will release, I think in ISCCM we will be releasing, the NRP pathway, where you put a patient on ECMO, then if the patient it's futile and the survival is not going to be there, but your ECMO has stabilized the end organs, you then use the ECMO for preserving organs, and that's a whole donation after circulatory death pathway. So a lot is happening, and the time to act is now. And because the door to offload time, the important thing is that ER gets involved and cath lab gets involved. If these two key players are hesitant to cannulate, then we will not be able to have shock pathways or anything, because in intensive care, we've already sometimes lost the window in both cath lab as well as ER. So many times in cath lab, the maximum device that is put is an IABP, and once the patient comes back, we are still kind of, struggling with the lactates, with the multi-organ failure, and then the heart improves, but the patient is in acute liver failure and dies of liver failure. So we have to, in these patients, we have to stay one step ahead of the pathology and not let things develop.
Can I have just one comment?
Sure, of course.
So rightly pointed out by Dr. Jumana. So always in the ER, it is the VA ECMO. Okay, so most of the times the VV ECMO for respiratory failure, we start in the ICU, that you have the time actually. But what she pointed out, cardiologists are your best friend. Intensivists are your second best friend. Take help of your cardiologist. If any doubt for cardiogenic shock, particularly if there is a ECG changes, patient is in shock and the shock etiology is predominantly cardiac, even if the patient is on high inotropic support, ECMOs should always come to your mind. That is the most important thing. And your team, you will see you are not the alone person, so you have to take a help of a team. So always activate your team, and whoever the appropriate persons, I think 50% of the jobs are being done by a cardiologist only. They will tell you, boss, see, this is a cardiogenic shock. You activate your protocol, put the patient on ventilator, start ECMO, and do whatever the best. So take help of your teams and do the needful in the ER at least. Because the cardiogenic shock, you see, the survival is very, very important. Maximum patient they can survive with proper support. And your time is vital. You don't get much time, but your survival is definitely improved if you give the right support system, ventilator, ECMO, inotropic support. So that is what the crux of the story. For VV ECMO, for respiratory failure, if the predominant pathology in the lungs, you have a sufficient time. The patient will first got intubated, come to the ICU, we do them prone position, then we think of your ECMO support. So those are the different issues. But cardiogenic shock, do not miss the time, do not miss the window. That is what the crux of the this whole discussion is. Yeah.
So one of the, I think you have told rightly, most of the time ECMO gets, the discussion gets stopped at the time of rate limiting step that you have mentioned is the counseling part. Because yes, we also face a kind of lot of problem like ECMO could not be done because the financial problem and all those things. So that we see, but if we see that the overall cost of running an ECMO and then salvaging a patient, sometimes, and if we compare it to somebody who we didn't do an ECMO, he doesn't survive again. There is a kind of end to that place only. But suppose the patient survives and remains on CRRT for 5 days, ventilator for 6 days. And so ultimately the cost becomes same. Rather, somebody comes with an acute myocardial infarction. First of all, the patient needs to be revascularized as early as possible. If at the time of revascularization, the patient goes arrested, developing VTAC, the cardiologist is not able to do his job properly because the patient is extremely unstable, the best thing probably put them on ECMO, stabilize his hemodynamics, take control of the hemodynamics, do the appropriate revascularization, send them back to the ICU. Probably all this cascading effect of the multi-organ dysfunction can be prevented. So ultimately, if you see the cost-wise, probably keeping somebody on ECMO for 5-6 days and then taking decannulate after cardiac stabilization probably becomes much more cheaper than having a.
I'll just add a point here. Having said that, see, there were times when we used to feel that, for eCPR, let's keep a very low cost for initiation. Let's just do it in 1 lakh, 2 lakh, all doable. But the fact remains that these patients have suffered from a downtime. They've had all organs impacted. They will require change of strategies. They will have complications because we are doing it as an emergency procedure. They will require CRRT 9 out of 10 times. So if you're trying to save the patient's money by just cutting down on the ECMO initiation cost, you're not doing anything great, because what will happen is patient will say yes for ECMO and then will withdraw care immediately. So actually, what Dr. Sandeep said was correct. Get yourselves trained in indications for ECMO and be able to spot a person and know exactly how to go about it, because unless you don't have courage of conviction in the technology, you cannot convince the person across. Like my conversion rate for patients is 100%. They will pay that 5 lakh, 6 lakh on the spot in the middle of the night, and then next day they'll come back and say, oh, but we didn't realize that the intensive care cost for this patient per day is going to be 2 lakhs. And that you still cannot give us care. So then the extended family comes in. So the person on the floor will always agree for eCPR, especially if it is a young patient. But your counseling has to cover what's going to be the ongoing cost, the fact that you may not be able to get the distal limb cannula, you may have to change strategy. So don't try to save the patient's money. Like our intensivist always says, you can save the patient's life or you can save the patient's money. But your counseling has to be very comprehensive. You have to talk about the cost, you have to talk about the science, you have to talk about why there are no guarantees and why there are complications. But at the same time, like he said, even if you have a survival rate of 30% or 20% with ECPR, that's 2 out of 10 post-cardiac arrest patients going home, which is a big number, plus going home with intact neurological faculties, because definitely the out of the 30, the international survival is 30% post-ECPR. But in them, the number of patients going home with better neurological recovery is almost 70-80% of those 30%. So that is what we are aiming at initially. Plus, do cherry pick your patients. Get it down to patients who will definitely do well with ECPR. Otherwise, wait to achieve ROSC and then strategize. Buy yourself time, because it is a big endeavor to take. And even if this patient survives, ECPR se survive hua, then limb complication hua tha after 10 days or nothing, secondary sepsis hua, critical illness hua, after 40 days the patient dies, it is still an ECMO death. It is still an unsuccessful ECPR. People will not see that the patient actually survived because of the ECMO to get on to, the rest of the spectrum of things that happens in intensive care.
Thank you so much, ma'am. I think we need to conclude. I just want to tell my conclusive statements that there's a role of a CPR team and an early recognition which the emergency doctors have to do. Call the specific people, the perfusionist, the intensivist, the surgeon, and get the ECMO started so that we can save a life before it's too late. That's all I wanted to say. Thank you so much. It was a pleasure having you all.
Thank you for inviting me here. And it was a real pleasure talking to emergency medicine physicians.
Okay. Can I ask Dr. Brajesh to come on stage, please, to felicitate everybody?
So he's our cardiologist?
Yes, he's our interventional cardiologist. He also has a next talk. Ma'am. तो चारों को दे डॉक्टर स्वदीप डॉक्टर गुनादार Doctor sir. So we come on to the next topic, which is again a case-based discussion. We all have encountered patients with bradycardia, right? Like no matter how much you pace, that heart refuses to race. So what do we do in that situation when you have all the hemodynamics failing, your heart is not pumping, you are trying to jumpstart the system, but it's just not happening? Do you select transvenous or do you select transcutaneous? So we would like to call upon Dr. Brajesh Kanwar, our senior interventional cardiologist, and Dr. Nikhil KV, our third year DNB resident. I hope you're here.
A warm good afternoon to everyone. I'm Dr. Nikhil, DMB JR3 resident at Apollo Hospital Emergency Department. I welcome Dr. Vijay sir to this discussion. So I know all of you are hungry and most of you are angry also. So to start with, the lunch is to the rescue after 20 minutes, but as of now, we'll go with the pacing to the rescue in our unstable patient, okay? So before delving into the gray zone, let's just brush up the basics of transcutaneous and transvenous pacing. So as we know, transcutaneous cardiac pacing is a temporary method of pacing that might be indicated in patients with severe symptomatic or hemodynamically unstable bradyarrhythmias. It is particularly helpful in patients with reversible or transient conditions such as digoxin toxicity, AV block in the setting of inferior wall MI, or when transvenous pacing is not immediately available or carries a high risk of complication. Most patients with minimal hemodynamic compromise require a current of 40 to 80 milliamps. So electrical and mechanical capture is the need for transcutaneous pacing. So in an emergency where a patient is experiencing cardiac symptoms or assistole, transcutaneous pacing is the method of choice. But nevertheless, transvenous pacing has the following advantages over the transcutaneous method. Major being enhanced patient comfort, greater reliability, ability to pace the atrium, and the particular indication of transvenous pacing in ED is profound symptomatology, shock, high degree AV block, and sick sinus syndrome. So this is the algorithm of bradycardia as per ACLS guidelines. So if we see, identify and treat the underlying cause, and then if the persistent bradyarrhythmia is causing hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure, then you have to go with atropine 1 mg 3 doses, and then go with, if atropine is ineffective, then go for transcutaneous. Even if that is not there, consider expert consultation and then go for transvenous. So major differences between transcutaneous pacing as well as intravenous pacing is transcutaneous, it can be established easily, whereas transvenous requires at least 15 to 45 minutes to get it done. It is easy to perform and requires a minimum level of training in case of TCP, whereas in case of intravenous, it has a longer learning curve. And in case of TCP, it can be initiated by nurses, paramedics, and doctors while waiting for the expert help to establish transvenous pacing. Intravenous pacing requires cardiologist or emergency in selected cases. Transcutaneous pacing has, it stimulates painful contraction of chest wall muscles as well as causing some chest discomfort, which is not seen in intravenous pacing. Transcutaneous pacing has a 40 to 50% capture rate in some studies, whereas intravenous pacing obviously has a higher capture rate. Addition of sedatives can further cause hypotension in case of transcutaneous pacing, which is obviously not seen in case of intravenous pacing. So in case of transcutaneous pacing, some condition might need airway protection, whereas not necessary in case of intravenous pacing. So going on to the cases, so we had a patient who was...
I just wanted to say a few things. What is more important is what you are comfortable with. I mean, when you talk about putting a temporary pacemaker in emergency, what line to be put, whether you wanted to do a transcutaneous or you wanted to do transvenous, it all depends upon the situation. For example, suppose a patient lands with a bradycardia and my friend is trying to do a transcutaneous pacing. If there are two people in the emergency department, one can definitely start a line. You know that the failure rate is almost 50% with transcutaneous. Not always you get success, because there are issues like it may not capture it. You may have a phantom wave. You may be thinking it is a true capture, but actually it's an artifact. And it all depends upon a patient may have an underlying emphysema. Patient may be obese. Patient may be a female, with large breast. You cannot pace that, So these are the situations. So whenever you have a patient with a bradycardia, of course you can give atropine. You can start something like an isoprenaline, 1 ampule isoprenaline, 2 mg, dilute it in 50 ml, start rate between 1 to 5 ml per hour. That is how the rate you started. Simple to remember, 2 mg, 1 ampule of isoprenaline, 2 mg, dilute in 50 ml saline, start at between 1 to 5 ml based on the response. That is what you do it. So now, one person is doing a transcutaneous pacing because the patient is going into severe bradycardia. The other person can put a central line. Now, what is important is what you are comfortable with. If you know that putting a central line is an easy job, just put a line, put a 6 French sheath or 5 French sheath and take a catheter. Now, what is important for all of us working in emergency department is to be aware about the hardware. Now, use balloon tip catheter. Never use a straight tip, the one which we routinely use it. Always use a balloon tip. Because in a situation when there is a bradycardia associated with inferior wall MI, where the RV is infarcted, you can cause perforation. So we have seen people getting perforated. So getting a tamponade. So you try to solve a problem which probably could have been sorted out with an isoprenaline infusion. You ended up in causing a tamponade. So always you should be aware about the balloon tip catheter. Now, I have seen that most of the emergency doctors are not used to that balloon tip. Please make sure that in emergency department you have a balloon tip catheter. It's a life-saving. Now, what is the advantage of balloon tip catheter? You put it into jugular and inflate the balloon, and it will swim into the RA, and from RA it will go into the RV. So it will be an easy job, and balloon tip catheter will not perforate the RV. That is the good thing. So please make sure you see the device, you see that how the balloon to be inflated, how much air to be pushed in. You push it more air, it can rupture. The balloon can rupture. So that hardware knowledge is important. And which line to start, it depends upon how good you are in starting. Suppose you have no experience of putting a jugular line, you can put a femoral, you can try femoral. And femoral with the tip of the, usually the TPIs comes like this, isn't it? All temporary pacemakers. So when you put it from the femoral, keep the TPI like this and then proceed it. If you keep it like this, it'll go to the branches. It'll go to renal arteries, it'll go to the SMAs, celiac like this. So keep it like this vertically and then go. Probably you have a chance of reaching the RA. So that is a few tips which I wanted to share. Then, let's go to the case. So important is to identify the phantom waves, which are actually the artifacts when you do a transcutaneous pacing. Transcutaneous pacing can have issues because it can burn the skin. So actually the transcutaneous pacing was started in 1950s. Why it got discarded? Because of the side effects. It can burn your skin. With new good pads available, new patches available, it has again taken, people are using it. Of course, in our emergency also we used it. So, go ahead.
This is a patient who presented with chest pain, and on evaluation, blood pressure of 80 or 40 mm is recorded. ECG revealed complete heart block, and there is a significant history of pericardial effusion. Now, further arrangements are in place for invasive pacing, but how should the patient be approached in case of ED? So, should we apply transcutaneous pacing and then shift the patient, or should we approach the
So
pericardial effusion first?
in this case, probably patient has got a chest pain. I feel that this patient has an underlying acute coronary syndrome. There may be an inferior wall MI in this patient. So what is important is for me giving an atropine, starting an isoprenaline infusion. What is the age of the patient?
This was 70-year-old man.
72 years, probably the compliance of the chest may not be good. So I will, if the cath lab is already occupied, if the heart rate is somewhere above 40 and patient is maintaining the BP after starting your inotrope or giving an atropine or starting the isoprenaline, or I will not be putting a transcutaneous pacing because that will further cause discomfort to the patient. If possible, what I will do is put a jugular line and put a balloon tip temporary pacemaker. Now, it all depends upon how experienced is the team handling the patient. If you don't have a people to put a transcutaneous pacing, if you feel that the patient is getting arrested, it's time to intubate the patient and all those things, then of course for a temporary things, you can put a transcutaneous pacing. But my advice to you is don't hold on till that. Even if your transcutaneous pacing is working, secure a line so that if needed, if suppose there is a failure to capture, you can put the venous pacing also.
So building upon that, so we know the transcutaneous pacing in condition of pericardial effusion requires a higher joules of energy. It goes more than 100 milliamps. So in this case, in this particular case, was applying transcutaneous and waiting for the pacing to happen rather than shifting the patient with IV in situ. That would have been better.
In our ER, where all of you are so well trained, so usually what we do in these cases, if the patient has come with a 40 heart rate with BP 80-40, you give atropine, start isoprenaline, start inotrope, and activate the cath lab. We are the only hospital, in Navi, Mumbai, who has got 2 cath labs. So invariably, 1 cath lab, you will get it for a PAMI. So in this scenario, if you are working in Apollo Hospital, where facilities are massive, huge support from everyone, you can take the patient directly to cath lab and put a temporary venous pacing. But in a scenario where you don't have that facilities, probably you don't have a cath lab or 1 cath lab which is occupied, transcutaneous pacing will be done here. Will definitely help. But not to stop there, put a center line so that you are ready with a TPI balloon tip in case if it is needed.
Okay.
Yeah?
Okay. So we had a second case where there 80-year-old male with a history of hypertension on telmisartan with recurring syncope at rest. Heart rate was 50, BP of 130 or 70. So this was the ECG recorded wherein it showed first degree AV block with bifascicular block in stable patient, symptomatic with recurring syncope. And apparently there was normal labs and admitted for pacemaker insertion because at that time there was no signs of instability. Now, what if the patient had signs of instability? So do you consider this patient for transcutaneous pacing considering the fact that AV block with bifascicular block usually doesn't work well with transcutaneous pacing? So how should be the approach?
Yeah, so again, the age is 80 years. Probably the chest compliance also will not be great in this case. And patient's hemodynamically stable, except the heart rate is 50. So what my aim will be to stabilize him by giving drugs like atropine or isoprelin. I'm going to, probably this patient is a candidate for a permanent pacemaker. I am going to take this patient to cath lab and put a jugular TPI. For me, transcutaneous pacing will not be a good idea in this case, especially because I don't know the patient will tolerate it or not. It may require an anesthesia. You end up in intubating the patient. And by seeing the rhythm right now, except that the first degree AV block, bifascicular block, definitely with the heart rate 50, I think I can manage this patient well with my medicines as well as with jugular TPI, rather than putting it. See, I think the transcutaneous pacing should be used to by the time. Should used to by the time. You know that there are 50% chances of capture, failure. You know, you cannot be offering it as a whole soul therapy in bradycardia. You buy the time, and the time you got it, put a transvenous pacing and settle the case.
So we had another case wherein 80-year-old male with a history of hypertension on Ramipil with 1 week of fatigue and shortness of breath. Heart rate was 70, BP of 170 or 70. And the ECG showed second degree AV block with 2:1 conduction, likely infranodal because of the bifascicular block in symptomatic but stable patient. They were normal labs admitted for observation and progressed. So during the admission, the patient progressed to third degree AV block with junctional escape, and then it required pacemaker. So in this case, we know transcutaneous pacing doesn't work well with the higher degree of block. And considering the experience, we, as you've seen in the last case, you could predict that which patient can go into higher degree of block. So how should we approach this patient in particular? Should we consider the early pacemaker or should we?
So this is something like a high degree AV block. You can see the patient is going into 2:1 and then there is a third degree AV block. It's an ideal candidate to go for this thing, but please rule out electrolyte abnormalities as well. Patient is on ACE inhibitor, rule out potassium and all sorts of things. Now, you can have the same scenario, patient coming to you in ER with 0 urine output and the ECG showing hyperkalemia. Then how you will approach? That is one thing probably need to be discussed more. What soda bicarb will you give it? Will you give a calcium gluconate? What are the medical management? See, not always the patients are ready for interventions. So, of course, you can have the use of transcutaneous pacemaker or jugular venous pacing, but also to look for doing an ABG, looking for the potassium levels and trying to correct it. Those things also should be kept in mind. By seeing the age, by seeing the ECG, it looks like this patient will need a permanent pacemaker. But of course, the other causes should be ruled out. For example, electrolyte imbalance, probably an angiogram also need to be done before putting a pacemaker.
So that's it for the case. Direct question, sir. What are the key strategies you have developed for confirming capture?
First of all, see, whenever you are pacing by transcutaneous pacing, what is important is when you do a transcutaneous pacing, the QRS usually you get is very wide QRS. Basically, why it happens is because you are directly stimulating the ventricle. Your electrical impulses are directly stimulating. Sometimes what happens, as I said, there is a possibility of phantom wave. Phantom wave means what? The electrical impulse is passing between the two pads. They are not reaching the heart. So in that terms, if you see the ECG will be of narrow complex. It will not be a wide complex. It will be narrow complex ECG. And then, of course, you can palpate the pulse. If the pulse is not palpable, that means there is a pseudo capture. So that is a scenario. You need to increase the amplitude. You need to increase the output of your pacemaker. So that is what is important. And for venous, you need to check where is the position. Whenever you put a what pacemaker, temporary pacemaker we do is in cath lab, is we try to put it in the RV apex, not at the RV septum. Because RV apex has got a trabeculations that will hold the lead. But if you put it in the septum, it can get dislodged. Always the preferred side for the next question, of course, is which one to put, IJV or femoral. I think all of us should be good enough in putting IJV. Because putting in TPI, there's always a chances of getting it dislodged. When you are shifting the patient from bed to cath lab to bed, shifting the patient to ICU, there is high chances of dislodgement. Plus, patients get irritated because they will not be able to fold the leg. If they fold the leg, the catheter will get dislodged. And also in a situation where there is a associated myocardial infarction involved, or if there's a dilated cardiomyopathy, something like that, there is always a chances of perforation if the patient folds his leg. So because the TPIs are stiff, and now all TPIs should be balloon tip. All other TPIs are outdated. We should not use TPIs which are without balloon tip. Balloon tip always gives you protection against many things. As the balloon will flow across along with the blood flow. So unlikely to cause perforations. So it is important.
Sir, as you said, transcutaneous approach is a bridge therapy. So how do you determine the appropriate time of transition to transvenous? Is at every case as earliest as possible, or?
I think suppose in emergency patient has come to you, you are the only single doctor. Suppose you are working in a hospital probably where the manpower need to come little late, may not be always available on time. You put a transcutaneous pacing and then call for the help at the earliest. And even if it is happening, please make sure you put a central line and be ready to put a transvenous. And once you get a transvenous available, put a transvenous and then remove the transcutaneous. Because transcutaneous, as rightly said, has got a side effects. It can burn the skin. 50% cases it can fail. So why to depend on something which has got only 50% success rate? Yes, it has a role in an emergency where the other facilities is not available or it is delayed. It may not be available on the time.
Moving on to the last question. Role of ED in emergency transvenous pacing in emergency department. This was based on case report published in...
I think in all these scenarios, the role is only of emergency department only. We are called much late. I mean, we are not available. It's an emergency doctor who should know how to put a... that is why I'm telling you, all of you should have been aware of the hardware. The jugular TPI, which we use it, a balloon tip, I have seen people don't know how to inflate the balloon. Some people inflate it with a 5 ml. So it ends up in rupturing the balloon. So all of you should know, see, this transcutaneous, even a nurse knows how to put it. The important is to put a central line and put a jugular balloon tip catheter, for which everyone should be very clear about the hardware, how to use it, how to push it. As I said, suppose your jugular is not available, somebody who is a dialysis patient, all jugular lines are all burned up, putting a femoral and taking the catheter, putting it looking up so that you don't reach the branches, sometimes help, So it's important that you are aware of the hardware, that is important. So all these things is for emergency department. Where we come into picture is when the patient is shifted to the cath lab. So before that, all stabilization, everything is all your responsibility and you should be skilled enough to do it. That is why I feel all emergency doctors should have a posting in cath lab for 15 days. Not only in this, for tapping, tamponade. See, if suppose you have done 10 tamponade tapping, 11th you can do without cath lab, under echo guidance, because you have an idea what we are doing it. Suppose you have done 10 temporary pacemaker in cath lab, 11th you can do without cath lab. So once you are aware about the hardware use, so it's an important topic and life-saving one. And everything is emergency department. Cardiology has the last say, because once you have saved the life, then only we come into the picture.
So thank you for your key insights. I'll open the questions to the public. Great. Any questions? Thank you, sir. Thank you for your time.
May I request Dr. Varnika to come on stage and felicitate Dr. Brajesh and Dr. Nikhil? Backdrop. So I think it's time for lunch. I'm sure you all are thinking since a while. You all can go out and start. We'll be back in 30 minutes and we have some interesting thing planned after lunch so that you all are not drowsy and sleepy. We have a skit which is going to actually awaken you from the postprandial drowsiness, and then we have a debate which is going to be led by Dr. Nitin. I hope you all are very excited for it as much as we are. Please go ahead.
The time even by elevator, if you climb down by elevator, it's going to be 7 to 8 minutes. Fastest person leaving his OPD, a cardiologist leaving his OPD, I'm not speaking about procedure, forget that. So it will take 8 minutes.
So
by that time the patient is brain dead.
sorry to interrupt, but I'm just going to move on because you all are still stuck at kaun hai, kaun nahi hai. We are talking about when it's all of you are there. We should move past ki
Sir,
kaun kab aa raha hai.
we are looking at cardiac arrest only from a cardiac point of view. It's a very holistic thing. There is an airway that needs to be taken care of.
Okay.
There has to be, a team that needs to be allocated certain roles. And the cardiologist is a single person, not aware who the team is. The defibrillator, where everything is. I think the ER physician is much well equipped. Also, we handle it on a daily basis. As sir said, we are handling it on a daily basis.
So you can run a cardiac arrest without cardiologist.
Definitely.
Yeah, code we can run.
Definitely.
But
We
once,
do that
so
every
what,
day.
What
How is
we
this
are going to
possible?
do- So, so
No, I completely disagree. I will.
Sir, debate हमको करने दो.
Right, sir. But when the patient is coming for the first time, he gets a VT-VF rhythm. He needs to be revived. 96% of the time, it is cardiac cause.
Sir.
It may be a nurse, it may be a doctor. You don't need qualifications. You need to be ACLS certified, and you have to run a code before whoever comes.
Correct. We agree to that. Yeah.
The team leader is the person in charge there. So cannot wait for a cardiologist in cardiac arrest. It's a matter of seconds.
So
Right. So that is, see, we are beyond that.
We are beyond.
We are beyond that.
We are beyond.
CPR has to be CPR has to be initiated by the.
CPR is been initiated, the code is running.
Once we come in, we are the masters at that time. That's what I'm saying.
I don't think so. The worldwide treatment, the guidelines are very fixed. So whether it is a cardiologist or whether it is an ER physician, if it is a VT or VT without pulse or VF, it is going to be defibrillation. So cardiologist is not going, by his hand, he is not going to put a shock. It's very clear. So the thing is, what I want to tell, or what we are trying to tell is, okay, till the time CPR is going on, then only ER physician would be in charge. Once the ROSC is achieved, the cardiologist can take.
No, again I disagree.
We have
I will
lot
tell
of
you.
cases. We have lot of cases when we're done CPR on a table being shifted to the cath lab. Okay, one guy standing on the patient's chest.
The quality of CPR during transport is supposed to be the worst quality of CPR.
Yes.
Whenever you are transporting, so we know the data says if the blood supply to brain is lost for more than 5 minutes, patient is going to be brain dead. So the quality of CPR cannot be compromised, and nowhere None of the literature it is mentioned that you rush the patient in cardiac arrest to the cath lab with ongoing CPR.
But
You
we
have to
cannot
revive
delay.
the
Like for
patient
example, I
at
will
the
tell you,
place.
when there is a patient, you know, time is muscle, and we want to keep the ischemic time as low as possible. Now there are 3-4 scenarios. Suppose the patient is in arrest, he is not getting revived. He is not getting revived by your CPR. Again, we are into picture, whether it is Impella, whether it is ECMO. These are the things which will be done by the cardiologist. So they have to be involved at the very beginning.
The
Sir,
eCPR
ECMO
concept is
is
now
now
in
in
ER.
ER, yes.
The emergency physicians will initiate eCPR.
Definitely.
The first,
But the ECMO will be put by the cardiologist.
Yeah, so the cardiologist will be involved. Our talk is not, the discussion, debate is not whether the cardiologist needs to be involved. He needs to be involved, but the leader will be ER.
Okay. Time out. So we have got more scenarios, right? कि सिर्फ cardiac arrest करना है. More scenarios, no? We'll keep it going. So let's take a second case. We've got a 65-year-old AF with fast ventricular rate and compromised, diaphoretic systolic of 70, GCS 13, cardioversion. So who's in charge here?
Cardiologist. Cardiologist.
Cardioversion is something.
I will tell you my reasons. Let them tell.
Unstable AF, we will go ahead with a cardioversion without consulting a cardiologist, sir. Definitely, cardiologist should be involved, but we will go ahead with a cardioversion.
Will you waste time in cardioversion when the reason may be ACS?
But right now, when ACLS
When opening up the artery is going to be more helpful than
Sir,
cardioversion?
but the rescue right now is to cardiovert. Once we cardiovert,
No, but
then
if the ischemia is the reason, see, there are so many patients who have got atrial fibrillation. Do they become in cardiogenic shock?
Sir, but
Atrial
the
fib-
patient is
So we are
unstable.
speaking
We would want to
specifically
Why is he
stabilize
unstable?
Yeah, because of atrial fibrillation.
No, atrial fibrillation causing instability and causing such a low BP is very low.
Underlying ACS.
He has
will be
chest pain
different.
also, no?
Underlying ACS will be there.
Chest pain, diaphoretic, then
So my concern is, are you going to take this patient straight away into cath lab with this rhythm and this pulse and going to go for a procedure?
I will shock him while I am doing the angiography and angioplasty.
That's what I'm saying. So why you want to wait till going to the cath lab? We will shock him.
Because
in the
I don't want to wait even a single minute. Ischemia, as I tell you, is time is
No, but
extremely
you are going
important.
to do same thing what we are going to do downstairs,
No.
and in fact we are saving more time.
No, sometimes it takes a lot of time to shift the patient because everybody is waiting. They are waiting for the sedation to be given, all
Sir,
those things.
we will cardiovert and we'll insert the sheath also. You can just take immediately once the patient is cardioverted.
As well as doing an angiography down in the cath lab. ER itself.
So
Our concepts
Next
are
case?
very, we are very clear. If it is a patient is unstable, he needs to be stabilized, partially stabilized at least.
No,
so
but
that
how
he is
to
made in a
stabilize?
condition-
I think AFib is a symptom. It's not a primary issue.
No.
So it may be because of the ischemia which is causing that. There may be a valvular severe MS which is causing atrial fibrillation and hypotension. So there are multiple reasons. So I think if a patient comes with AFib, chest pain, diaphoresis, before you do anything, just call the cardiologist. They will screen the echo and all, and then they can.
The cardiologist, because he is not seeing the patient, he may say, okay, you give Amiodarone, wait for some time, 10 minutes, repeat again second dose of Amiodarone.
No, we come immediately.
Any cardiologist will be, saying
That's
give
what
Cardron.
I'm saying. So the thing is, we will be informing cardiologists, but first we will be shocking the patient. I don't want to.
No, I think you should inform the cardiologist. They will arrive before you shock, and then we can decide.
I don't think so. It's possible. Practically, it's not possible because my shock will be.
Finding out the reason is
seconds.
very important. Finding out whether it is a occlusive MI.
It is a ischemic event. We agree with that.
No, it may not be, but we need to differentiate.
Most likely to be a ischemic.
agree with you. Immediately call the cardiologist, but don't wait for them. You can do your cardioversion. So it should be simultaneous. If you are there, then even better because we call the cardiologist. Don't you know how to
So we are going to move to the next case. Wayne. Oh. 55 comes with a STEMI and cardiogenic shock. Intubation in ER, intubation on the table, or first just open the vessel. Who wants to go first?
So I would
Everyone
like your
wants to go.
opinion. I have both the experience, so which I can share. a cardiologist asking me, no shift, we will take care in cath lab, and the other one, no, first tube in ER, then only shift. So what you?
We would like the patient to be shifted to the cath lab. We'll keep our anesthetist ready over there, and then we will do the angiography and all. If it is possible, open up the vessel. If needed, then we will intubate. Or we will intubate if the patient is really into respiratory distress. We'll intubate in the cath lab.
Here comes the time whether you want patient who's already quite sick. We are seeing he's STEMI, he's on inotropes. You want him to land up in more problem and then go secure airway, or before that secure airway and move to cath lab?
No, we want to secure the airway in the cath lab before we proceed.
Any reason for that?
Yeah.
Any reason for that? What's
Because if the patient arrests during the procedure, during the intubation, then I will have the immediate access of the cath lab to open up the artery. Otherwise, they can go into refractory.
You will be opening the artery with the heart in arrest.
No, so when because the
So you want to intubate and then shift? Yeah.
Intubate and shift, yes.
Yeah. So,
They want to shift.
yeah, we have an experience that if you intubate the patient down, by the time he gets up, all the symptomatic drive is gone, and we find patients severely hypotensive. So this is our experience that if you do it in a long, if you give an half an hour time for a patient, if you intubate the patient and get him up to the cath lab, by the time he comes to us, he is like severely hypertensive because all the symptomatic drive, everything is gone. That we find it difficult to resuscitate such a patient. That's the reason why the patient is stable. He doesn't have any pulmonary edema. Then we want to intubate the patient in the confines of cath lab. And what we found that there is no damage to the oral cavity if done by a professional anesthetist in the cath lab rather than in the ER.
So here comes the real story. One second. The real story is like this. Anesthetists are good intubators, no doubt, but in a secured environment. Yeah. So none of the, if your patient crashes on table and the cardiac anesthetist who's intubating, the success rate of that person compared to a ER physician, because our intubation, we don't know the malampatti, we don't know how much is mouth opening, we just know how to tube the patient. Okay, so our thing is very clear. Okay, so any patient who's very bad, this kind of patient, I would not allow my cardiologist to take patient in cath lab without me intubating the patient. Yeah. Because if this patient while shifting, so none of the cath labs is on the same floor, or it takes at least say 1 minute to reach, and if patient arrests on the way, you cannot umbu with such a bad pulmonary edema, patient might be in failure also.
So solution is we will take you along with us in the cath lab.
So that doesn't make any sense.
We want intubation to be done by a trained ER technician.
Rescue
and nobody
intubation.
else.
So I'm saying intubation in distress, no one can match.
Yeah. Yes, sir.
So anesthetists are good intubators, no doubt. Difficult intubation, we also may ask for a backup from them in difficult intubation, but mostly elective. So because they are being trained for elective intubation, hardly any anesthetist comes there for intubation when patient is in real distress, and then he has no chance. There's no choice of drugs available, nothing. So he just has to tube the patient.
So only case when the patient wants to be intubated in the ER is patient is unstable, severe pulmonary edema, unable to lie down flat on the.
Agreed.
These are the only categories where we want to intubate.
Sir, this
Otherwise,
patient,
no.
I'm sure in real life you would also say first intubate and shift, because he has a very high chance of having a cardiac arrest.
I mean, we don't know. He's still on 100% FiO2, NIV, and.
Oh, SATs are 88 on 100%.
88%.
I know, but we can shift the patient in 5 minutes to cath lab, and then we can intubate over there.
Survive also, sir.
5 minutes is also a
5
very long
minutes,
time.
sir. 5 minutes ho jayega, sir.
Arey, sir. So that's the difference.
So
you play in minutes.
We move to the
second,
fourth.
last word.
Sorry.
So you play in minutes, we play in seconds. So that's the difference.
So we move to the last case. Well, there are many more, but for today. So we're getting a 45-year-old who's coming in and out of Ross. And every time it's a VF.
What time is it? The very important to. What time? Midnight,
Time of
1
the
o'clock,
day.
2 o'clock, in the morning. So that is also matters a lot, no?
Right now, this time. 2:30 in the afternoon on a weekday.
So cardiologist should be called immediately, without delay.
We definitely will, sir.
So in this case, 100% will be involving a cardiologist but the CPR control will be taken by us.
No, we will put the ECMO and we'll prepare the impeller in the cath lab.
Yeah.
We'll put the ECMO in either in the ER or we will take the patient to the cath lab.
In ER we will
because
do
he is a
self.
refractory VF.
Yeah.
So unless you put the ECMO, this patient is not going to survive. So whatever time you try, ROS, cross, 30 minutes, 40 minutes, he is going to,
In this case, we'll put on ECMO. We'll involve you also for putting it on ECMO, patient on ECMO, and move the patient.
But we will be the in charge. That's what I'm saying.
Once patient is on the ECMO.
Once ROS is achieved.
Once patient goes on ECMO, you are in charge. Because finally, we are not going to admit any of these patients. Admission will be under your care only. It is thing that initially who will take the leadership.
Because you're forgetting something. We are answerable for everything. Okay, once the patient is in the ER, we are answerable. If patient is in the transit, we are answerable. Patient is in the cath lab, we are answerable.
In ER, you are not answerable.
Of course, we are answerable. We are answerable in the ER also. We say, हम लेके आपको और कुछ हो गया.
नहीं. So consider patient is not been referred or not your old patient, a new patient, young guy came from somewhere. So it is ER person who will be answerable to everything. Only thing is, once the ROS is achieved, you have taken for
So
a
the only
procedure, you are
difference is
answerable.
we are not thanked once the STEMI is resolved, but we are equally answerable.
See, most of the patients come to us by referrals. Okay, so the primary physician has to be involved in all these things. So, be it in ER, be it everywhere, we're answerable everywhere.
Definitely,
so,
sir. We
that
will
is very
definitely
important.
Our
involve.
discussion, involvement every time it will be there. The thing is, when the code is running, we don't want anyone else to instruct us or to
code should
interfere
be
in our code. Once we are done with our job, everything is yours.
Okay, great. Is the debate over? Then we can shake hands here.
Shake hands.
So he asked me to fight like a bull and be a devil's advocate.
This is the problem when you have a very good relationship and completely seamless care. So yes, we are at the end of the debate, but what I would request is for starting with maybe Rahul, all four of you can just say just summarize things in whichever way you would like.
I think what I would say, as it looked like, we are a family. So it cannot be one, somebody taking a charge. It has always to be a continuous care, which starts with the emergency physicians. Their decision is paramount because they are the one who will look into multiple things, whether it is ischemic, non-ischemic, electrolyte imbalances, or other causes. They are equipped with doing echocardiography to assess immediately regional wall motion abnormalities. And I think the success of any program in reviving these patients is the team effort, beginning with the emergency physician. And I think the cardiologists have to be involved as early as possible so that they start preparing whether there is any cath lab procedure which is going on or if they are at home in the night so that they can start moving towards that, activating the cath lab so that we give the best outcome. In case it is not a non-ischemic, then we can diffuse the thing. We can say, okay, de-escalate the thing. But at least if we keep things escalated, patient's timely treatment can do wonders for this patient and the survival rate will increase dramatically. So this is what I would say. So it's always a team effort. It is never who is the master. It's, I think everybody is the master for that patient.
Thank you.
So the thing is actually...
Yeah, nothing more to add in this. It is just like a relationship between two people, okay? And the ER people never show their love back to you. So it's an unrequited love for a lover. That's a relation between an ER and an cardiologist.
I incorporated your slides in mine. No?
Yeah, you're just showing love for
that's
some time.
love.
That's what the ER people do. Show love for some time only. It's never for a longer time. No? So,
Samir.
So actually, I just thought of, it's like cooking a food. So when in food, each and every ingredient is important. Whether it is a pinch of salt, it is pepper, it is chili, whatever, and the major ingredients. So everyone has their own role. Even if you don't add salt to any food, it won't be tasty. So it is teamwork, no doubt. Only thing is
but I'd like to add something. But the Tadka is a cardiologist.
So the only thing is only tadka you cannot eat. So that we have to remember.
Debate still continues, huh?
So finally we have to eat food and it is going to be a team effort throughout. And as he said, it starts from ER and it ends with the ward. So ER, cath lab, ICU, ward care, and finally patient gets discharged.
I think I'll just tell you the example. when things go wrong, we had with that patient, we did everything right. But from ER physician to the cardiologist to the CVTS surgeon to the neurologist, the patient's family has involved with everything being done well. So as you are rightly saying, it is ER people also become responsible, and it's always a team effort. So it's not
We also have to buy indemnity insurance.
We were just arguing for the sake of arguing, okay? So nothing to be taken very seriously here.
Sir, as a young ER physician, I would say having that confidence from the cardiologist gives us also, the confidence to run the code and then get you involved. Because there are times we won't be able to call you in middle of a code. So yes, the teamwork and having that confidence in each other, I think that is very important.
Best part is because now it's not like the olden days, everyone seems, okay, I am the boss. We have now noticed, suppose we revive a patient and then we do ECG, we don't know what is caused, we see some minor changes and we ask our cardiologist, they are okay, they'll just screen kiya hai tune, if you feel RWA mein hai and there are minor changes, we can take in cath lab. So it goes very hand in hand, very smoothly nowadays.
So thank you, all of you. And I think it was well illustrated that even though we work with each other, there will be moments, there will be situations where, we may have different ideas at that moment. Particularly, I think mostly what we demonstrated is priorities. Pehle kya, baad mein kya. And usme challenge aa sakta hai. But keeping the lines of communication, having these kind of either simulations or case-based discussions that we are doing from morning, it just informs all of us. And then we can kind of talk to each other on the same platform, which is what we only success for the patient is if we are all together. So thank you, everyone. I think it was a great session.
Thank you.
पहले ज़माने में बोलते थे शास्त्रार्थ, fight, discussion with.
They are very, very important people for us.
Thank you. That's nice.
Thank you.
No, sir will give.
Sandeep, can we have you on stage? We'll connect. You want to announce? Akansha, can we have you on stage as well? Sir, आप भी खुश रहो, sir. So,
Okay. So basically, we have taken this opportunity today to felicitate some of our senior emergency physicians who have been contributing in field of emergency medicine over more than a decade. Because you know that emergency medicine was a new specialty some 10-15 years back. So nobody knows where we are heading. And that time, people has taken this specialty, made sure that this specialty will grow. They sustained, not only sustained, they glamorized this specialty. So we will be felicitating some of the senior emergency physician. I consider them as a leader also in emergency medicine in this forum. and as a small token of appreciation from Society for Emergency Medicine Maharashtra chapter as well as Society for Emergency Medicine India, I will be felicitating them today. Firstly, we'll call Dr. Samir Rathi. Samir is now almost more than 15 years with Kokilaben Dhirubhai Ambani Hospital, relentlessly serving specialty of emergency medicine. Many students under him got passed out and they are doing successfully practicing emergency medicine. Now I request Dr. Kishore Sathe to come. We know about Hinduja and Khusrao Bhajan is a very much, Khusrao Bhajan sir is a very indispensable combination. But there is another combination is there that Kishore Sathe and Emergency Department of Hinduja Hospital. He is also contributed more than couple of decades in emergency medicine and his significance is far more than which he is the unsung hero of emergency medicine. So we take this opportunity to felicitate him also. Now, we'll call our very own co-host Akshay Devdhar. He was leading emergency department at Nanavati, and now he is with Nitin Zagasia. Leading any emergency department is not a simple thing. It requires lots of guts and determination, and we are appreciating him today. Last but not least, Dr. Samrat. Samrat is leading emergency medicine department at LH Hiranandani Hospital for almost a decade now, means more 7-8 years now. And as you know that those who go out and practice emergency medicine, start emergency department, change the concept of casualty and lead that place to pro-emergency and transfer it to the emergency department is a huge and Herculean task. When you go out and practice, you will realize that to staying in emergency department and leading on departments for a decade means what. So we appreciate his contribution also.
वो लेके आएगा सर रुक जाइए थैंक्स HDMI जाता है
So our next talk is by a faculty who is quite famous. I don't really need to introduce him. When we are talking about IABP, ECMO and ECPR and whatnot, what else did we talk about? Intubation and ventilators. We are talking essentially about man and machine, how a man and a machine both together can save a life. So let's have our expert Dr. Kushraf Bhajan talk about mechanical life support devices.
Sorry guys, 2 minutes.
एक काम दूसरा है ये सी नहीं चलेगा आपका नहीं चलेगा नहीं वो ऑडियो सी से नहीं होता आपने ट्राई किया एक्सटेंड ट्राई कर ओके नहीं that's हो गया
Yeah, thank you. Bring in.
Yeah.
Hi, friends. Extremely happy and overwhelmed to be back here. Amazing conferences Nitin and his team arrange here. So thank you all for having me again. A relatively difficult topic to actually convey in 20 minutes, and this is not all the time done and seen in the ER. So there'll be 80% or 90% of the slides which would be just I will run through them so that you have at least an idea, because next time, like debates we had, they used words like impala and IIBP, etc. We will probably know what we are doing. So this is more of making all of us a little aware of the mechanical life support systems and devices that we have, and when should we incorporate each one which has a separate role. So we obviously need these devices when there is cardiogenic shock, and I'm not going to bore you with all the three definitions of cardiogenic shock, but in short, clinically and with parameters, cardiogenic shock is basically nothing but a persistent hypotension, a cardiac index which is low, and the LV EDP or pulmonary edema sets in. The CVP is high, the wedge pressure is high. So we know that this patient is in cardiogenic shock from a cardiac origin, obviously not neurogenic shock, which may present like that. So you may have an X-ray which presents like this. You will have an echo which shows cardiogenic shock where there is a dilated left ventricle, hypocontractile walls, and the patient will be extremely critical and may even need intubation and the works. So how do I know what to use and how to treat this cardiogenic shock? So there is a very nice SCAI scoring system, and we need to understand the Society for Cardiovascular Angiography and Interventions, and they have got criteria from A to E. And a cardiogenic shock patient is always put into one of these categories, and we know that it's a dynamic process. So even from A, they may move on to D, or D, they may move on to E. So A is only at risk, B is beginning of cardiogenic shock, C is the classic cardiogenic shock which I just mentioned, and D is a deteriorating patient, and E is an extreme patient who might arrest in the next few minutes. So we need to understand that there is a preclinical stage in A and B. There is a cardiogenic shock, which is C, and the latter part of B. And then there is refractory cardiogenic shock, which is extremely difficult to treat. And sometimes you really can't do much, and you just need to support the heart till a transplant is made available. So the deteriorating and the extreme ones are the ones where we would need a mechanical cardiac support device. And we'll come to that. in a bit. And as you can see, the lactates are actually rising as it goes from A to E. And the hypoperfusion sets in at the maximum here, and the multi-organ failure also sets in. So once the entire cascade has set in, there is no point in trying to treat, but we need to keep it low. We need to treat it early and identify it early. So I think I'm spending a little time on this, but the SCAI scoring system is the very easy bedside way of understanding where to actually put this patient on. When we say OMT, it means optimum medical management or treatment, and we have the 4 main categories which actually help us clinically and medically. That is the MRAs, the ARNIs, the beta blockers, and the SGL2 inhibitors, and these will definitely try to stabilize this patient. But most of the patients that come to our ER are already on 3 or 4 of these, and they will not be able to, you won't be able to do anything better medically because they are optimally treated. And short-term mortality for patients with cardiogenic shock, despite improvement in medical treatment, still remains above 30% even in the classic cardiogenic shock. And therefore, we need to have some different form of treatment for these patients with cardiogenic shock. So look to the right, or at least that side. In cardiogenic shock, they've made a nice pyramid here. Again, A to E comes from below to up. And first you start with OMT, which is optimum medical therapy. Then comes the IABP. I was just discussing with Dr. Sandeep that the newer guidelines of AHA have said IABP may not be very useful. This comes from an article in NEJM in 2013, but we use it all the time. The cardiosurgeons use it all the time, and the cardiologists use it all the time. We are not looking at 28-day mortality. We are looking at how to stabilize the patient so that the cardiotomy, etc., can be done well. So after the IAPB, as I'm saying, there are many words and many devices which even I have not used in my entire career, but at least we should be apprised about how they can be used and where to place them. So once you move on from IABP, it is Impella, CP, or the tandem heart. Sorry for all these words. And then comes the Impella 5, which is now not available, the tandem heart and the ECMO. And when you use ECMO, you might need to do an LV venting. And then finally, you need an ECMO plus LV vent plus Impella plus tandem heart. And I think this is all a khichdi and a tadka of whatever you might want to do. So you need to understand that cardiogenic shock management needs a combination of all these. Now the treatment, because the mortality remains high over the last 2 decades, the paradigm shift has occurred in the treatment, and instead of short-term stabilizing them with ionotropes, vasopressors, triple ionotropes, as you saw the case, because those patients will temporarily stabilize, those patients will be temporarily stabilized with these triple ionotropes, but sooner or later they will cause arrhythmias, they will cause other tachycardia, splanchnic ischemia, etc. And therefore, the paradigm shift has occurred towards using mechanical circulatory devices much earlier because they restore the stable hemodynamics, they minimize the myocardial ischemia, they reduce the native heart workload, and they maintain the vital organ perfusion. So they don't have much complications if done appropriately and monitored. Sorry about that. But you can clearly put them on properly in the right patient at the right time, the right device, and you can hope that they work and they do their job. So early mechanical circulatory cardiac devices is the key now, and we incorporate them earlier and earlier. Again, there is a nice stepwise approach where I just mentioned to you, there's a medical therapy, there's an IABP, there are intracorporeal devices, and then finally ECMO, and then recovery or transplant or even death. So this is a stepwise approach to cardiogenic shock, but I would say that now this is not a stepwise approach anymore, and it is totally a horizontal approach. Like even in trauma, we say that you do A and then B and C, so it's a vertical approach, but practically it's always a horizontal approach. You do not do A and wait to do B, you do everything simultaneously. So where are these indicated? These MCSs are indicated in cardiogenic shock, of course, which could be because of myocarditis, MI, or acute cardiogenic syndrome, a coronary syndrome, or even some poisonings like aluminum phosphide. Stabilizing before interventions, which is important, like a high-risk PTCA or inability to wean from the pump in a post-cardiotomy or a CABG syndrome, or if you're going abroad, a cabbage place, a graft rejection from a transplant, and then eCPR, which Sandeep is leading in our part of the world. So this is how we need to understand how to do and place the cardiac devices in the right scenario. So the reasons are a bit philosophical here: bridge to recovery, bridge to decision. So you allow the heart to settle down, you keep this as a bridge, and then they improve after a little weeks or months. Or bridge to decision: what am I doing? Am I doing a PCI? Am I doing this? Am I taking the patient up for CABG or a transplant, and the transplant is 3 months away? Or, as I said, bridge to transplant, or finally a destination therapy in which you might put the patient on LVAD. And we will just quickly touch upon all these. So this is again the spectrum of mechanical supports. Once we decide that we do need them, you will have IABP, you will have LVADs, you will have total artificial heart, which I will just show you. You will have ECMO on the other hand, and you can have the Impella. So these are the main 5 which I will touch upon with the major discussion on IABP, if we may. So the left ventricle and the right ventricle, we would divide these chambers, and we would use pulsatile versus continuous flow for the left chamber. The pulsatile one is the IABP which we use, and the continuous one again is divided into axial versus centrifugal. You're going to throw me out if I talk 10 more minutes with these terms. But axial is Impella CP and another heart, I don't know the PHP. And the centrifugal would be tandem heart and a VA ECMO. And against that would be the right ventricle, in which you have the Impella RP, the VA ECMO, and the centrifugal would be tandem heart, and the Protec, which is available easily. So you have to divide: are you supporting the left heart, are you supporting the right heart, depending upon the intervention needed and the case that is in front of you. So this is the difference in a centrifugal blood pump as against an axial. So in axial, it just rotates like a bullet and the blood will flow around it. And there is a diffuser, there is an impeller, and there is a straightener, more like a hair treatment. And here you have a centrifugal pump in which it keeps on rotating like you have in ECMO. And now they've come up with something which is gravitational or anti-gravitational, which is called as the levitating pump. So there is no mechanical destruction of the platelets or any DIC happening in the blood, and you have these levitating pumps. And I hope this lecture is a levitating one for you guys too. Now, which one and when to use it is also important. I'm sorry for this slide, but when you need a support of just 1 liter, then you might use an IABP. When you need more than that, up to 2 liters, you need an Impella, because a IABP can only give 25% of the cardiac output, which is not more than 1 liter. So it can only help you with that. When you need 2 liters, it is Impella, and then it is the tandem heart up to 4 liters, and then the Impella CP all through, and then the Impella 5, and then the VA ECMO. So at different stages, depending upon what you need to do, you will have to decide the device. Again, this is a nice flowchart of comparing the 4 main ones. I won't go into the details, but there are complications of each and there are indications of each. But if you know these 4 at least a little bit, then you know mechanical circulatory, cardiac circulatory devices well. There are left ventricle and right ventricle. This is just to tell you that I don't belong to the leftist or any other community, but if you want to talk about the lefts, I've just put this cartoon up. We talk about the IABP. Now, IABP is what we do in the ER, what we do in the ICU, what we do in the cath lab also, along with cardiologists or even without them. And this is pretty important, so I will just spend about 5 minutes on this. So IABP basically works on the principle of counter pulsations, and this counter pulsations means that when the heart is in diastole, the balloon inflates, and when the heart is in systole, the balloon will deflate. So what happens in diastole, if you all can say it with me, in the diastolic phase of the heart, the balloon which is placed in the descending aorta will inflate. By inflating, it will push blood backwards into the coronary arteries and improve the coronary perfusion. Are you all with me? Yes, no? Yeah. So in the diastolic phase of the heart, anyways, the coronary filling happens in the diastolic phase because the coronary arteries are end arteries. So in the diastolic phase, it is going to work. So in the diastolic phase of the heart, the balloon inflates, say it with me if you want, and by doing so, blood is pushed back into the coronary arteries, improving coronary perfusion, improving cardiac output. Simple. Now, when the heart is in systole, the balloon suddenly deflates, therefore creating a vacuum there, therefore decreasing the SVR, or the resistance against which the heart has to pump. So if it is decreasing the SVR, the failing heart has to pump against less resistance. What is blood pressure, my friends? Blood pressure is nothing but the flow exerted by the column of, actions karo. BP is nothing but the flow exerted by the column of blood on the lateral walls of the arteries, right? So this is cardiac output and this is SVR. Karuna, I don't want to be the only clown in the audience. Yeah. So it's cardiac output multiplied by the SVR. So you are trying to improve the cardiac output and you are trying to improve or increase or decrease the SVR to try and maintain the BP. So can you all please say it with me once, because I would love you all to understand the balloon for sure. IIBP works on the principle of, louder please. I can't hear. Those people are making notes and balloon will never be understood. IIBP works on the principle of counter pulsations. Say it fast. In the diastolic, with actions please. In the diastolic phase of the heart, the balloon inflates, therefore pushing blood into the coronary circulation, improving coronary perfusion, improving cardiac output. That is one. So obviously BP will be good. In the systolic phase of the heart, the balloon suddenly deflates, therefore decreasing the resistance against which heart has to pump, therefore decreasing SVR, therefore again improving the blood pressure and So this is what I would like you all to know, and this is nothing but what we have drawn here. It's the same thing. So this is how it will inflate, this is how it will deflate. We use helium as a gas because it's the most inert. Actually, that's a lie. Neon is the most inert, but helium is available to us on Earth and easily, and therefore helium is used. 50 years ago, they used to use carbon monoxide, or carbon dioxide, sorry. Let's look at Got that? The same thing which we were mentioning. Now, this is the only device or thing in the world, therapy in the world, which is decided by the height and not the weight. Drugs are decided by the weight, but this is the only thing decided by the height. Less than 5 feet 4 is 30 cc's, more than 5 feet 4 till 6 feet is about 40 cc's, and above 6 feet is 50 cc's. For Nitin, we'll have to get a new one, maybe 60 cc's, where it's not made yet. Thank God he didn't hear me. So in India, the usual height is about 5.3, 5.4 average height. So many used only 30 cc's and many used only 40. So it was wasted, the production. So they were smart enough to make a 34 cc. So you will get a 34 cc and you will get a 50 cc. And now the newer guidelines are that anyone more than 5 feet 4 should have a balloon which is 50 cc, and anybody less than 5.4. So you don't have to be a 6-footer to get a 50 cc balloon. It is called as the mega balloon. Why so much hue and cry of selection of the balloon? This balloon, the cc's decide the length of the balloon. So if you use a bigger balloon for a shorter person, as you place it, you might involve the renals. So patient gets better, but the urine output may decrease. Are you all with me? Yeah. So it depends upon the height. So you need the distance between the subclavian and the renal arteries to be appropriate. And this is how it should be used. And it should occlude 85% of the aorta. So the correct position, as you can see on the X-ray here, can you see this mark? And this mark is where the balloon tip is. And you can even see the balloon inflating on the X-ray, which you may or may not see. So this is perfectly placed balloon and it should do its work. Indications, again, cardiogenic shock, complicated MI, high-risk PTCAs, high-risk CABGs, and sometimes unstable arrhythmias or refractory arrhythmias of ischemic origin, and then as a bridge to cardiac transplant. Contraindications are severe aortic regurgitation, dissecting aneurysm, of course, otherwise you will help the patient to die, and then severe peripheral vascular disease because you cannot really put it in, and brain dead patients, obviously, please don't. So this is important. If you understand this, you understand IABP. There is a systole and a diastole. Everyone knows, can you all draw it with me? You have a systole, you have a dicrotic notch, and then you have a diastole, and at the end you have an end diastole. Are we there? Together? Come on. Peak systole, dicrotic notch, diastole, end diastole. Now this is your systole, which is not because of the balloon. Now if you do 1:2, every second cycle of the balloon, of the heart will be augmented or assisted by the balloon. So this is the unassisted. Are you with me, guys? It's difficult to just say it in 5 minutes. This is the unassisted systole. This is the dicrotic notch, and if you see in blue, that would be the normal. But here, during diastole, the balloon inflates. Didn't we say that? If the balloon inflates, it will give you a big augmentation of the diastole. So the highest peak is the augmented diastole. Then you are suddenly deflating the balloon before the systole or during the systole. So the resistance is reduced, and therefore you will have an end diastole which is assisted. But it is lower than the unassisted end diastole. Does it make sense? Impossible, I can tell you all afterwards. So this is an augmented diastole, this is an assisted end diastole, and because it starts at a lower level, the next systole still is assisted, is called the assisted systole. Can you all read it with me, guys, please? Bolo, where is the arrow? Unassisted end diastole. Now systole begins, peak systole, bolo na yaar, dicrotic notch, augmented diastole, assisted end diastole, and then assisted systole. So if you actually notice, the highest peak is augmented diastole, and your assisted systole is lower than the unassisted systole. The reason being, your assisted end diastole is lower than your unassisted end diastole. You only need these 6 peaks and troughs. Make sense? Or you all are totally fired? Okay. So if you all have understood this, I'm happy. And this is the line. Where is this line going across? The unassisted systole. Haan ke nahi? And this line, unassisted end diastole. So if you can see, the augmentation is so much more. The assisted systole is so much less. And the assisted end diastole is so much lower. Does it make sense? Yes, no. So people ask, what should be the ideal blood pressure on IABP? So there is no ideal blood pressure. You can titrate your ionotropes to get your IABP pressure or blood pressure. But to make the IABP work optimally, you need a U and you need to have a V. Not WE, but a V. So if you get a V shape here and you get a U shaped here, then your balloon is optimally functioning. So it's never the blood pressure that the balloon decides. It's only a U and a V, and that's what the balloon can do. Sometimes you get an augmentation of almost 40.
Now, the complication, if you understood this, my lecture is kind of over. I'll just show you the other devices. The vascular access, the balloon related, and the other miscellaneous. So basically, you can have thrombocytopenia, you can have an arterial puncture, you can have problems, but the balloon will stay in for a few days. So you can have dorsalis pedis and posterior tibial arteries blocked, and therefore you might even have a gangrene, and you may need an embolectomy, Fogarty's, or you might even have to amputate. So these are very bad complications to have. Now some literature. So there was an in-hospital mortality with and without the balloon during a primary PTCA, and you can see that 59% of the primary PTCAs had a better outcome, and there was mortality of 19% without the intra-aortic balloon pump. The next one is Impella. It is an axial pump. It is 2.5 and 12 French, and you have different ones, 2.5, 5, etc. This is an Impella device. It looks like this. It is placed in the heart. You can see this, and this will actually protect the heart for a longer time. This is almost the same as an LVAD, but Impella is very expensive. A balloon may cost you 25,000-30,000, but an Impella costs 25 lakhs, which is the same as a transplant. So it's not used. And what it does is there is an inflow-outflow across the aortic valve. It may decrease the end diastolic volume, it increases the aortic outflow pressure and increases the flow, and it does the same thing which other devices do. Then you have a tandem heart. It looks like this. I'm not giving you details, but this is how it looks, and it is inserted right into the heart, and you can see the cannula go across the atria. This is the actual LVAD, and that is the left ventricular assist device. The main one, I've put it up because this is the only one used. It's called the HeartMate 3, and we have therefore some cardiologists in our hospital calling us mate. How are you, mate? Who've come from Australia. Yeah. So this is the HeartMate, and this is how it actually looks. This is on the X-ray. So if you see an X-ray like this, then this is an LVAD procedure, and this is what is placed into the heart. You can have a total artificial heart, you can have the left ventricle, the right ventricle, and so much more, and it goes on and on. Then comes the VA ECMO, and VA ECMO is life-saving. You can centrally insert it or peripherally insert it. It would be from the femoral artery into the jugular vein, or femoral artery to the fem to the femoral vein, and this is how you do it. And there is an entire circuit of the ECMO where there is an access drainage. It goes through the pump, goes through the membrane oxygenator, gets humidified oxygen, there is an oxygen blender, and then gets returned to the venous side. And then there are indications for ECMO, but I'm not getting into details. You must do a course in Fortis to do that. So when the mortality risk is 50%, you must consider, and when the mortality risk is 80%, you must do it. So that's the dictum 50-80. Using ECMO support definitely reduces the mortality by half. And combination devices, you can use ECMO with Impella, and that can also have benefits. And when you use Impella and ECMO, it is called as ECPella, which is EC for extracorporeal and Pella for Impella. Now the rightist approach, not the right approach, but we did the left, now the right ventricle. You have the Impella RP and you have the Protect Duo. Please don't ask me, I've never used it. So in short, these are the devices which you all should know. The complications could be mechanical, it may fail, it may migrate, and the patient will die there, the battery failure, whatnot. Cardiovascular problems, there'll be vascular injuries, etc. But these are there in the book, so I'm not wasting time on that. There are cardiogenic shocks, and now it's the day and age of talking about phenotypes, and we have to understand that not all cardiogenic shocks or heart failures are the same, and therefore you can have patients which are acute, typical decompensated, or those with pulmonary edema, or those without pulmonary edema and having low cardiac output, and those who are having everything and the works, and the treatment actually differs from medical to IABP. So those who are in acute decompensated cardiogenic shock with pulmonary edema and low cardiac output, you will need inotropic therapy and a very early IABP or LVAD or any other procedure. Again, there are so many algorithms of which to use when. And if all fails, just one or 2 minutes more. heart transplant is the way to go, and you need to know the indications of heart transplant, which would be a correct referral, and cardiogenic shock requiring mechanical assistance itself becomes a reason for cardiac transplant. And you either need an antihistaminic or a heart transplant. This is just a stupid one. But see all the wires and the gadgets that we have in our ER at times, and we really can't get our access to the patient. So the future of MCS is biocompatible surfaces, so there is no hemolysis, wireless charging, more adaptive flow regulation, pulsatile flow is better than non-pulsatile, and physiological blood flow, which is called as co-pumping. The heart pumps and the mechanical device pumps, otherwise it just takes over, and that is not appropriate. And AI is coming up in a big way in helping ECMO, etc. So my last slide here, what do I do actually practically? So I would first start with optimal medical treatment. I would then put the patient into a PCI suite or do a cabbage depending upon the vessels blocked. Use an IIBP and Impella. Again, it's a horizontal device, way of approach. And then maybe if nothing works, ECMO, and there are patients who might directly come into this stage, and then transfer the patient for a transplant if you all don't do transplants in or, I can't be saying this in Apollo. Yeah. So I always treat my patients as VIPs. All my patients are VIPs. There's no single patient that is not. And VIP for me stands for ventilate them, inotropes or infuse them, and perfuse them with the right gadget, that is the PCI or the CABG. I leave you with a point to ponder upon. Is cardiogenic shock a mechanical problem? It is a mechanical problem, right? So therefore, don't we need a mechanical device to treat it? And why do we waste our time trying to continuously do medical treatment? Thank you. Thank you.
Sir. वो डिस्कनेक्ट हो रहा है, डिस्कनेक्ट हो गया. So we have one more debate coming up. We all have been learning, as ED physicians, we all have been learning ABCDE, right? Can anybody summarize ABCDE for me? A.
Apple.
B.
Ball.
C.
Cat.
D.
Dog.
And E. But what do you do when everything goes wrong? What do you do when all of your alphabets are crashing? Anybody? So your adrenaline is taking a rocket, skyrocket, and your airway is taking a nosedive. What do you do? That's what our debate is. Can you hear me? Airway in a crashing state. Kunjalakshmi versus Danny, moderated by Shreya.
Hello. Hello.
I think the global mute. Yeah. Hi everyone.
Hi guys.
So I'm Danish. I'm kind of like an alumni. Not kind of like an alumni. I'm alumni.
Actually,
of
we've
Apollo.
had extensive conversation on STEMI and cardiogenic shock, and we've already covered the entirety of it. So right now, I think we're going to focus on what ER guys talk a lot about. It's airway. So
I think most of you are sleepy. 80% not sleepy. No, it's fine to admit. I mean, the first policy about ER is being honest about yourself. Okay, so you can admit that you're sleepy. If you are sleepy, you can stand up.
nobody is sleeping.
Wow.
Okay.
Okay, so basically, I studied emergency medicine. Right now, I'm a resident in critical care, DRNB. No, but it's not like I hate emergency. No, it's not about leaving. It's about extending your knowledge. So, no, I do.
Yeah, I'm still in ER, so.
Yeah. Okay. So I think Shreya would.
Yeah, so I would actually prefer if you want to take a seat, you may take a seat. Both of you. So like both of them have introduced, they are emerging. One is emerging emergency physician, another one is critical care physician, as you can see. So we'll be discussing on should we secure the airway early in a crashing STEMI patient or not. So that's the topic for discussion today. So they'll be debating on this. So more than a debate, I would say it would go as a discussion most probably. So I'll be giving some case scenarios and I'll be throwing some questions upon them so that they can have a discussion on what has to be done and when has to be done. So coming to case number 1, it's a 65-year-old male. He's a known hypertensive and diabetic, and he presents with complaints of ongoing antireval STEMI and heart rate is around 50. BP is 90 out of 60 and saturation is 85% with 6 liters O2 support with increasing respiratory distress. His GCS is 14 and he is having frothy pink sputum with bilateral basal crackles. So the question is, should we intubate early to optimize oxygenation or should we avoid intubation due to peri-intubation hypotension risk?
So to start off with the case, can we go back to the case?
Sure.
Yeah. So we have a 65-year-old male, and it looks like this patient is in STEMI with shock, cardiogenic shock. Heart rate is on the lower side, 50, and SATs are about 85 on 6 liters of oxygen, so there's respiratory distress. And GCS is 14, so I wouldn't say that the airway is threatened. So my approach here would be to optimize this patient. When I say optimization, I would say that I would like to start the patient on some inotropic support, start the patient on NIV, which will give some positive pressure ventilation, because we are already dealing with some amount of pulmonary edema, frothy pink sputum and basal crackles. So the NIV with the PEEP and the pressure support will help with the pulmonary edema, and inotropic support because obviously the BP is on the lower side. And see how the patient fares and try to delay intubation and accelerate the shift of the patient to cath lab, because we have limitation of time. We want to target for PCI, that is the definitive management. And the shock could be a byproduct of the MI. So that would be my approach. So to answer the second question, I'm worried about the second question.
Yeah, so I would not agree much with what you said. Yeah, so I think we are dealing with an anterior wall MI. The patient is decompensated, I think you can see. An anterior wall MI presenting with a BP like that and a heart rate like that is not a very good sign. And patient getting a GCS of 14 and having increased respiratory distress within 85%, I would think that the patient has been too long been hypoxic. Second thing, an anterior wall MI going into a decompensated heart failure. I would prefer getting a definitive airway, because why? 2-3 things. One, in this scenario, it's not just the oxygen that is getting deranged, it's more like the ventilation part and the perfusion that is getting rearranged. Now, ventilation can be completely controlled by your intubation, but intubation, it's not going to be a crash intubation, it's definitely going to be an RSI, wherein you would have pre-medications designed to improve the hemodynamics. So we would go ahead with the ketamine, we would go ahead with the fentanyl, and then we would intubate the patient, get a definitive airway. Now, positive pressure ventilation with the definitive airway is much more superior than an NIV. Why I would say so? One thing, we get a complete control of the ventilation. Second thing, your afterload control, that is reducing your afterload and having less effect on the diaphragmatic pressure change is much more maintained with a definitive airway. So I think we would go with the definitive airway. Second thing, it's not just a respiratory distress, that patient is going towards a respiratory failure, right? So we don't want to take any chance. We don't want to further deteriorate the person. I would go with the definitive airway, because anyway the patient is going to the cath lab, that patient would have to lie flat with a pulmonary edema. So I think we should intubate and then shift the patient to the cath lab for a definitive management. And seeing this, it may be even a double vessel disease. All right. So yeah, I think that is my take on intubate. What would we do to improve the oxygenation? It's not about oxygenation, it's about improving ventilation and perfusion both.
But when you consider tubing this patient, in my opinion, intubation itself is arrhythmogenic. There's going to be a lot of vagal stimulation, laryngeal stimulation, and all of that can further worsen the bradycardia that's already existing in this patient. So I think that my approach of being passive and choosing to non-invasively ventilate can also give all the necessary things to optimize this patient for safe transfer to the cath lab, rather than just going aggressive in taking the airway. Yep. So if bradyarrhythmia comes, then we'd have to again take crash airway. So why not optimize and prioritize shifting to the cath lab?
No, but I think what you are afraid of is a pre-existing hypoxia, on top of which a laryngeal stimulation, which might go into a vagal stimulation and cause a bradycardia, right? Now, your hypoxia part is taken care by your pre-oxygenation, or maybe in this case, we can go ahead with something called as peri-oxygenation intubation. So, you can actually start with a HFNC, or you can start with nasal prongs. Anyway, give a high flow oxygen. So, during intubation episode, your hypoxia doesn't bother you much. Second thing, you can always try an atropine shot before just intubating the patient. Although in pediatric studies, it is said that there is no much effect with an atropine. Adult studies have not yet been much conducted with an atropine during intubation. But I feel pre-oxygenating and giving an atropine, or maybe starting off with an ionotrope, like an adrenaline infusion, would actually help this patient during intubation. So I wouldn't much worry about peri-intubation bradycardia and bradyarrest.
But when you do the measures that you just explained to me, don't you think you'll push the patient into the opposite direction and then they can go into VT, VF or tachyarrhythmia?
Yeah, so that is why I said initially we would go ahead with a fentanyl also. So that is a sympatholytic drug. So I think 1 to 1.5 mics per kg should be good enough. I mean, I know it is going to push the patient further down the BP line, but peri-intubation, once you start with an ionotropic support and once you have a patient running on adrenaline or a dopamine and then going ahead with a definitive airway, I think that would be a better management prior to shifting the patient to the cath lab.
I still think that when you do the non-invasive method, you're also optimizing. It's not like you're also not giving any medication to the patient. You're also going to start him on inotropic support, optimize the patient, give the positive pressure ventilation. The only difference being that you're going to transfer the patient without a definitive airway. And the cath lab should be equipped to handle the airway as well as target the culprit vessel. So,
yeah, I mean, it's not just the culprit vessel. The management, I feel, the definitive management is the culprit vessel, but prior to that, improving a cardiac output, improving the breathing status of the patient, improving the ventilation, I think that helps. So I feel not delaying putting the patient on an NIV, waiting for the patient to stabilize. I feel get a definitive airway, get a rails or something in place, get some inotropes running, shift the patient to the ICU. I think that would take care of ventilation, circulation, and opening up the definitive airway would be much, easier. Patient can have a good supine position.
Okay, so it's not like we have a definitive approach that we have come across. I would suggest that audience also can have a word on this, or you just can note down the points, what you feel about this case and how do you want to approach this. So by the end of the discussion, we'll have a question answer session also. So I'm moving on to the second case. So the second case is a 58-year-old male, anterior STEMI with cardiogenic shock. He presented with a BP of 180/110 and heart rate of 179 with cold peripheries. He is confused, agitated, with saturation of 92% on NRBM, and his ECG is showing ongoing ST elevations, and bedside echo is suggestive of his LV ejection fraction to be approximately 25%. So the question is, will intubation reduce myocardial oxygen demand, or will sedation and positive pressure ventilation affect hemodynamics negatively?
Yeah, so I think what we are dealing with is a person whose heart is not functioning, and body being body is going into a sympathetic storm, right? So I think that is what we are dealing with. Now, whenever we are in a sympathetic storm, so that is where we are trying to compensate. So you have a higher BP, you panic, the body panics, the body is thinking, the heart is not having a good blood supply, heart is not pumping out properly. So I think in this scenario, calming the body down as soon as possible, finding out what is the culprit vessel or culprit issue, shifting the patient for a definitive management would be what I would go for. In other simple terms, since the patient is on a sympathetic overdrive, and even if you see the heart rate is around 179, so I think more the heart rate, more the heart is going to pump, so the oxygen demand is going to increase, and it's kind of like a vicious cycle. Oxygen demand increases, and in between these contractions, your coronary filling again goes down. So it's the demand is increasing, but the supply is going down. So what I would want is to cut down the sympathetics at this point. Cutting down the sympathetics is not just the goal in this. I think patient is also in something called as a respiratory distress and a phlebitic pulmonary edema. So I would want to have a better ventilation for the patient. So I would go ahead having an RSI for the patient. Meanwhile, preparing for a crash, preparing for any adverse effects that might happen with intubation and mechanical ventilation. I think Kunju might have a difference in opinion, or are you standing with me?
Obviously, I have a difference in opinion. You've chosen to intubate the patient like a true emergency physician. So I'm going to choose to optimize the patient first. This scenario is seeming like a patient who is in failure in acute pulmonary edema, like a SCAPE scenario. So in such a scenario, we have our trusted friend NIV. I think that we can again try to oxygenate this patient and deal with the pulmonary edema with NIV. So you can not only just NIV, NIV would give the PEEP as well as positive pressure support, but also you can start the patient on nitrates, a nitrate infusion as well as the positive pressure ventilation with your NIV, and then optimize the patient. Because if you look at the scenario, the SATs are 92 on NRBM. I believe starting NIV, giving more FiO2 and nitrates can optimize this patient for safe transfer for PCI again. So I would want to go for that, and for anxiolysis and you can start maybe a low-dose fentanyl infusion. Why do we have to rush to taking airway and in an invasive manner when the goals that you want to achieve can be achieved by non-invasive ventilation?
Yeah, but how much time do we have? I mean, maybe 90 minutes, 80, 90 minutes. I mean, when the patient comes in, already some time is gone with, the initial approach, getting an IV line, starting on oxygen. How much more time do we have to put on NIV, start an NTG, wait for the patient to respond, and then shift the patient aramse to the cath lab? How much time? I mean, why don't we just intubate, mechanically ventilate, bring down the heart rate, control the ventilation, reduce the afterload, left ventricular, give a better chance at more cardiac output, more coronary perfusion, maybe reduce the oxygen demand of the heart, and reduce the oxygen demand of rest of the body, give the respiratory muscles some rest. I mean, why can't we do that earlier and then shift the patient to cath lab?
I agree that there is a time crunch here, but there are studies that show that you starting NIV for a patient who is having a scape scenario, it can delay the intubation as well as sometimes it can even forego the entire intubation in itself. So giving a trial to a patient who is in frank respiratory distress with NIV and nitrates is something that we do often in the ER, that we have any patient who presents to you in such a scenario, you're not going to directly think about taking the load of the patient by intubating. You can always give a trial of NIV, and if it fails, obviously you're going to, it's not about not taking airway, it's about delaying the airway or being prepared for the airway. In the meantime, you're also trying to optimize the patient, and that's the approach that I would want to stick to. Delay but not eliminate.
Okay, but I don't know, but the second question was maybe how does it affect the oxygen demand?
Yeah, so the second question is the sedation and positive pressure ventilation affecting the hemodynamics negatively?
Yeah, sorry. So in this scenario, sedation and positive pressure ventilation will definitely not affect the hemodynamics negatively if you do it in a controlled way. Now, in such a scenario, you can go ahead, use the drugs of your choice, and without any calculation, you can just go ahead and do it, in which way even the body will be like, I'll take my choice, I'll take my shot and do whatever I want. But for this patient, having a controlled way, so in any intubation, mechanical ventilation, advanced airway, there is always a preparatory phase, okay? It's not a pre-anesthetic checkup kind of preparatory phase. There is always a 3-4 minutes where you step back and think, okay, am I ready with the equipments? Am I having an advanced help? Am I having a senior support? So all these things in place. Am I having the devices that are required for a difficult intubation? Am I having the drugs necessary? Am I prepared for the bad thing that is to happen? Okay. So if you are not prepared for the bad thing to happen, then bad things happen to you. Okay. So you should be prepared for the hemodynamic compromise, but if you aren't, that hemodynamics is going to affect you. For example, if in this scenario, if you are going to use propofol to calm the patient down and give him a good dose of fentanyl, you are likely to push him down the lane to cutting down the sympathetic as well as cutting down the hemodynamics, hypotension, and then that's it. But in a different scenario, if you try to give him an etomidate, if you try to give him a controlled fentanyl, or maybe if you start him on a low dose inotropes and adjust it as per the BP falling down, or maybe even think about delayed sequence intubation. Even in this case, you can actually think of DSI also. So I don't think hemodynamics is a big problem here if you do things calculated. So
I would still like to say that my approach
so there
by
are no
NIV...
particular studies that are actually going to say that in such a scenario in SCAPE, we have to go for definitive airway or we have to go for non-invasive ventilation. So that's what, so right now we have to think of whether we have to intubate or we have to go with delayed sequence intubation. So that is how we have come up to, okay? So let's move on to this next scenario. So going to case 3, it's a 72-year-old female with inferior STEMI with complete heart block. BP is 60/30, and heart rate is only 30 with no response to atropine. Saturation is dropping, increasing work of breathing, and the patient is developing altered sensorium. So the question is, should we intubate immediately as part of resuscitation, or should we prioritize transcutaneous pacing first before airway control?
Okay, I want to
Start.
just for a change, I want to intubate here. Well, before intubation, I would obviously start off with some something to optimize the patient to make him ready for intubation. That is, I would start with inotropic supports. Here the heart rate is 30, the BP is 60/30. So going ahead and doing RSI is going to be a gutsy move. And to do something like that, you would have to optimize the patient. Obviously, patient has not responded to atropine. So you'd have to start on inotropic support to increase the BP. It's an inferior wall STEMI. You can also start with fluid resuscitation. And following that, you can prepare the patient for an RSI, and you can try ketamine and succinylcholine if there are no obvious contraindications, and then plan for pacing this patient.
No,
and because we are ER guys, we'll try for our transcutaneous pacing. In the meantime, activate your cath lab. That would be my approach in this case, because I find this patient to be very decompensated. 60/30, rate is 30,
But
SPO is dropping.
don't you think that it's kind of like a unstable bradycardia that we are dealing with?
Yeah, so
And don't you think we can just make everything right by just, making the bradycardia right?
what if you were to face with an arrest while you are doing that? Like, I'm trying to, my approach is to try and get the airway so that I don't have a crash
So
airway.
you're thinking that maybe once you give the sedation, you might have a collapsed airway, and then you're going the other way around. You're just going to intubate and then sedation and then going that.
Because the patient is already too decompensated. Like, these are not numbers that I want to see in my patient. So I would have to treat it, get the airway, because I'm looking at an airway that's going to crash on me at any point.
All right.
So that would be my approach.
But he's just developing altered
Like-
sensorium. There is increased work of breathing, so he's going into a respiratory distress issue. On top of that, hemodynamically, he's getting unstable because of that CHB. Now, inferior STEMI, we have an ECG which shows an inferior STEMI. So why don't we just, start off with the pacing, or maybe get 2 IV lines, start off with an adrenaline infusion, dopamine or adrenaline infusion. And why don't we just wait and watch, and maybe the heart rate improves without even the pacing. And we can even avoid the airway. So once the heart rate comes up, your cardiac output comes up, your perfusion increases. So once your perfusion increases, the oxygen is received by so many of your organs which are in high demand. So your distress goes down. So why don't we just wait? I mean, why are we jumping to intubation in this patient?
Let's be real. Are these the numbers that you're not going to think about intubation with these numbers that we have on?
I mean, it's not about the numbers. It's a CHP it's an unstable bradycardia. That is what I see in this case.
Okay.
So why don't we just...
I'm not saying that we shouldn't pace this patient. I'm trying to say that this seems like an airway that's going to crash on me at any point. So I want to secure it. I'm also doing measures to optimize the patient simultaneously.
No, but he's just developed altered sensorium. He's not in altered sensorium. He's developing. He's not completely agitated.
Yeah, but
restless.
the procedural sedation is definitely going to tank the BP further. It's going to,
No, why don't we try with ketamine?
For you to pace the patient, you will have to start sedation, right? So that's going to tank everything. So why not have an airway in place?
Then I think we can go with ketamine.
How long do we have to actually wait till the adrenaline infusion starts and then the heart rate improves and the BP improves?
How long should we wait?
Yeah, that's what. You have to actually start the infusion. Anyways, by the time we are starting on all those medications, even the textbook says, even all our this thing says that we have to actually go for transcutaneous spacing for sure.
Okay.
Okay, at least transcutaneous spacing has to be done,
so
and
it's
next is the
basically-
transvenous spacing that we have to go for.
True.
So
So
with the
transvenous
developing
spacing goes to your
altered
management,
sensorium-
and then we have your, if you treat the underlying cause and it corrects the rhythm on its own, then there is no definitive pacemaker that is going in place. Now, I think transcutaneous spacing or inotrope is what our option is, or it's combined. So it's basically operator dependent. Why can't we just give a procedural, okay, if you want to go ahead with transcutaneous spacing, why can't we do a procedural sedation with a ketamine, wait for an impending airway? I think ketamine is going to push up your heart rate and BP, and then
Okay, a saturation drop is happening, he's having an increased work of breathing. So for that, what are your approach going to be? Like with the airway, what is your
SpO2 is dropping because your demand is increasing and your dead space is losing its oxygen supply. So you need to push in more oxygen. So a HFNC or an NRBM should work with filling your dead spaces with oxygen. So you're going to have your oxygen reserves. Now, increased work of breathing, definitely, because you're in distress. So I think your distress can be cut down with the control of your arrhythmia if you have an impending airway collapse, and I think that is when we...
Okay, so I think this would be an interesting case for audience also, because here also we are in a confusion whether one person is ready to intubate the patient and the other person does not want to go with NIV also.
LMA in, at
Sorry?
least put an LMA in so that I don't lose the patient while I'm
Yeah,
trying
so anybody who has an opinion on this or want to say or give a voting on both of them, which approach would you like to have? Because this is a really interesting case. I don't think
this actually happens when you
has a
have
clear
two
cut-
seniors on shift who are egoistic. I mean, if they're helping each other, then it works out. But you have two seniors and very less number of patients, then this happens.
Yeah, suppose if you are the emergency physician on floor and this is how the scenario is where both of them are having a fight, thinking that someone has to actually start with the NRBM, the other one has to intubate. So where do you stand? Or whom do you stand with?
Or maybe you might be the only emergency person and someone from the ICU comes down to help you. This happens.
To make the scenario worse.
Hey, I really want to know what you guys think, because I feel like we should get an airway here, and Danny doesn't.
Yeah, how many of you actually want to intubate this patient before taking the patient for transvenous or transcutaneous spacing? Nobody wants to intubate. Okay, there are 2, 1, 2, 3, 4, 5, 6, 7, 8. Okay, 8 of them want to intubate the patient. Anybody who wants to just optimize the patient with an RBM or maybe high flow oxygen system, how many of you want to do that?
It's not just the NRBM, it's...
Yeah, just to optimize the hemodynamics without going for intubation. Okay, 1, 2, 3. Rest are not going to do anything.
Don't want to.
Rest of them are sleepy.
What are you planning? Like whoever has not actually puts their hands up, what is your plan of treatment or what is your plan of approach to this patient? Nobody has an answer for that.
Prasad, what would you do, man?
He did answer. He wants to intubate the patient before optimizing.
Abdul, what would you want to do?
Intubate the patient.
See,
All the seniors on shift want to intubate.
No, it should be with the answer and with one good reason.
So ER is packed right now. You all should go upstairs and debate over there who to intubate and who to not. Right?
Okay, man, we'll go.
You all want to go in action? Anybody wants to summarize?
Thank you, guys.
Anybody wants to summarize this or would like to give an opinion on this? Dr. Nitin or any of the seniors? Good.
What I'd like to say is that I don't think there is a right approach to, there's no right and wrong here. It's patient to patient, doctor to doctor, and what's happening on the floor. So it's about working as a team in ER and deciding what is best for the patient. So I don't think most of these scenarios are really worrisome scenarios. They are not like they are gray areas. So let's not fight. Let's just decide what's best for the patient. And remember that the right outcome does not mean you have always been right in your process. So always go back and see if you were right. And that's about it. Thank you.
One more thing I just want to add to what she said. Just one sentence. Be the doctor that you want to see when you take one of your loved ones to the hospital. Okay? I think everyone understood what I meant. Right?
Thank you, Dr. Kunjalakshmi and Dr. Danny for this wonderful talk. Hopefully you might come across these kind of cases soon or near future. Just be ready for all those cases. Thank you.
So can you come and felicitate Kunju and Danny? Yeah.
एक ही सेकंड ना Ravish, 1 second. Check कर.
So we come to our last segment, the young faculty talk. I think this segment is very important because the youth is the future of our ED, is the future of our nation. So let's welcome 6 different residents from 6 different hospitals who have actually enrolled to give the young faculty talk. Can I have you all in front, all the young faculties? Dr. Krishna, Dr. Lavanya, Dr. Abdul, Dr. Nikhil, Dr. Shiksha, and Dr. Mandar. They'll sit in front. Huh. So, I know I've told you the rules quite a lot of times, but I'll just say it again. Every talk is 10 minutes each, and the buzzer will go off at 8-minute mark, at which point your presentation will close. And the judges will get 2 minutes to ask you questions, and then they will score you accordingly. A winner will be announced at the end of the talk. So 10 minutes each. We have 6 faculties right now. Okay. Dr. Sandeep, 8 minutes each, and 2 minutes judges questions from judges. So 10 minutes each. And okay. So Dr. Sandeep Gore and Dr. Kushrab Bhajan are judging you. So can we have Dr. Krishna on stage, please? Dr. Krishna Nambiar is a resident from Jahangir, Pune. So please have an applaud.
Good evening, respected dignitaries on the dais and delegates present here. I'm Dr. Krishna Ashokan Nambiar, just completed my DNB emergency last week from Jahangir Hospital, Pune. So I'll be discussing on a case of a concurrent cardiocerebral infarction, which is rare and that has been presented to our emergency department. So before going to the main case, I would like to give a small introduction. So as you know, this acute ischemic stroke and acute myocardial infarction are both the life-threatening medical emergencies that we come across daily in our emergency department. And both entities do require emergency action, early diagnosis, treatment, and both of them have got a narrow therapeutic time window. So we have seen either MI or stroke coming, but simultaneously both cardiocerebral infarction presented within 48 hours and has been reported with an incidence of 0.009% in the whole world, and it is not yet well studied. So moving on to the case, we have a 52-year-old male presented to the emergency department with sudden onset of right facial palsy, right hemiparesis, aphasia, and he was last seen normal 2 hours prior to presentation to the ED. Along with the patient complained of chest pain and sweating. So the past medical history, the patient had a history of diabetes, hypertension, and he was non-compliant to both the medications. And there were no history of any breathlessness, headache, or visual disturbances. So moving on to the ABCD, we have seen airway pattern, though aphasic, and breathing-wise, respiratory rate was 18, and saturation was 98% on room air. Circulation BP was 150/90, and pulse rate was of 72 beats per minute. His GCS was E4, V2, M6, motor aphasic, and positive systemic examination was the tone right side was decreased, power right upper limb and lower limb was 3/5 with plantar's extensor on the right side, while left lower limb was normal, and NIHS was 15. Patient also had an intact cranial nervous system examination, sensory system examination, and normal cerebellar examination. So moving on to the adjuncts, as we know, the patient had this chest pain and sweating history also. We did a ECG which showed a ST segment elevation in the 2-3 AVF, and along with that we also moved on to 2D echo which showed an apical and apicolateral hypokinesia with EF of 40%, and there was no obvious clot formation or thrombus in left ventricle. So being in ED, we have announced a code cardiac as well as a code stroke because the patient has both neurological symptoms as well as the cardiac symptoms. So initially, first DD was aortic dissection, like morning we have heard. The patient can be presented with both MI as well as stroke. We did a CT aortogram to rule out, and that was showing no aortic dissection. And finally, we did a CT, brain with angiography. You can see that there's a loss of gray water white matter differentiation in the left temporal parietal region, and the patient not have any hemorrhage, and there was a non-opacification and short segment of left middle cerebral artery according to the angio present. And how we proceeded was that this was a rare case. So after a discussion with the neurologist as well as a cardiologist, we proceeded to thrombolize the patient. Since the patient presented with 4.5 hours and with ingestion altiplay 0.9 mg per kg, 70 mg, and door to needle time was 55 minutes. And after the thrombolysis within 1 hour, patient's symptoms improved from 3/5 to 4/5, and also there was a slight improvement in the speech. And on day 4, the patient was taken up for coronary angiography, which showed critical triple vessel disease. And subsequently, the patient underwent PCI to LAD and RCA, like you can see from the images. Patient was discharged on day 9 with a power of 4/5 in right upper limb and lower limb, and there was an improvement in the speech also. So finally, initially, but after the discussion, we came to the diagnosis of concurrent cardiocerebral infarction. We also did an MRI which showed on the day 2nd, which showed a large wedge-shaped area of respiratory diffusion in the left parietal lobes involving the insular cortex and left external capsule. So a short discussion on what is concurrent cardiocerebral infarction. There are 3 types. Type 1 is concurrent CCI, type 2 is ischemic stroke after recent MI, and type 3 is MI after a recent ischemic stroke. So moving on to type 1 of concurrent CCI, there are 3 types. Type 1A, which because of cardiac causes like AF, the type 1 aortic dissection, electrical injuries. Type 1B, brain causes that you can see from my patient, it was a parieto-insular region stroke. And type 1C, which is basically due to non-cardiac and non-brain causes, especially like COVID-19 infections. So what is type 1B insular cortex or type 1B CCI? There has been a laterality hypothesis which is still being studied by many cases, many guidelines, which shows that right insula is a center of sympathetic control, and any lesion on the right insula can cause a parasympathetic activity. While in this patient, my patient had a lesion in the left insula, which was a center of this parasympathetic control, and that lesion can cause into sympathetic overactivity leading to any MI, myocardial infarction, arrhythmias, and this autonomic imbalance can result in myocardial injury, cardiac arrhythmias, and sudden cardiac death. And according to AHA guideline, which released in 2018, they say that if initially as a patient present with such symptoms, we can go with CT as well as an ECG, and the patient is hemodynamically stable and there was no contraindication for thrombolysis, we can plan for the injection altiplase 0.9 mg per kg over 10% in the first 10 minutes and next 90% over 1 hour. And we prefer the stroke dose because we don't want the patient to go into any hemorrhagic transformation. And finally, the patient can be taken up for PCI. And if any large vessel occlusion is present, patient can be taken up for intravascular treatment. So I'm ending my discussion on that. Like management of concurrent cardiocerebral infarction can be challenging for an emergency physician, as a management of one can result in the delay of the another medical emergencies. But as you know, more guidelines are coming up, more interdisciplinary collaboration, enhanced awareness, and timely detection and intervention, so we can mitigate the devastating impact on this complex and often life-threatening condition. And even my patient, after 3 months follow-up, he had come to the ED as well as in the OPD, and patient has got a very drastic improvement in the speech as well as power, and patient is able to do day-to-day normal activities. Because in the studies we can see the mortality rate is almost 30 to 40%, and survival rate is only 1 to 2% according to AHA guidelines. These are my references. Thank you.
Thank you, Dr. Krishna. Finished before time. That's a good quality. Next we have Dr. Lavanya Thote. She's from Holy Family Hospital, second year resident.
So, hello everyone, myself. So, hello everyone, myself Dr. Lavanya Thote, second year MEM student. Today I'll be discussing two curious abdominal pain in the emergency department. Going on the first case, 58-year-old patient walked in an ED at 3 a.m. in the ED, severely groaning in the pain. Patient appeared to be very restless and he was complaining pain over the left flank region, and he was not willing to lie down on the bed due to the severe pain. Patient was immediately triaged as ASI category 2 and was taken on the bed number 1, which is a high acuity zone in our department. In emergency department, we triage the patient basis on the ESI category. Now, what are the ESI category? ESI category 1, where the patient requires urgent life-saving intervention. Example, NIV, intubation, CPR, fluid bolus, inotropes in the shock. ESI category 2, where it is a high-risk condition, critical condition, but does not require immediate life-saving intervention. Example, chest pain, any pain score more than 7. ESI category 3, patients are hemodynamically stable, but multiple resources are used. Example, abdominal pain, where we do radiologic investigation, lab testing, injections and all. ESI category 4, hemodynamically stable patients, but only single resource is used. And ESI category 5, hemodynamically stable, no single resource used. We can treat them on the OPD basis. Now, what do you see, smell here? Patient is restless, profusely diaphoretic. He was not able to lie on the bed due to the severe pain. Patient has left hand pain over the left rack region. Vital parameters on arrival were patient was tachycardia, tachypneic, SATs he was maintaining 100% room air. Pain score was 9. Going on the primary survey, airway he was maintaining, airway pattern. Breathing he was tachypneic, circulation was tachycardia, GCS he was holding 13/15. He was confused and localizing pain. Exposure wise he was restless and diaphoretic. Going on the immediate intervention, we did 2 IV cannula, 12 ECG, telemetry monitoring, and defibrillator attached. Secondary surveys, head, neck, face normal, chest, lung, heart clear, S1, S2 heart. Abdomen, he was having tenderness in the left flank region, no abdominal brumention, extremities, all distal pulses present. Going on the sample history, signs and symptoms, patient was having severe left flank pain since last 2 days. He was not allergic any medicine. Medication, he was on hypertension and diabetes. Pertinent medical history, he was only for hypertension. Last meal 9 p.m. What was the event exactly which led him to bring ED? Simultaneously he gave the history that he was engaged in the physical exertion like game of tug of war 2 days ago, which he was he was following that symptomatic lower back pain. Pain was attributed to physical activity and did not seek any medical attention. However, when he had the dinner, postprandial he experienced severe pain. We did investigation. ECG shows sinus tachycardia, blood gas, 2D echo screening we did in ED, point of care HS tropi, basic CBC and create, CFT, abdomen, pelvis, plain and IV contrast also. Going on the blood gas pH, it was showing metabolic acidosis with lactate of 9.84, create was slightly elevated. 2D echo screening, EF was well preserved, RARV not dilated, IVC was not distended, it was 18 mm collapsible. We gave symptomatic pain management to this patient, paracetamol, tramadol, Dynapar, everything. Going on the case history 2, 44-year-old male came to the department at 8:10 p.m. with a complaint of severe diffuse abdominal pain and lower back pain, which was non-radiating in nature. Patient was immediately taken on the bed number 1, which is a high acuity zone in emergency department, and was marked as ESI category 2. What do you see, smell here? Patient is profusely diaphoretic, unable to lie on the bed and wants to sit. Appears to be very discomfort. Going on the primary survey, airway was patent, breathing was mildly tachypneic, circulation was normal. GCS he was holding 12/15, he was spontaneous eye opening to speech. He was confused and localizing pain. Exposure-wise, he was restless and diaphoretic. Immediate intervention was IV cannula, 12-lead ECG, telemetry monitoring, and defibrillator attached. Going on the secondary survey, head, neck, face normal, chest, lung, heart clear. S1, S2 heart, abdomen, he was having tenderness in the epigastric region. No pulsatile abdominal mass noted, and extremities, right dorsalis pedis was absent. Rest all distal pulses present. Vitally, heart rate was 60 beats per minute. Pressure on right hand, it was 200/100. Left hand, it was 190/100. SATs, he was maintaining 100%, and pain score was 8/10. Going on the sample history, he was having severe epigastric pain. No allergy. Medication on hypertension and diabetes. Last meal was 3 p.m. lunch. What events were patient had symptomatic lower back pain, exertional pain. That's why he went to a general practitioner. General practitioner suspected ACS versus MI. That's why he was advised to go for the higher center with a referred cardiological note. Patient had taken only hypertensive medicine. Investigation done was ECG, blood gas, HS tropi, which was positive 78, CBC create. Along with that, we did serum amylase lipase, CT abdo-pelvis plus CT aortogram. This was the 12-lead ECG on arrival, which showed the ischemic changes. Blood gas, he was having metabolic acidosis, again lactate of 6.87, creatinine was 1.64. So we gave symptomatic pain management for this patient, and this was the differential diagnosis which we were thinking. Aortic dissection, acute coronary syndrome, abdominal aortic aneurysm, rupture, mesenteric ischemia, renal calcula, pancreatitis. Next step was high-risk consent was taken to perform the CT abdo-pelvis in view of high creatinine. Relative was counseled regarding the poor fatal outcome of the disease, and risk for the dialysis was also explained. Need for emergency surgery was also explained. Patient was started on mucomex as creatinine was elevated. What challenges we faced were patient gave the history of tug of war, which undermined the gravity of symptom to the family initially. Location of pain was initially benign, suggestive of ureteric calcula. All disturbed pulses were also present. Then CT abdo-pelvis contrast of case 1. There was a large fusiform aneurysm of the abdominal aorta below the ceiling trunk up to the aortic bifurcation, and also hemorrhagic is also seen in the left perinephric space, displacing the left kidney anteriorly. However, there was no active atrial extravasation noted. Next step, report was informed to the cardiovascular surgeon. From emergency, we reserved 6 spine to the 6 spine, and patient was shifted to the ICU and was planned for the surgery mid-noon as patient relative were having financial crisis. Then outcome for case number 1, patient went to the hemorrhage shock in the ICU. Patient underwent skin grafting same day, 4 p.m., but ultimately patient succumbs on the same day. And CECT abdomen of the case number 2, CECT abdomen with aortogram. He was having acute thrombotic occlusion of the abdominal aorta below the level of the superior mesenteric artery with non-enhancement of the distal vessel. And also thrombotic occlusion of the distal splenic artery noted with the wedge shape hypotenusing the ischemic area in the spleen. Next step, cardiovascular surgeon was taken in the loop. Case discussed with the family, and poor outcome was also discussed with the relative. We started patient with the heparin in the ED. Patient was shifted to the ICU and planned for the surgery. But this patient also had financial issue and he was also not getting settled with the pain. Ultimately, this patient also went for this grafting surgery and this patient also succumbed. But what is this? There were two cases, aortic dissection and aortic occlusion. Aortic dissection, what is that? It is a tear in the intimal.
Thank you, Dr. Lavanya. Next up on stage, we have Dr. Abdul Rahman. He's a resident from Safety Hospital, I guess. Where are you now?
Hello. Welcome to Saga of a Broken Heart. Today, my topic would be mending a broken heart. So let's start with this unusual case. Okay? So, mending a broken heart. We'll see about a case case presentation, investigations, treatment, and the outcome of the patient. So good evening, everyone. Myself, Dr. Abdul Rahman Khatan, MBBS MRChem, and presenting a case of a young boy, 16-year-old boy, comes to ED with a heart failure. Let's see how it goes. So a 16-year-old male presented to emergency department with chest pain and productive cough and dyspnea. Dyspnea is NYHA class 4 for 2 days. There was a negative history of any sore throat or fever or any infective history. On arrival to the ED, let's go with the ABC. His airway was intact. Breathing was, I've highlighted the important ones. Desaturating with SpO2 79%. He was tachypneic with 35 per minute, tachycardic 139 per minute. Disability was okay, pupils were okay, exposure was okay. There was nothing wrong with it. On physical examination, his peripheries were clammy, delayed capillary refill time. Looks like the patient was in shock. On systemic examination, the only positive finding which we got was respiratory system. He is having bilateral diffuse inspiratory crepitations. Now, let's move on with the investigation part. The first thing which we did was doing an ECG. On ECG, we could see this. LVH with strain pattern. Based on the Sokolov-Lyon criteria, he is having left ventricular hypertrophy. We did a chest X-ray which showed cardiogenic pulmonary edema, bilateral hilar haziness. Then we have screened the echo for the patient. As you can see, what we can see, there is a thin rim of pericardial effusion with a very poor EF and generalized LV hypokinesia in this patient. From this 4-chamber view, parascending short axis view, we can see that dilated left ventricle. Formal echo showed the same thing, transthoracic echocardiogram, dilated and globally hypokinetic left ventricle. What we did in the ER, as usual for the heart failure thing, NIV support, Lasix, NORAD, and a consult with a cardiologist who may have suspected something for which we have started methylprednisolone. Now what it is? So the labs have come right now. The only positive finding I've highlighted was WBC counts 11,000, and we have done a CPK. CPK turned out to be 429, and positive troponin, HS troponin I, which was 199.4 in this case. So these are the positive findings. Rest all lab seems to be normal. So, we are now suspecting a myocarditis case. So earlier, the definitive diagnosis for this was endomyocardial biopsy to prove the diagnosis. But since the nature of it was very invasive and it has a very low sensitivity, now the paradigm has been shifted to doing a cardiac MRI. So we have proceeded with the cardiac MRI. And that's how we found out that the little bro was having acute myocarditis, which has led to heart failure. So we have started the treatment with heart failure with reduced ejection fraction with a beta blocker, diuretic, SGLT2 inhibitor, ARNI, and a steroid, 10 mg TDS for myocarditis thing. Over the next few days, the patient improved, inflammatory markers improved, CPK troponin improved, and he was gradually weaned off from NIV support and started on 2-liter nasal prongs. And patient was happily sent home with the above mentioned treatment after 10 days of treatment. Okay? Is this the end? Not really. On the same night, what happened? At home, the patient developed generalized seizure-like symptoms. He was brought back again on the same night. He was having just complaints of headache and dizziness. We did an examination, ABCDE assessment was absolutely fine. He was not crashing or anything. CNS examination appeared to be normal. He was not having any focal neurological deficit. But just because of the dizziness and headache, he was sent for the MRI. Let's see what it comes out to be. So this was the MRI image of this patient. As you can see, there is ADC hypointensity with some hyperintensity in the DWI imaging, which was significantly showed in the FLAIR image as well. I have pointed out the arrows for it. He has developed infarct, cerebellar infarct. Not only one place, another place, in the centrum semioval as well as that. It's in the right centrum semioval. So it's most probably due to the cardioembolic infarct, although it was not seen in the echo, which was done previously 10 days back. So my question is, can we prevent it with any low molecular weight heparin prophylactically, if we can give without any evidence of 2D echo? Let's see. We did an MRI, we found findings suggestive of acute ischemic stroke. We have started with LMWH, Clexane 40BD, and repeat 2D echo was done, which was not suggestive of any clot in LA or LV. What was the outcome? Again, 4 more days the patient stayed in the ICU and ward, and all his symptoms were subsided absolutely properly. There was no focal neurological deficit, he was absolutely fine, and a repeat echo was done, which showed slight improvement from 15% to 25% in this case, which was a very good improvement in a week's span. Key points to learn. I will just say the key points. Nearly 50% of the pediatric patients presenting with acute myocarditis will develop heart failure. So that's a very huge number. In pediatric heart disease, the thrombi within the ventricles are rarely found on echo. So we have to be more vigilant on such cases. A study has showed that stroke during the first month of diagnosing heart failure has a 6 times more risk. So that is also we need to be very vigilant about diagnosing it as early as possible and with the symptoms. Another study has found that the strokes in such kind of cases appears to be bilateral, as we can see in this case as well, and involving both the anterior as well as posterior circulation territories. Fifth more important thing is the common presenting symptom of stroke, which usually happens like limb weakness, motor limb weakness, sensory weakness in adults, usually are missing in the pediatric age group. They generally presents with focal seizures or generalized seizures, as we saw in this case. Now, recommendations about LMWH. The AHA recommends anticoagulation for at least 1 year when there is risk of cardiac embolism or a high rate of recurrence, or at least for 3 months with a diagnosed case of stroke in such cases. So these two are the recommendations which needs to be followed in every EDs in our cases, because these are very rare cases and we shouldn't be like becoming blank on how to tackle up with such cases. So what is the prevalence of myocarditis? A study from Finland has, under the age of 15 years has a prevalence of 1.95 out of 1 lakh. In USA, 0.8 out of 1 lakh. Another study, a cohort study in USA under 21 years of age had showed 0.05% prevalence. So these are the prevalence in the foreign countries. What about India? There are no large-scale studies currently happening in India. So we need of the hour is we need to do studies about this case. We need to publish studies. We need to have a research like the foreign countries. Also, we have to start all these things in India as well. Vigilance for signs and symptoms of ischemic stroke in such myocarditis patient, because it is very common, especially in pediatric age groups. Need for stroke risk assessment in such patients. And as I said, in India, the further research is necessary for optimal therapeutic and preventative strategies for such cases. I had done some homework after this case. I've done some research and I've written some article, and thankfully my article has been published in the Open Journal of Emergency Medicine. You can scan that and have a look at it with all the reference and everything. So that is my case. Thank you so much.
Thanks, Abdul. A very well presented young faculty talk. Can we call Dr. Nikhil VK on stage, please? He's a DNB resident from our emergency, Apollo ER.
So, good afternoon to everyone. So, I'm Dr. Nikhil, DNB Emergency Medicine resident. So, I'm going to start with two cases that I've come across in the first case was a 65-year-old male patient coming with known risk factors of hypertension and tobacco chemical consumption. And he had a history of typical chest pain since 4 hours. ECG didn't show any ST elevation in precordial leads, but it did show tall prominent symmetric waves in the precordial leads, upsloping of ST segment and depression of more than 1 mm at J point in precordial leads, as well as subtle ST segment elevation in lead AVR. Classically, this is known as D Winter's sign. Further angiography showed LAD occlusion, and that day I realized that there is something beyond ST elevation. And second case, similar, we had a example of 55-year-old male with no comorbidities of diabetic and hypertension presenting with chest pain since 3 hours. ECG shows biphasic T waves in V2, V3 with no significant ST elevation, which is classically known as Wellens pattern. This apparently shows critical proximal stenosis of LAD. Similar in this case, there is no ST elevation in precordial leads. So, well, these are the two examples that I've come across of the 25% that are snubbed as NSTEMI in documents which on further study shown to have a significant occlusion. And these limitations or anomalies create a crisis further down the line, giving rise to a new paradigm, which is OMI, which was introduced by Mayers, Weignart, and Smith in 2018. And the present discussion is around the state-of-the-art review published in Journal of American Cardiology, a November 2024 session. So it all started with Q-wave or non-Q-wave paradigm, wherein the patients with MI were classified retrospectively. But the advent of reperfusion therapy, reperfusion initially using thrombolytics and then later on with PCI prompted towards new paradigm. And as a new paradigm, it became prevalent in use because of its advantages. The major being is its easy interpretability and focus on acute sign. Now, what does STEMI paradigm, ST elevation MI paradigm took into account is the ACS symptoms with ST elevation and classified accordingly. One major factor to be focused at this is that NSTEMI, even with occlusion, is classified as non-STEMI rather than false negative STEMI. Now, what happened later with advanced understanding and studies, limitation arise with the major being in the incorporation bias. Now, what exactly incorporation bias means? Incorporation bias reflects a critical error in the diagnostic methodology, wherein the indexed text, which is intended for the testing, is mirrored by the reference test in whole or in part. In the context of myocardial infarction, such bias skews the diagnostic framework, obscuring the false negative results and perpetuating the no false negative paradox within the STEMI paradigm. So you can see, because of the incorporation bias, there is a perceived increased sensitivity or increased perceived specificity. Now, this gave rise to occlusions without ST elevation, which are often missed, and there is a poor sensitivity of acute coronary occlusion. And the study showed that 56% of individuals with acutely occluded coronary arteries do not exhibit any ST elevation, and 25 to 33% of individuals classified as non-STEMI have acutely occluded coronary arteries and could benefit from immediate reperfusion. Now, 6% of the individual classified as a very high risk non-STEMI event actually undergo angiography in less than 2 hours. So that resulted in occlusion MI paradigm, which in comparison to STEMI paradigm were based on whether there is occlusion or not. And the owners shifted to identifying patients who require emergent reperfusion and those who do not. So the new paradigm took into account 4 things. One is evidence-based EC changes beyond the ST elevation. Second thing is expert-trained AI to identify subtle OMI. And third, echo or cardiac adjuncts. Fourth being the clinical symptoms or signs of refractory ischemia. So the ST elevation, the ECG changes beyond ST elevation, one was the South African flag pattern, which you can see in the first ECG, wherein it, because of the OMI from the first diagonal artery occlusion. And OMI from the RC occlusion resulted in Aslanger pattern, D Winters pattern, which we have seen in the first case, as well as hyperacute, anterior hyperacute T waves, and early Q waves from LAD occlusion. So RCA occlusion, as we see, it can present as STD elevation in ST depression in AVL reciprocal to inferior hyperacute T waves and ST depression in V2. So one thing is false positive can also be ruled out with this OMI paradigm, wherein you can see the cath lab is activated for this, if this ACG based on ST elevation is used to activate cath lab, that can give rise to false positive, because this also has the QS waves with small T to QRS ratio, and this is usually found in old LV aneurysm. And also the Smith modified Garbosa criteria, which is a well-known criteria in lead 3 for RCA occlusion. And the STEMI negative OMI, also the fourth last ECG. These are the ST changes, or these are the ECG changes beyond ST elevation, which are used in OMI paradigm rather than just depending on this ST elevation. So what about the sensitivity and specificity of this OMI paradigm? So later on, after 2018, when it was introduced, over the 4 years, the studies were done, among which the 4 important studies were a Saga study, which showed that 28% of non-STEMI, which were further identified as having acute coronary occlusion, and this 28% had actually had a higher myocardial damage and in hospital and in long-term mortality than non-STEMI without ACO. Without acute coronary occlusion. And the second study, Mayer study, showed higher sensitivity and as well as preserved specificity. So if you see the sensitivity, it is 86% compared to the sensitivity of 41% in case of STEMI, whereas the specificity was preserved. Now in this case, the STEMI and STEMI positive and STEMI negative OMI had a similar outcomes, but STEMI negative OMI could be identified an average of 3 hours earlier using OMI criteria. So Al-Zaiti study, which again used AI, showed that 86% sensitivity and 86% sensitivity for OMI, which is superior to practicing clinicians of 58% and 93%. So AI could reclassify 1 in 3 patients with chest pain. And the last study, last prominent study was Harman study, which showed again using AI in detecting the subtle MIs were shown to have 80% sensitivity and 93% specificity for OMI, which is superior to STEMI criteria of 32% in case of sensitivity and 97% in case of specificity. So what next from here? Basically, the shared goal needs to shift from identifying STEMI criteria on ECG to identifying patients with OMI. Now, a shift in patient-centered outcome measures, audit and feedback on all these cases require a shift in OI quality indices interventions to reflect the new paradigm. Deploying these new diagnostic techniques require not only widespread educational intervention, but also technological shift in automation. A shift in research will be required to reflect and accelerate the new paradigm. So these are the references that I've used. The first study was published in 2018, and the review was published in 2024, November, American College of Cardiology Journal. Thank you.
Thank you, Dr. Nikhil. Next on stage, we have Dr. Siksha Upadhyay from Nanavati Hospital.
Good evening. My name is Dr. Shiksha. I am from Nanavati Max Hospital. I'm a first-year AM resident. So we all know what this is. This is the ACLS adult bradycardia algorithm. And if we try to locate where transvenous spacing falls, it's right at the bottom, just below the expert consultation. The expert being a cardiologist. While we contemplate whether or not to involve a cardiologist, when to involve a cardiologist, I would like to pose the pressing question of my talk. Should emergency physicians be performing transvenous spacing in the emergency department? Who gets to make the call? Hopefully, by the end of this session, we'll get some answers. This is the backbone of my talk today, this case report, which was published in the Indian Journal of Emergency Medicine in 2024. This was a case report done in the emergency department where I work by EM clinicians that I work with. This case report was an experience that my colleagues and seniors had with a series of 5 patients they encountered in the emergency department who underwent a transvenous pacing, a bedside transvenous pacing over a 6-month period in 2023. The most common presenting symptom among all the patients was syncope, and upon doing a 12-lead ECG, we can all appreciate that all of them had a high degree AV nodal block. The management included a primary survey and all necessary critical interventions were made, starting with a definitive airway, an advanced vascular access, and all patients underwent transcutaneous pacing, followed by a USG-guided transvenous pacing. Let us see what the outcome was. 4 out of 5 patients were adequately paced, and we can see the 3 ECGs here, which show a successful capture. In 1 patient, there was failure of capture, and the catheter was repositioned by a cardiologist in a cath lab. There were 2 out of 5 cases of in-hospital mortality. In 1 patient, the permanent pacemaker was withheld because of financial constraints, and the other patient succumbed to a transmural infarct with an ill-sustained ventricular tachycardia. 3 out of 5 patients walked home after a brief ICU stay, among whom 2 patients had a permanent pacemaker placed. Moving on to discussion. All the 5 patients in this study, they had profound symptomatology and a high degree AV nodal block, which are the indications of an emergent transvenous pacing, according to this 2007 paper. In my research, I found one of the very earliest studies in which bedside emergent transvenous pacing is being done on the patient. The study was done in 1976, and it shows a 77% success rate. But the question to ask here is, are non-cardiologists performing this procedure or not? Or has it been completely taken over by a cardiologist? Let's put a pin on that. First question to ask is TVP expected from emergency clinicians? According to the Australasian College of Emergency Medicine, it is expected in pre-hospital and retrieval medicine settings, for example, from paramedics. So I think it's obvious that it definitely should be expected out of emergency clinicians, if not more. Secondly, are emergency clinicians skilled in performing transvenous pacing? This comparative study done in the US in 2004 shows that both EM clinicians and cardiology are equally skilled in performing this procedure with no statistical difference in error. In India, emergency medicine became a board-certified program in 2009 as opposed to 1970s in the US. Assuming this, I think in the near future, we can expect ER clinicians to be proficient in this procedure. This was a survey done in the UK among non-cardiology registrars, and these statistics are slightly alarming. 61% doctors had not performed transvenous pacing before they became registrars. 18% only felt confident in performing transvenous pacing. Only 7% received any formal training, even though this was within the established curriculum. And 84% felt that their on-call consultant will not be able to perform this procedure. Transvenous pacing had a 95% successful capture rate in this 2016 study, which was again done in the US, and it also had a good prognosis. In my literature review in India, I did not find any studies where transvenous pacing is being done in the ED. However, this particular study was done in Kashmir by cardiologists, where they used unguided technique, and it had a high procedural success rate. What's very interesting about this study is that the cardiologists at the end strongly recommend clinicians who work in primary and secondary healthcare setups to know how to perform a transvenous pacing, since it's a life-saving procedure. In the ER, we advocate for USG-guided transvenous pacing. All my 5 patients underwent a USG-guided transvenous pacing since it's feasible, safe, and it saves time. I also found 2 very interesting studies on how EM residents can be trained using these inexpensive conceptual models, which improve the confidence of EM residents, and simulation-based learning improves their ability to perform transvenous pacing in the ED. So by now we have established that transvenous pacing is a core emergency skill. It is an endangered skill. If given adequate training, EM clinicians can perform transvenous pacing as proficiently as cardiologists. Where does that leave us? I am advocating here for a multidisciplinary approach to transvenous pacing in the emergency department. Why? It forms a bridge to permanent cardiac pacing. It decreases time to complete the procedure, and it has fewer complications, and it improves the clinical outcome in the emergency department. I would just like to end on a note while you read the key clinical messages that up until 30 years ago, procedures like endotracheal intubation and advanced vascular access were considered to be fortes of only anesthesiologists. And I think if that shift was made 30 years from then, I think the similar shift can be made in terms of transvenous pacing. And it's no surprise that a few hours ago, Dr. Kanwar said the same thing. So I think that by empowering more EM clinicians to perform transvenous pacing in the ED can save lives, and especially in settings where cath lab may not be available. For example, in my institution, where there's only one cath lab, which is utilized by all specialties. So I strongly think that we should empower more ER clinicians and we should train them to perform transvenous pacing in the emergency. Thank you.
Thank you, Dr. Siksha. Dr. Mandar, you're up next.
Good evening all. I'm going to be presenting a very rare case of a myocardial infarction. So we had a patient, a 70-year-old female, who had come to our emergency department with complaints of giddiness and hypotension. She had a history of a bee sting about 6 to 8 hours prior to presenting to our hospital. She had then gone to a local hospital and then she was referred to our setup. And on arrival, her pulse rate was 150 beats per minute and her BP was 100/60 and she was on a noradrenaline infusion. Her respiratory rate was 28 cycles per minute and her SpO2 was 96% on 6 liters of oxygen. Her RBS and temperature were normal. So we did an ECG and the ECG was suggestive of a broad complex tachycardia with ST segment elevation in V2, V3, V4 and V5. So since the patient had a history of a bee sting, we gave her epinephrine 0.3 to 0.5 mg IM and hydrocort 200 mg IV. And since there were ST elevations, we gave her a loading dose of ecosprin 300 mg, clopidogrel 300 mg and atorvastatin 80 mg. And we loaded her with unfractionated heparin of 5,000 units. So, like we have been having an ongoing debate with the cardiologist, we also had a debate with our cardiologist and they advised her a pharmacological cardioversion where we started her on infusion amiodarone and a dobutamine 250/50. So, we did a POCUS at the same time and the POCUS was suggestive of a global LV hypokinesia with EF of about 15 to 20%. So, troponins, the cardiac enzymes were sent at the same time which were elevated. And the patient was then admitted in the cardiac care unit. And once the cardiologist performed a coronary angiography, it was found to be completely normal. And the patient was continued on inotropic supports and dual antiplatelets and anticoagulant. So this is known as a Coney syndrome, in which we have a history of allergic exposure. In this case, it was a bee sting. And ECG and the biochemical evidence of acute coronary syndrome was present in this case, and the coronary angiography findings were completely normal. So gradually the inotropic supports were tapered off, and the ECG findings in this patient were that the ST elevations which were present initially had completely subsided, and the EF at the time of discharge had improved to 30 to 40%. So what is Cooney's syndrome? Cooney's syndrome is basically it is defined as a coincidental occurrence in which acute coronary syndrome occurs due to hypersensitivity reaction. So it is also known as an allergic angina. So we have three types of Cooney syndrome. The first one is one in which we have a coronary vasospasm. The one thing to note in these patients is that these patients don't have any prior history of any risk factors which could prompt a myocardial infarction. So type 1 is one in which the patient has no predisposing factors, but the allergic exposure causes release of mast cells. The mast cells degranulate, release the inflammatory mediators, and that causes a coronary vasospasm, resulting in a demand-supply mismatch, causing a myocardial infarction. And since there is no risk factor here, a coronary angiography reveals completely normal coronaries. The second type is a coronary artery the development of a thrombosis. Why does that occur? Because in these patients there might be pre-existing factors which are not active or which are quiescent at that time, and the exposure to the allergen ruptures the collagen core, and there is a release of the plaque, and there is a thrombosis. So in this case, we treat these patients with the normal myocardial infarction protocol, and also at the same time we have to remove the offending allergen. And the third type is a stent thrombosis, in which the stent which is inserted in the patient itself acts as a nidus fallen allergen, which results in a thrombus formation and a subsequent myocardial infarction. So what do we do in this case? We have to remove the stent, and that is how we can treat the myocardial infarction in these cases. So a prompt identification and treatment of the allergic reactions along with our standard ACS protocols and management of acute myocardial infarction is important. If the patient is not in shock, we can use nitroglycerin or calcium channel blockers to facilitate coronary vasodilatation and improve the condition of the patient. Since in this patient, the patient was in shock, we could not use a nitroglycerin. And the prognosis depends on timely diagnosis and management. So in this case, early diagnosis and multidisciplinary approach along with the emergency physician and cardiologist is important, so that such cases can be managed with proper care. And in these cases, we have to treat the offending allergen, and that is enough to improve the outcomes in the patient. Thank you.
Thank you, everyone. That was the end of Young Faculty Talk. We'll have the winners in some time. Till then, you all can enjoy some tea, coffee, and there's some snacks also. And we'll be giving out Kahoot winner gifts as well. We also have a last Kahoot session. Dr. Akshay? Yeah. So... Sure. Okay.
All did quite well. Certain cases, I think Krishna Lambiar presented quite well with stroke and MI at a time together. Lavanya escalated couple of atypical abdominal presentation cases. Abdul's case was quite interesting and very good, means echo images and everything was very comprehensive. Nikhil addressed very important topic because the relevance of topic is very important. He has shared that one paper, he has given one reference of one paper which was published in 2022, but this year one paper published by American College of Emergency Medicine regarding OMI-NOMI paradigm. So it's a very, very important topic he has discussed, and this now the term STEMI and NSTEMI has been absoluted. Now we have to focus on OMI, NOMI, means STEMI, negative occlusive myocardial infarction. What they are, very high risk NSTEMI, plus the deep inter's pattern, then this South African flag sign pattern, he has described quite well. That is quite interesting topic. Then Shiksha's topic was also very good because every emergency physician should be doing this transvenous pacing. Yes, I did first transvenous pacing I did in Jahangir Hospital when I was there. Dr. Ajit Mehta's patient was there in complete heart block I put from IJV. And then it's whenever required we should be able to do this. Very simple. Though the one who can put a center line can do this line. So this is a very important concept she put for discussion. And this allergy causing acute myocardial infarction, last topic was quite interesting. So all have done very good topics and very nice topic. But of course we have to choose two. Okay. So we have, we have certificate for all. All will get, but two means all presenters will get gift. All presenters will get certificates, but two presentation will get the registration of MCon free for Delhi. So these two presentations are this Nikhil and Abdul. Okay. And this was unanimous decision.
Yeah, absolutely. And I think all 6 of you all are winners. First of all, coming and presenting here is very, very important. And you all should always try to present cases and get confident with, answering questions. For shortage of time, we couldn't ask you all questions. We would have really checked your mettle out. But there were some of you all who chose the right topics and therefore you all have won. And there were some who were great presenters, but the topics were a little weak. So please pardon us if we have chosen only 2 out of 6 because there are 2 prizes. But presentation itself in a forum like this is a way to go ahead. And if you are a first-year resident and if you are a passed-out resident, it still is the same. The platform is the same. So keep going, guys. This is just the beginning.
Dr. Siksha Upadhyay. Dr. Nikhil VK, congrats.
Choice of topic, relevance in current advances, application in ED, and power of presentation. So 5 heads were different. So of course, sometimes a good topic will get more score. So everyone has done good, but based upon, we have to be objective while giving the numbers. So objectively, these 2 scored more than others. That's what. Okay.
Last count. Shall we play last count 10 questions? Or no?
We still have gifts, okay? For Kahoot winners.
There is still one person who can get MCon registration sorted today. Shall we play Kahoot or no? Please log in. Log in. 2 minutes for everyone to log in.
Who is Blair? Who is Blair? I know it's the end of the session, but why are you Blair?
AD? Who is AD?
Yeah. Imposter. Somebody is an
If
imposter.
you win, I'll go to MCon free registration. Warrior is not playing. Anyone pending? Nick and Nikhil Jr. Shall we start? Shall we start? Ten seconds to answer, be fast. Right, wrong? Right, wrong? No one is discussing, arguing. I know you're tired. Yep, bleeding complications is what you are more worried about, not the right ventricular failure. Ten seconds. I think blue. Oh, I expected people to answer blue. Good. Message is sent clear. Good. Simple questions. Good. I expected those two guys or girls also to answer. So we don't reduce myocardial oxygen demand by intubating. If it was managing tachycardia, that would make sense. Option A. This was also discussed when Danny was speaking. So high PEEP is going to reduce the preload, and your drugs also have reduced the preload. So there's a high chance. Think of Danny, and Danny is here. That's you, na? Very easy questions. You just have to be fast. Simple. Three questions left. Everyday scenario. Something which the team leader needs to do. Good. Majority are answering right. Last two questions. ICD, but the cardiac one. Okay, majority are answering right. Last question of the CME. Ritesh. Okay. Second is Pritesh. Who's Dr. K? Good.
So we have come to the end of our CME. I'm really thankful for you all for staying till the last session. I will announce. Special thanks to our senior faculties, Dr. Kushrav, Dr. Sandeep, Dr. Samrat, Nitin sir and Akshay sir, of course, and Apollo Hospitals for organizing this CME. So the Kahoot winners, the last Kahoot winner is Dr. K. Please come up. And the first Kahoot winner was Krish. You are Krish. And Aditya. Congratulations. Come up on stage, please. We have the gifts for you. Thank you, everyone.
Just last one announcement. Just I would like to tell you a couple of things. First, I would like to know that we are hosting MCON, 27th National Conference on Emergency Medicine, which will be held in Mumbai in 2026, November 2026. Okay. So I want all, this conference is generally the Society for Emergency Medicine India organizes this conference every year. And Mumbai, me, Nitin, Dr. Khusrao sir, we are organizing these things. And this is going to be a very big event of emergency medicine. I think biggest emergency medicine event will be in India, because Judith Tintianelli has given provisional acceptance for invitation as a keynote speaker. So I request you that everyone, I think if you are not member, please become a member of Society for Emergency Medicine India 1 and actively participate in that conference. In whichever role you are interested, you let me know. And we want to make it a big MCon. Last time when I announced it, it was a Big Daddy MCon, so we have to make it really big. And that's it. Thank you. Okay.
Thank you, everyone. Don't forget to eat the snacks. Is anybody interested in taking a group photo? We can